caused by Pseudomonas aeruginosa, Staphylococcus, and mixed flora. Acute suppurative otitis media was the third most common ear disease in our study and accounted for 16.9% of them all. Similarly, it was also the third most common ear disease in the study done by Akinpelu and Amusa et al. The study showed that 11% of the children had chronic suppurative otitis media. It is the most common cause of persistent mild to moderate hearing impairment in children. Chronic suppurative otitis media is a major health problem in developing countries throughout the world. Conclusion: prevalence of ear disease among the pediatric population was 54%. Ear disease were common in 4 to 12 years of age group. Sex ratio is 1.2:1. Impacted wax was the most common ear disease, followed by otitis externa, acute suppurative otitis media, and chronic suppurative otitis media. References. Thank you.
What are the congenital conditions did you found in your study? Congenital ear conditions.
I didn't come across any congenital conditions.
You didn't get any congenital. Okay, tell me some cochlear congenital deformities. Whatever you know.
Sheep's dysplasias.
What is that?
Sheep's dysplasia, sir.
What is it?
Sir?
What is sheep's dysplasia?
Cochleosacral dysplasia, sir.
Okay. What is Mondini deformity? What is Michael's ablation?
Mondini's is the basal turn of
Is there any difference between urban and pediatric diseases in your study? Have you gone through that, urban and rural pediatric populations?
no, sir. We have gone through only patients reported to our OPD, sir. We didn't go across.
Okay, what is more common in rural setup, pediatric patient?
Impacted wax was the most common, sir, followed by otitis externa. In our
No, generally I'm speaking. Generally, what literature says, rural population.
otitis externa, sir.
How do you evaluate deafness in children? What is a flow chart if you have anything like that?
Sir, for neonatal screening, we use photoacoustic emissions and brainstem evocative response audiometry, sir. Following that, we can use
Is there any role of para in neonatal screening?
They should suggest all the newborns to get. They should counsel the mothers to get the child screened for hearing.
Okay. Next person.
Next, Bhanupriya, are you ready?
Sir, I'm ready.
Okay, you can start.
Yes, sir, just 1 second. Just a second. Yes, sir. Good morning, sir.
Yeah.
Myself,
Good morning.
Bhanupriya from Stanley, sir.
You start your presentation.
Yes.
Is it comparative study of pre and post or per and post?
The per and post. Per and post, sir. Intra-op and
Okay.
post-op.
Please start
Just,
presenting. Change
yes,
your
sir.
slides.
1 second. My screen was blocked, sir.
Okay,
What
then
you can
we
do
will.
is you can unshare the screen and again reshare your
Yes, sir.
screen.
Yes, sir. Sir, screen visible or not, sir?
Yeah,
Mm.
you can see your slide. Change your slides.
Yes, sir.
Yeah, please start your presentation.
Yes, sir. Good morning, sir. Yes, sir. My topic for this today case series is comparative study of per and post-operative outcomes of standalone balloon sinuplasty versus endoscopic sinus surgery. So, sir, I would like to go for introduction. This chronic rhinosinusitis is a common medical condition that has
Yeah. Juveria, please stop your screen sharing. Dr. Bhanupriya, you can start again.
yes,
Change.
sir. Yes, sir. Okay, sir. Yes, sir. I was telling that chronic rhinosinusitis is a common medical condition that affects patient quality of the life and hinders the social function significantly. So here, when we go for either FES or balloon sinuplasty, it usually helps further relieve the symptoms. So FES helps in removing of the disease and obstructive sinus tissue with the intention to restore the sinus function. And here, FES we describe as a maxillary enterostomy, ensinectomy, total ethmoidectomy, together with or without this frontal sinusotomy. Whereas balloon sinuplasty, here we are going to do only maxillary sinus dilatation, sir. So balloon sinuplasty allows a less traumatic approach by utilizing sinus dilatation to restore sinus function, as it damages less surrounding mucosa and more of mucosa preservation after this during the surgery. So balloon sinuplasty reported, according to my study analysis, to be more effective than a traditional FES. Uh, as a current investigation, we have used 1 year post-operative analysis and follow-up study, where we have done regular weekly and bi-weekly DNE and that endoclining if required. Here, we have considered specific core symptoms such as facial pain, headache, post-nasal drip, rhinorrhea, congestion with the nasal obstruction. And this above the mentioned clinical feature, we have calculated the SNOT scores for the quality post-operatively. Here, I'll go for methodology. I have like prospective randomized control trial we have done between August 21 to July 23. In this study, we have taken 75 cases which were admitted in our department with the chronic rhinosinusitis, and we have planned for the surgery. We had taken the consent, and we have divided among two groups. Group A, we had like 32 cases, and Group B, 43 cases. Group A underwent balloon sinuplasty, and Group B underwent endoscopic sinus surgery, sir. And then we have analyzed our data on the basis of uh, intraoperative blood loss, duration of the surgeries, post-operative synechial formation, post-operative maxillary sinus osteopatency, and Lund-Mackey score and SNOT-22 score. So I had taken inclusion criteria and exclusion criteria. In inclusion, I have taken patient presenting with chronic rhinosinusitis with without sinonasal polyposis, patient with maxillary sinusitis, patient age between 20 to 60 years, and patient of both genders. Exclusion, I have taken patient uh, with sinonasal polyps, patient of CRS with frontal ethmoid and sphenoid sinusitis, and dehiscence of the skull base or orbit, fungal sinusitis, and immunocompromised conditions. Here I'm showing some pictures. Patient came with this maxillary sinusitis. We have undergone balloon sinuplasty. Here I have pre-op picture of that maxillary sinus ostium, sir. 1 second, sir. And here intra balloon sinuplasty using that uh, guide wire and balloon sinuplasty instrument. Here that is during the post surgery, sir. Balloon sinuplasty, osteal opening, and I'm comparing here with the blood loss, sir. During in the right side, I'm showing the FES blood loss, and in this we have a clear field during balloon sinuplasty. And sir, here post-op follow-up, I have posted as a Sinecare picture. Post-op follow-up with first patient group B. There was a Sinecare formation, whereas in this balloon sinuplasty, field was quite clear, sir. I just posted a balloon sinuplasty instrument, sir. Using the guide wire, we use inflation balloon, and we uh, inflate and dilate the ostia, sir. Here I have mentioned the SNOT score, sir. In that we have 0 to 5, no problem, mild problem, moderate to severe, and very bad problem. In that we have a 20 score considering the sneezing, patient complaint, frustration, irritation, sad mood, and also. And Lund-Mackey score I have mentioned, where that frontal, maxillary, anterior ethmoid, posterior ethmoid, sphenoid, and osteometal complex. We see the opaque variation, so we score 0, 1, 2. Clear sinus, partial and full, complete ossified. So I'll discuss with that discussion. I'll go for that. Balloon sinuplasty is a surgical technique for dilating ostia of the sinus. Initially, excess obtained by endoscopic placement of the guide wire. Position confirmed with direct visualization of trans elimination. Sir. Balloon catheter advanced over guide wire and inflated with irrigation. And based on the factors, we found intra blood loss was comparatively less than FES, and duration of the surgery for with balloon sinuplasty was less, 20 to 25 minutes. Compared to the FES was 40 to 45 minutes, and post-operative synechial formation was more with the FES. And And conclusions, with 1 year follow-up, it has observed balloon sinuplasty is effective than endoscopic sinus surgery in treatment of chronic rhinosinusitis with maxillary sinusitis with or without frontal sinusitis who has failed medical therapy and met the inclusion criteria for surgery. Results of current investigation suggest that both BCS and traditional FES are effective treatment option for uncomplicated CRS, but BCS result in long-term elevation of core sinus symptom as well as decreased sinus-related medication use. Sir. Here are some references, sir. Thank you, sir.
You are selected only with maxillary sinus or
Yes, sir. Only maxillary sinus, sir. I've selected.
which sinuses are involved if this procedure is not indicated?
Sir, if frontal, sphenoid, and ethmoid involved, will go for a full house press rather than balloon sinuplasty.
Why?
Sir, like due to instrument wise and
Balloon sinuplasty is indicated
Yes,
when
sir,
which
we can
sinuses
do.
are involved? Only
Yes,
maxillary
sir.
sinus?
No, sir. We can
Okay.
do in sphenoid and ethmoid and frontal also, but we have
Ethmoid
chose
also?
only maxillary, sir.
Ethmoid also?
Ethmoid, sir, we won't, ethmoid also, but preferably frontal, sir.
Okay. What are the major and minor criteria to diagnose CRS, chronic rhinosinusitis? And
Sir, me.
and also what is Lund-Meche score?
The Lund-Meche score will be we have to consider maxillary sinus, anterior posterior ethmoid, osteomeatal complex, and frontal sinus. We have to see the opacification. And in that, we are going to see 0, 1, 2. 0 is no opacification, 1 is partial opacification, and uh, uh, 2 is full complete opacification. And the
Okay,
major
what is
and
the major and minor criteria?
yes, sir. Major criteria will be the nasal obstruction, nasal discharge, headache, facial swelling, and minor criteria will be heaviness of the face with the post-nasal drip, sir.
Okay.
Okay.
Okay, madam.
Next presenter, Father
Thank you,
Farzi.
sir.
Are you ready?
Yes, sir.
Please share the screen.
Yes. Good morning, sir. Sir.
Yeah, good morning.
Yes.
Uh,
I'm opening the system.
okay.
Good morning, sir. Is it visible, sir?
Yeah, it is visible. You can start.
Okay, sir. Good morning, sir. Good morning, everyone.
Good.
Today, I'm going to present about acoustic analysis of vocal parameters among female primary school teachers versus non-teaching females. It is a case control study, sir. Then, coming to introduction. The term voice is the acoustic output from the vocal tract that are characterized by dependent on the vocal fold vibratory inputs. First, the quality of voice can be assessed by audio perceptual analysis, but it is a subjective analysis. So we need an objective analysis for the acoustic analysis, which can be performed by various devices, and it can be analyzed using Pratt software. First, we have to know about the intense occupational voice use contributes to the high prevalence of voice disorders, and teachers are the particular occupational group who are more prone for this voice, prone for the voice use. Among the teacher population, these voice disorders are twice the common in females compared to male teachers. Then the objective of this study is the study aims to analyze the acoustic parameter and estimate the presence of voice disorders among female primary school teachers in comparing with females who are in other professions. Then the methodology is an analytical case control study. The total study population is 40, in which 20 are cases who are female primary school teachers and 20 are non-teaching females. Now, inclusion criteria. We take cases of the school teachers who are between ages of 22 and 50, minimum 2 years and more experience taken for cases. For controls, females who are age matched with cases, but the controls should not have any history of voice abuse or voice change, and they should be in profession other than teaching. Exclusion criteria, same. The population below age of 22 and above age of 50 are excluded from our study, and the patients with history suggestive of laryngopharyngeal reflux, gastroesophageal reflux disease, chronic sinusitis, allergic rhinitis, and postnasal drip are excluded from our study. Then the protocol is patients are chosen according to the inclusion and exclusion criteria, and the procedure is explained in detail. After obtaining informed oral consent, first I'll collect the demographic data of the patient, and then the work environmental characteristics and clinical background information and personal history is collected. Then a modified voice handicap index 10 questionnaire is filled from all the patient. Then the voice recorded. A voice is recorded using a digital voice recorder in a relatively silent atmosphere, which was then subjected to analysis in Pratt software. The voice is recorded using the page. The subjects were asked to pronounce vowels A, I, and U for and sustain the vowels for 5 seconds. Then asked to read a common passage. Mid 3-second range from each vowel is taken for analysis. From this analysis, we get fundamental frequency, jitter, shimmer, harmonics to noise ratio, and intensity of the patients were all documented and subjected to statistical analysis. Then this is my proforma. In this, the demographic data of patient is collected and work environmental characteristics such as how much years of working experience and how much day they will take classes and noise in the class. And other clinical conditions like heartburns, regurgitation, postnasal drip, any chronic cough, these are used to exclude any past medical history of the patients, and personal history like the smoking and alcohol use is obtained from the patient. Then this is voice handicap index questionnaire, which is useful in preliminarily assessing the how patient perceive their voice is. Then coming to the results, the mean age of my study was, for cases it was around 27.4 plus or minus 3.7 years, and in controls were 28.5 plus or minus 2.4 years. And while taking the subject taught by teachers in my study, the teachers are mostly more number of teachers in maths subject, and they are more prone for this voice disorders as they use their voice more. Then while coming to distribution of acoustic parameters between the cases and controls, comparing it, while coming to jitter in vowel, when we see vowel I and U, it's significantly elevated compared to control population. And shimmer in vowel, all three vowels A and U, it's significantly elevated compared to controls, and harmonics noise ratio is decreased than the control population in cases. And also I studied work experience among those teachers less than 5 years and more than 5 years. While studying it more than 5 years in vowels I and U, jitter and shimmer are significantly elevated than the control population. Harmonics noise ratio is decreased than the control population. Then while filling the voice handicap index, comparing to controls, cases have perceive they have voice issues, and as VHA scores mean is more in cases, significantly more in cases compared to the controls. Acoustic analysis is a very useful tool in assessing the voice quality and evaluating the effectiveness in voice therapy. Butler et al. Found that female subjects have relatively less amount of hyaluronic acid in first superficial layer of the vocal cords, but more hyaluronic acid in deeper vocal cords. This less hyaluronic acid may have less protection from the vibratory trauma, so that the females will be having more phonotraumatic issues compared to the males. And Lochner et al. Proposed that increase in jitter and shimmer correlate with the fatigue of the throat in the healthy population. And also, Veterate et al. Reported that decrease of the HNR in a female teacher after day work is reported. In our study, it is noted that perturbation acoustic parameters such as jitter and shimmer showed a significant increase compared to non-teaching population. HNR and HNR measure for the female teacher population were significantly lower than for the corresponding control group. Lisa et al. Stated that speaking loudly alone doesn't result in voice disorders, but other factors such as speaking continuously, inadequate voice rest, and speaking against background noise all leads to the voice disorders. Concluding it, in our study, it is concluded that female teachers had greater risk for voice disorders in comparison to normal, healthy females who were in other professions. We have to implement various measures like voice training, use of a microphone during teaching in the class, voice rest, and adequate breaks in between the class should be counseled to teachers through proper health education. Teachers should approach clinicians when they experience any difficulties like in change of voice, and this will help in preventing the further worsening of the voice among the teacher population and improve the quality of life. These are my references. Thank you, sir.
What are the parameters included in GRBS?
Sir?
What are the parameters which are included in GRBA scale?
Sir, breathiness, roughness, hoarseness of voice, sir.
And
Okay, what are the other conditions where this voice analysis can be utilized?
Sir, it can be used for any, if there is a Rinke's edema, vocal pathology, sir, vocal nodules.
What is presbyophonia? Is it useful in that condition?
So presbyophonia is like change in voice which associated with old age, sir. Voice, any change in the voice can be detected using this acoustic analysis, sir. Using
Similarly,
this
can it
data.
be used in malignancy of larynx?
So growth of it's mostly useful for the vocal cord vibratory trauma, sir.
Okay, right.
What is the cause for change in jitter and shimmer values?
Sir, jitter changes due to the lack of control of vibration in the vocal fold, sir.
And
Shimmer is due to the any reduction of the glottal resistance, sir.
okay, next.
Thank you, sir.
Next presenter.
Hello, Dr. Tanya.
Yes, sir, I'm ready, sir.
Okay, you can share your screen.
Yes, sir. Sir, is my presentation seen, sir?
Yeah, it is visible.
Okay, I'll start, sir. So, good morning, everyone. My topic is comparison of clinical vestibular evaluation and video head impulse test in detecting semicircular canal dysfunction. So, video head impulse test is a documentation of critical bed impulse test, which was introduced by Harmagi and Curtois in 1988. So what we see in head impulse test or VHIT is vestibulo-ocular reflex. Vestibulo-ocular reflex is an important mechanism that helps in gaze stabilization. It stabilizes the images in the fovea. So when the visual target is moving but the head is steady, or when our head moves and the visual target is steady, or when both our head and visual target is steady, it helps in gaze stabilization. So if you want to get perfect gaze stabilization, the speed of the eye which moves and should be equal to the head or the visual target that moves. And sometimes due to any vestibular effects, the VOR will be less than 100%. And that's when to focus on the target, our eye movement will have jerks, which is called catch-up saccades. And this eyes movements will become abnormal. So VHIT was helps in sharpening the diagnostic efficacy of head impulse test and record the VAR gain if it is done properly. So the aim of my study was to compare the efficacy of the vestibular evaluation and visual head impulse test, and to prove that the video head impulse test is a specific test to identify which semicircular canal is affected, and to evaluate the sensitivity of the video head impulse test for identifying the semicircular canal dysfunction. And I did my study from May 2024 to July 2024 and included 25 people. All people who came with features of vertigo were included in my study. And I excluded people who had taken anti-labyrinthine drugs within 1 week, or who had active giddiness and who we could not do the vestibular evaluation, and who had restricted neck mobility, or who had congenital nystagmus, mostly towards the right, because the sensor of the goggles was in the right side. And after getting permission from the patients and getting proper history and doing vestibular evaluation, video head impulse test was done. And how we did it was, we made this patient sit 1 meter away from the wall with a brightly colored sticker towards the wall. And we had calibrated the eye movements, and 10 head impulses were made, and 7 correctly done head impulses were calculated based on the head impulses and the area be above under the desaccated eye velocity curve and above the area under the curve, the VOR gain was evaluated. So VOR gain less than 0.7 was pathological. And in my study, most of the patients we had observed was in the age group 30 to 39, and mostly were male, 60% were male. And most, of course, all of the patients had giddiness, followed by ear discharge, which was about 20%, and tinnitus and hard of hearing. And in 5 patients that had central perforation, 1 patient had normal VHIT, while 4 had abnormal canal paralysis. And in 7 patients that had negative vestibular evaluation, we had a positive correlation of 28%. And in all patients that had positive with vestibular evaluation, there was a positive correlation of 72%. So conclusion, if vestibular evaluation is done properly by trained hands, it can yield proper results. And VHIT is a very good test that records and gives proper video evaluation of the head impulse test. And it in most of the cases that if there was nystagmus to one side, the VHIT showed more than one canal being affected. And also, when there was no negative vestibular evaluation, it did show that there was a positive finding. So VHIT should be used in tandem with vestibular evaluation. And patients who have vertigo, it is a debilitating diseases, they should be given anti-labyrinthine drugs and taught vestibular exercises and lifestyle changes and restricted neck mobility. Thank you, sir. These are my references. Thank you, sir.
What is the sensitivity of this specificity sensitivity?
Sir, in sensitivity was 92%, sir, and specificity was around 56% based on this study. But what we noticed was, even though there was, even when we did the maneuvers, even if there was one side nystagmus or unilateral vestibulopathy, the VHIT showed a positive response in canals that we did not expect. So if there was a posterior canal involvement that we found during the vestibular evaluation, when we did VHIT, we saw that anterior also was involved, or all three canals, or opposite side here was also involved, sir.
Is there any role of VHIT in low frequency saccades? What is the test you would like to do in low frequency vestibular access?
Sorry, sir. Test to do in low frequency saccades, sir. We dynamic visual acuity, sir.
Okay, no problem. Next candidate.
Dr. Kirtana,
Yes, sir.
please share your screen.
Yes, sir. Yes, sir. So, good morning, sir. Just a minute, sir. So, just a minute, sir. Uploading, sir.
Okay.
Sir, you are able to see, sir?
Yes, yes. You can start.
Good morning, sir. My case series is about hospital-based study on house dust mite sensitization among asymptomatic Chennai residents, sir. So, coming to the introduction, allergic disease are emerging as one of the major health concerns in our society, and incidence was found to be 25% of Indian population is sensitized to diverse allergens. And the main clinical spectrum of allergic disorders, which includes conjunctivitis, urticaria, eczema, anaphylaxis, allergic rhinitis, and bronchial asthma. So among the 13 house dust mites, the most commonly encountered house dust mites are Dermatophagoides farinae, Dermatophagus terronicinus, and Blomia tropicalis. So 75% of the populations are sensitized to atopic dermatitis, whereas 63% were sensitized to allergic rhinitis, and 72.5% were sensitized to bronchial asthma. This secondary to dust mites. The main objective of my study is to estimate the rate of sensitization to house dust mite among asymptomatic Chennai residents. And my study is analytical cross-sectional study, and all patients and the study population includes the all attendants and patients, volunteers attending in our hospital without any clinical manifestations of allergy. The calculated sample size is 119 and the study sample size is 132. The main inclusion criteria is all the individuals above 18 years of age without any symptoms of allergic disorders and persons who volunteered to undergo skin prick test for detecting house dust mite allergy. And the exclusion criteria is patient who had taken antihistaminics in the last 5 days and patient who had history suggestive of allergic disorders, as I told you before. The patient with past history of any acute anaphylactic reaction. So I have taken the informed and written consent from the patient who are willing to go for a skin prick test. So the questionnaire was given to the all the volunteers or healthy patients so that they can fill the demographic data, socioeconomic profile, and clinical background. So then I performed a skin prick test. So as a result, after 20 minutes of the skin prick test, the response to the individual allergen was compared with that to the control saline and histamine. The wheel of more than 3 mm with the surrounding flare, equal to or more than 3 mm with surrounding flare, was considered as a positive response in SPT for a particular species of house dust mite. So all the participants were monitored for any adverse reactions in the form of dizziness, generalized itching, vomiting, wheezing, tachycardia, hypotension, and altered sensum. And in this picture, there is in this patient, there's a positive response for all the 3 house dust mite, for Farinae, Pteronismus, and Blomia tropicalis. So results. The study was conducted among 132 volunteers without any manifestations of allergy, and mean age with standard deviation is 26.18 plus or minus 6.88. And the age distribution in female is 46.97% and in male 53.03%. So in this chart, I want to tell you that D. farinae, that is 57.5%, is more prevalent than compared to other species, whereas D. terronicinus is 28.28%, and in Blomia tropicalis, it is found to be 9.09%. About 63.6% population were sensitized to at least one of the 3 house dust mite, and 43% is sensitized to 2 house dust mites, and 4.54% were sensitized to all the 3. So, in my results, an individual possessing soft toys in their home were more frequently sensitized to dust mite than their counterparts. In this chart, that blue color represents the persons who are having the soft toys, who own the soft toys, were more sensitized compared to that of those who are not owning the soft toys. Individuals from better socioeconomic background were more frequently sensitized to house dust mite than their counterparts. So we have taken the mean average of 37,500. So persons who are better socioeconomic status were found to be more sensitized compared to the low socioeconomic status people. So in discussion, house dust mites are arthropods belonging to the suborder Astigmata and family Pyroglyphidae. Of the 13 identified species of dust mites, D. farinae and D. pteronomus has been found worldwide, and Blomia tropicalis is prevalent in tropical dwellings. So as per the Carl Christian Bergman study, it also found to be 15.9% of the German population were sensitized to be house dust mite. But regarding the literature, Indian articles providing the data regarding sensitization to house dust mite among asymptomatic general population are lacking. Most of them have studied the rate of sensitization to house dust mite only among patients with allergic manifestation. So in Debrati articles regarding review of house dust mite allergy in India, the sensitization of Indians in house dust mite varied between 12% in Delhi, 44.65% in Bangalore, and 88% in Calcutta. So as per our study, it was found to be 63.6% of asymptomatic Chennai were sensitized to HDM, and sensitization to D. farinae was more common than to D. pteronomus. As per our study results, higher rates of sensitization to HDM was observed in socioeconomically better individuals. And this observation could be attributed to hygiene hypothesis, according to which lack of exposure to more diverse environmental microbe in early life may prevent proper tuning of the immune system and predispose to the development of allergic disorders. So coming to the conclusion, sensitization to house dust mite is quite common among asymptomatic Chennai residents. Keeping articles like soft toys that attract house dust mite should better be avoided in households. Health education of asymptomatic sensitized individual regarding strategies for household maintenance as suggested by WHO may prevent the development of atopic disorders in them by reducing their allergen exposure. and some of the measures for household maintenance to reduce house dust mite population. And these are my references. Thank you, sir.
What is the role of immunotherapy in these sort of allergic manifestations?
Yes, sir. After we are doing the skin prick test, I have done this test for only for dust mites, but usually there will be more than 75 allergens will be doing the skin prick test, and immunotherapy is also being done in the form of serum. So the persons who are more allergic to that, that is, I have already told you, the wheel of more than 3 mm is considered positive. And first we have to check to which allergen the patient is more sensitized. Then we have to start, patient is willing, we have to start immunotherapy, which includes a vial, so that we can, in immunotherapy, it was taken around for a duration of almost 1 to 2 years. So it's a very long duration course. In this, we'll be administering the antibodies to the patient so that they become more sensitized to that. So by later by screening the patient of 6 months, 3 months, 6 months, we can able to reduce this allergic disorder, sir, compared to the medication and steroids we are using.
Okay, what precautions would you like to take while providing immunotherapy to the patient?
Sir? So we have to look for any allergic reactions or any. First time we have to administer it in our hospitals, sir, because if the patient was, we have to check for any reactions they are going, like such as anaphylaxis or giddiness. We have to watch for that, sir.
Okay.
Dr. Usha?
Yes, sir, I'm there, sir.
Okay.
Thank you, sir.
Okay,
Sir, is it seen, sir? Is it visible, sir?
yes.
Yeah, it is visible.
Good morning, everyone. The topic or the title for today's presentation is correlation between the reflex symptom index and reflex finding score in patients with laryngopharyngeal. Starting with the introduction, laryngopharyngeal reflex disease is a growing epidemic, especially affecting the younger generation due to lifestyle and stress factors, accounting for 10 to 30% of patients consulting ENT specialists. This led to further studies. Further studies have reported an association between
என்ன
LPRD
பண்றது எப்படி இருந்தது நிஜமா சொல்ல
such as muscle tension dysphonia.
கேட்டாங்க டைம் இல்லையா
LPRD is also considered a risk factor for laryngeal swamps as well as adenocarcinoma of esophagus.
அப்படியே கேட்ட ரெண்டு கேள்விக்கு நான் ஒழுங்கா பதில் சொல்ல
All others, please mute your mic.
நிஜமா சொல்லுங்க அது
Due to lack of gold standard diagnostic methods and testing methods with lack of sensitivity and specificity, further results is diagnostic dilemma. It is often difficult to diagnose LPRD because the patient presents with vague symptoms, something like postnasal drip or a pricking sensation in throat or unresolving sore throat, which further leads to unwanted treatment like repeated course of antibiotics and also surgical treatment, like patient might undergo tonsillectomies. So therefore, to overcome this, two scoring systems, that is reflex symptom index
Your
and 9 and
PPT is not being shared, madam.
Your slides are not. Make it full screen. Make it full screen.
sir, it is showing as full screen, sir.
Okay, go ahead.
We started a study with the aim to find out the relationship between a reflex symptom index and reflex finding score in patients with suspected laryngopharyngeal reflex disease. We set out objectives. Those were to identify the symptoms of laryngeal LPRD through the reflex index score, and to identify the signs of LPRD through reflex finding score, and to clinically evaluate the correlation between the reflex symptom index and reflex finding score in these patients. Methodology: in this study, we included 85 patients attending our ENT OPD. The study design was a cross-sectional study. Inclusion criteria was we included all the patients above the age of 18 years presenting with LPRD. Exclusion criteria: we excluded patients with chronic debilitating disorders, chronic NSAIDs users, and patients who have already received treatment for LPRD. A procedure: those patients who fulfilled the inclusion and exclusion criteria were first evaluated for symptoms using the RSI. Patients were evaluated. RSI is a nine self-assessment questions that are graded from 0 to 5, 45 being the highest, according to severity, and those who were having a score of 13 were considered as LPRD, and they were subjected to endoscopic evaluation. This is reflex symptom index, which was developed by Belaski. The components are hoarseness or change in voice, excessive throat clearing, excess throat mucus or postnasal drip, difficulty in swallowing, cough on lying down or cough after eating, choking episodes, troublesome or annoying cough, sensation of something stuck in the throat or a globus sensation, heartburn and sense of indigestion. The scoring system was given from 0 to 5, 0 being no problem, 5 being severe problem. These questionnaires were translated in local language and it was evaluated to the patients. Next is reflex finding score. Again, it was developed by Belaski. It is an 8-item score which includes the signs that are seen on laryngoscopic examination, including subglottic edema, ventricular obliteration, erythema, vocal fold edema, generalized laryngeal edema, posterior commissure hypertrophy, granuloma, and excess mucus in larynx. This was done by another examiner to avoid observer bias. Each item is scored based on the severity, location, and presence or absence of the sign. This is a component of reflex finding score. The severity grading is self-explanatory. So there are certain parameters which needs a little explanation, like ventricular obliteration. It is graded as partial and complete. Partial is when there is false chord and true vocal cord edema, which is when the ventricular space is partially obliterated. Complete obliteration is given a point of 4. In vocal fold edema, it is characterized as mild, moderate, severe, and polypoidal. Posterior commissure hypertrophy, again graded as mild when there is a mustache-like appearance of the posterior commissure area. A moderate when there is a straight line creating in the end of the in the posterior aspect of the larynx. Severe when there is bulging of the posterior commissure into the airway, and the last score is grade 4 for obstructing. Coming on to the results, the most frequently reported symptom according to a study was excess throat clearing, heartburn, and globus sensation. The least reported symptom in our study was choking episodes. The RSI ranged from 13 to 30, 13 being minimum and 30 being maximum, with a mean of 17.4 and median of 15 and standard deviation of 4.7. Most of the patients fell in the range between 13 to 17 and 18 to 22, that is mild to moderate symptoms. This is the bar chart depicting the symptoms. The most common symptoms was excess throat clearing, heartburn, and globus sensation. More than 95% of our patients presented these symptoms. The least common symptom was difficulty in breathing or choking episode. The other bar diagram shows the severity grading. That is green color showing severity of 5, blue showing 4 and 3. Most of the patients had this light grade 4 or grade 3 in severity. Next, reflex finding score was assessed. Based on RFS assessment in our study, most common sign was erythema. Almost 100 patients of our patients had erythema, followed by posterior commissure hypertrophy seen in 95%, diffuse laryngeal edema. None of the patients exhibited subglottic edema, and 2 patients had granuloma. So RFS score ranged from 7 to 17, 7 being least and 17 the highest, with a mean of 9.6, median of 9, and minimum a standard deviation of 2.6. Most of the patients fell in the range between 7 to 11, like 66%, and next is 12 to 16. So as we can see in the bar diagram, erythema and posterior commissure hypertrophy followed by diffuse laryngeal edema. Most of the patients had mild, moderate, and severe forms of these symptoms, these signs. Then correlation of RSI and RFS symptoms in the study population was carried out using Pearson's correlation test. In this study, there was significant positive correlation between RSI and RFS scores with R value, that is coefficient value of 0.6 and P value of less than 0.01. Apart from this, there was significant clinical correlation as well. The patient who presented with foreign body sensation in throat had most or persistently all the patients had posterior commissure hypertrophy. Patients presenting with change in voice had vocal fold edema, and patient having excess throat clearing had posterior commissure hypertrophy. These are some of the pictures. The first picture is laryngeal hyperemia. all the grading of posterior commissure hypertrophy. This is grade 1, grade 2, and grade 3. This is laryngeal edema confined to the interarytenoid region. This is diffuse laryngeal edema. A conclusion, the following conclusions were drawn in our study. Excess throat clearing, heartburn, and globus sensation were commonly reported symptoms. Erythema, posterior commissure hypertrophy, and diffuse laryngeal edema were the signs. There is significant positive correlation between RSA and RFS. Take-home messages, RSA questionnaire and RFS assessment with an endoscope are simple, economical, and minimally invasive and objective measures of LPRD assessment should be implemented in routine screening measures for the diagnosis of LPRD in ENT outpatient clinic. These are the references.
Okay. What are the other ENT manifestations can be seen because of this LP or the laryngopharyngeal reflex disease?
Sir, like the signs that are seen, sir?
Yeah.
Or symptoms?
Symptoms.
Okay, symptoms like yes, sir. Most commonly, they come with the foreign body sensation or a pricking sensation in throat, or sense of reflex, acid reflex, or change in voice. Then sore throats are unresolving. Even after taking antibiotics or other measures, there will be unresolving sore throat.
Yeah. Globus sensation. You were talking about globus sensation. Before labeling them globus sensation, what are the other points, other factors should be ruled out apart from your LPRD?
Sir, we should do routine assessments, sir, to rule out other pharyngeal causes of globus sensation, sir. Other causes should be ruled out, sir. Sir, Zenker's diverticulum. Other laryngeal causes.
What is Zenker's diverticulum?
So it is outpouching from the defect in the cricopharyngeal muscle, sir. Pharyngeal mucosa is outpouched.
Okay. We have to rule out osteophytes of the vertebrae. That is.
Next present, Dr. Jayaprada.
Yes, sir.
Okay. Please share your screen.
Yes, sir. Yes, sir. Good morning, respected judges and presenters. My topic today is analysis of
slideshow button, madam, because it is not visible. It is visible with small letters. We can't see exactly.
Yes, sir. Is it visible, sir?
Yes.
Yeah, better.
Yes, sir. Yes, sir. My topic is the analysis of nasal crest in post-operative nasal surgery patient using Fourier transform infrared spectroscopy. Yes. This is an entirely new study with post-operative nasal crest sample is taken from after nasal surgery. Only 1 week sample is taken so far. After post surgery, only up to 1 week nasal crest sample is taken and run in biochemistry department. This is a device which is present in our college. A schematic diagram of FTIR spectrometer is shown in the image. First, infrared source is transmitted from the source, and there will be a beam splitter. It will split the infrared into a fixed mirror and to a moving beam mirror. So it will split back into a beam splitter, and it project into a sample, and there will be a detector. It will detect from the from the sample, and it is a completely computerized mathematical calculation, and we'll get a reports. This is the first one I show. There is a rounded thing is there where will keep the sample. In the second photo, it is showing like it is a inbuilt computer software. If we ask to process the sample, it will process the sample, and there will be a, this is the result we'll be getting. There will be a peaks and troughs in the sample, and the reference value is given in the slide. Like for example, if 2009-24 peak is there, it means we are our sample is having simple alkanes. Like that, we have to analyze the sample. Methodology: sample preparation. Obtain a sample. Samples should be sterile. We should not put in like saline or formalin solution. Just like that, in a sterile container without any contaminants, we have to give the sample. And FTIR instrument setup, it is calibrated properly and set up for analysis. Check the baseline and optimize the instrument parameter for best spectral resolution. Data collection: place the prepared nasal crust sample on the sample holder of a FTIR instrument. Collect the infrared spectrum by scanning the sample in the infrared range. Allow multiple scan to improve signal to noise ratio. Data analysis: when the spectrum is analyzed, the peaks and troughs in the spectrum will be visualized. Then we can compare the peaks and troughs with the database available with us. Then interpretation: interpret the FTIR spectrum to extract information about the molecular structure and composition of nasal crust sample. A similar molecular structure like N2 and O2, the one which are having similar structure, we cannot differentiate in this FTIR study. Totally 15 samples are collected. All samples are run in Department of Biochemistry, approved by FDA. Patient selection inclusion criteria: all patients who underwent nasal surgeries, those who are all willing, irrespective of sex, comorbs, post-op drugs are taken into consideration. Age group is 20 to 60 years. Exclusion criteria: patient who are not willing and those who are on steroids spray post or pre-surgery, and age group less than 20 years and more than 60 years are excluded. We classified according to the etiology and surgeries we performed. We classified the nasal crust sample into surgeries from inflammatory etiology, surgery from non-inflammatory etiology. Like surgery from inflammatory etiology are FES with and without polyposis, or all terminal blastocysts. Those who have allergic etiology, or we put under etiology, and those who are non-inflammatory etiology, or those who have septal correction, deviated nasal septum, and those who have septal correction, those who underwent septorhinoplasty. Totally 15 samples are collected. 9 is from inflammatory etiology, 6 from non-inflammatory etiology. Only 1 week sample we have done so far. Not 2 weeks, 3rd week crust are on in process. Totally, we got a spectrum band. We divided into 2 things for inflammatory and non-inflammatory etiology. We got a common peaks like 3469 to 3486, 3274 to 3286. These are alkane group, alkene, and collagen groups are present in these common peaks. Like inflammatory and non-inflammatory both contain alkane, and collagen. Specifically in inflammatory etiology, we had like 1080 to 1085 peaks, which is a very peculiar peak seen here. Almost like 1600. First one shows a inflammatory etiology, second one shows a non-inflammatory etiology. In inflammatory etiology, we had common peaks like 1684, around 1684, 1051, and around 1041, 1042, around similar peaks are there. Only one different peak is 1085, which is seen only in inflammatory etiology. In non-inflammatory post-nasal crust, we cannot see that 1085 crust. So in conclusion, we found that 1080 to 85 peaks are only present in patients who underwent surgery for inflammatory diseases, and common peaks are seen both in inflammatory and non-inflammatory diseases. So far, the study is under process. We are going to see on 2nd big crust, and third week post-surgery nasal crust. So far, we have concluded that 1080 to 1085 can be taken as an inflammatory marker. Okay, this is the only reference we have seen. So far, no articles in there related to FTIR spectroscopy with the nasal crust, post-surgery nasal crust. This is the only reference we got. It's from evaluation of inflammatory process by FTIR spectroscopy journal. Here they have given, in the journal, it was given like 1080, we can take it as an inflammatory marker. 1080 spectrum is present. The sample contain nucleic acid and collagen. So, thank you, sir.
Okay, what are the various other applications of this FTIR?
Yes, sir, we can use for both solid and liquid. Any sample can be given processed through FTIR, sir. Like cholesteatoma samples is also in process in our biochemistry department, sir, in our college. And other than this, all abdominal renal stones and cholesterol, all cholesterol stones, they are doing for all samples. In fact, in future, we are also planning like malignant cancer, like in CA, larynx and all, we can give the sample to biochemistry to see any other markers, extra spectrum is there, and post CCRT, we can again take a tissue from site and we can compare the things like any spectrum is present pre-operatively and post CCRT and post CCRT also. We can compare and see any new spectrum is present or not, like that we can see, sir. And one more thing is third and second week and third week samples also we are planning to analyze, sir. We have to see whether this inflammatory spectrum which is present, like 1080 to 1085, which is present, whether we have to see when it will still exist in second sample and third sample, sir. It is in process, sir.
In what way this FTIR modifies the management of nasal crust?
Maybe in future for nasal drops preparation, because we have found like inflammatory thing is there for patients who have chronic rhinosinusitis. For treatment side, maybe in future we can expect some changes for nasal drops preparation and also. Because now only we have started this study, sir. It is in process, sir.
Okay, what is ideal beam splitter?
Sir, ideal?
Beam splitter. Okay, what are the three advantages of FTIR? Like
Yes, sir, it is simple, easy to measure, sir. It is simple, easy to measure.
no. I am asking about this Pelaget's advantage. Likewise, the other two advantages are there. No. What are those?
We can find the content which is present inside. Like we can use it as a marker.
Okay.
Yes,
Nice.
sir.
Dr. Asma,
Thank you, sir.
Dr. Asma, Dr. Asma, are you there? Dr. Asma Begum, are you there?
If she is not there, we'll proceed with next.
Oh, okay, sir. Next, Suresh. Dr. Suresh.
Yes, sir. So just a minute, I'm just sharing the file.
Okay.
Sir, can you see my screen?
Not it.
Just a minute. So is it okay if I go as a next candidate, sir?
Yeah, yeah. So next candidate, Dr. Subbu.
Dr. Subbu. Dr. Subbu, are you ready?
Yes, sir. Yes, sir. I'm ready, sir.
Yeah, please share your.
What about 37?
37 shall present at the end, sir. Again, due to technical
Okay.
issue. Ask her to present at the end.
So is my presentation visible, sir?
No, ma. No, madam.
Jemima, you can join later. Let Subbu, Dr. Subbu continue.
So is it visible now, sir?
Dr. Jemima, you can present later.
Just log out from this link. Dr. Subbu, please share your screen.
Yes, I'm sharing it, sir. Is it visible, sir?
Right now, you can unmute and again reshare that.
Now, sir, is it visible?
Yeah, you can just change the next slide. It is blank actually.
Is it visible, sir, now?
No, ma'am.
Showing here, sir. Can I get back later, sir? Thank you, sir.
Dr. Indira?
Sir.
Dr. Indira?
Yes, sir.
You can go ahead.
Other candidates who are not presenting, please log out from the link and you can watch in the YouTube. Too many logins will congest the viewing of.
Sir, is my screen visible, sir?
Yeah. Yes, madam.
Yeah, Dr. Indira, please continue.
Yes, sir. Honorable judges, Respected senior members of the ENT fraternity, my dear colleagues and friends, good morning one and all. I am here to present a very interesting topic on 3D virtual reality rehabilitation therapy for peripheral vertigo with anxiety disorders. So is my slide changing, sir?
No.
Is it visible now, sir?
Yes.
Yeah,
Yes.
yeah.
Tracing to its etymology, vertigo comes from a Latin word where verter means to turn and ego is a condition. It is a condition of turning about. The first citation of vertigo was given way back in 1528,
Please click on.
which make it a
Please
man.
click. Please click on the slide sharing button so that it will become bigger.
Yes, sir. Now, sir?
Yes.
Yes, sir. The first citation of vertigo was given way back in 1528, which maketh a man to ween that the world turneth.
Switch on the timer.
Life is all about balance, and the human equilibrium is a complex sensory psychomotor function. There are various treatment approaches for vertigo, like reassurance, pharmacotherapy, vestibular rehabilitation exercises. Cawthon was an English otorhinolaryngologist who found out that rapid head movements brought about balance, and Cooksey developed a regimen of exercises which is being put into wide practice. Rarely, the patient might even require surgery. Out of all the recent advances, the 3D virtual reality tops the place. It is a blend of science and technology with medicine. This special electronic equipment, Oculus Rift and HTC Vive, keeps the patient immersed in a simulated world through various channels such as vision, hearing, and touch by giving a real-life experience. This cutting-edge technology fosters a new era of adaptation, habituation, and rehabilitation non-invasively and effortlessly. After an extensive review of literature, I could not find much of work on this topic. As a postgraduate, despite all the challenges in front of me, I was extremely happy and content that I was able to do the study end to end. My study aims to evaluate the benefit of 3D virtual reality vestibular synergetic rehabilitation in patients with peripheral vertigo along with anxiety disorders. Patients with unilateral peripheral vestibular dysfunction confirmed by video nystagmography along with anxiety symptoms were included in my study, and those with coexisting neurological diseases were excluded. My subjects were 30 patients divided into two groups. Group 1 is the study group, where the patients underwent extended 3D virtual reality therapy along with conventional Cawthon-Cooksey exercises in a series of 2 sessions per week for 3 weeks. It was given in a highly customized VR lab. The stimulus that was given are the elevator environment, walking on a plank, looking down from the terrace, the roller coaster effect, and a bus simulator. Group 2 is the control group, where the patients underwent only conventional therapy. These were my assessment scales: the vertigo symptom scale short form for vertigo, the Hamilton anxiety rating scale A for anxiety. Coming to the results, the age and the sex distribution are shown as follows. The vertigo symptoms in group 1 patients decreased drastically as shown by the blue line when compared to the group 2 patients as depicted by the orange line. The p-value became significant. Similarly, the anxiety levels also decreased in group 1 patients when compared to the group 2, and again the p-value became significant. Therefore, the 3D virtual reality rehabilitation along with the conventional exercises significantly help in synergetically reducing the vestibular as well as the psychological component of the imbalance. Therefore, the conscious imbalance and anxiety was addressed efficiently by this revolutionary method of stimulus. Overall, the patient satisfaction, day-to-day performance, and stability was improved. Coming to the discussion. Balance is a holistic function of brain which involves both the cognitive and the limbic system. So a balance disorder patient is not just a spinning individual. It also has a lot of cognitive, emotional, and psychological problems. The central nervous system collects information from the ground using various sensors. It integrates all the inputs in the brain and produces precise coordinated contractions of specified muscles. This forms the basis for 3D virtual reality. If one of the sensory input to the brain is defective, for example, the vestibular input to the brain is defective, the other two inputs are strengthened. The repetitive movements of images on the retina produced by the VR devices induce a vestibular response adaptation and cause an increase in the gain of reflexes. Also, it helps to desensitize the patient by repeated exposure and re-exposure therapy and thereby reducing anxiety. On a similar note, however, all the patients who underwent 3D virtual reality therapy showed amazing results. We had a certain interesting group of patients who showed drastic superb results in the first 2 sitting itself. They belong to the category persistent postural perceptual dizziness. In this group of patients, the symptoms are exacerbated by a moving visual stimulus or a change in posture. Also, there must be a definite predisposing factor like a vestibular syndrome associated with a psychological component like a pre-existing anxiety disorders. Both of these separate entities are well addressed by the 3D virtual reality therapy, which led to those amazing results. The core areas of how the 3D virtual reality works is by habituation exercises, increase in vestibulo-ocular reflex gain and gaze stabilization, postural control, and thereby improving the patient general state. Hereby, I conclude that the tool of 3D virtual reality can be used effectively to address the consciousness of disequilibrium and anxiety. This innovative approach will unlock new possibilities to transform lives and to redefine the boundaries of vestibular rehabilitation. These are my references. Thank you.
Any
Who are
disadvantages of this rehabilitation 3D?
Yes, sir. Initially, when the patients are exposed to the therapy, the symptoms are kind of exacerbated. So sometimes the patient will feel more dizzy. Like we saw that 1 or 2 patients experiencing symptoms in the first 2 sittings, and later they tend to get rehabilitated.
What is the cost of the setup?
Sir, it was done in our college, and also we had an tie-up with an institute IT setup, sir. So we went there and did, sir.
Whatever it is, what is the cost?
It was around like some 3 lakhs, sir.
Who are the candidates to undergo this 3D reality rehabilitation therapy? How do you select?
Sir, we selected the patients who had a peripheral vestibular dysfunction. So those who are having any central nervous system pathology was excluded from our disease.
Which is more
Well,
common, central or peripheral?
Peripheral is more common, sir.
How do you differentiate central from peripheral vertigo? And what is that Alexander law?
Sir, by nystagmus we can identify, sir, whether it is central or a peripheral vertigo. Like in a central vertigo, there is no latency period. Also, if the nystagmus is towards the opposite side, then it is mostly due to a peripheral lesion. And any hearing pathology, or if there is no central nervous symptoms or any previous head injury is there, then we tend to go towards peripheral pathology, sir.
Okay, what is Alexander law? Okay, Indira, no problem. Your very nice presentation.
Thank you, sir.
Next, Dr. Soundarya.
Sharing my screen, sir.
Okay.
Share screen. Sir, is my screen visible, sir?
Yes. You can enlarge it. Make it full screen.
You can start.
Yeah, good morning to all the judges. I'm going to present a topic on rare sarcomas in ENT. So, introduction. Head and neck sarcomas are rare tumors accounting for 1% of all head and neck malignancies and 5% of all sarcomas. These are malignant solid tumors arising from mesenchymal tissues or any soft tissues or osseous tissues, regardless of age and sex. Owing to its low incidence and its complex nature in head and neck region, treatment comprises of multidisciplinary approach. The main aim and objective of my study is to discuss the clinical presentation, diagnostic and mode of treatment in patients diagnosed with sarcoma to improve their survival outcomes. So now moving on to the cases. Case 1. A 7-year-old male child came to the hospital with the complaints of right nasal obstruction and right nasal discharge for 2 months and right eye swelling for 1 month, and his swelling was insidious in onset and progressing in size, which is associated with visual disturbances. There was no other significant ENT complaints noted. On examination of nose, external nasal contour was altered. On anti-rhinoscopy, the septum was found to be deviated to left, and a reddish mass visualized in right nasal cavity with secretions associated with foul-smelling discharge. Rest of the nasal cavity could not be visualized, and the left nasal cavity is narrower compared to right. On examination of eyes, swelling of size approximately 7 cross 5 centimeters seen over the medial aspect of right eye, extending to roof laterally. It is hard in consistency with eccentric proptosis and periorbital fullness. Conjunctival and corneal erosions were noted, and range of movements were found to be restricted in right eye fully, and vision is found to be less than 1/60 in the right eye. CT penis or the other investigations were found to be normal, hence we proceeded with CT penis with orbit. Soft tissue mass arising from right nasal cavity eroding the lacuna patricia was found to be in CT. To find out the extension completely, we proceeded with the MRI penis with the orbit. Here there is a heterogeneously enhancing lesion of right maxillary and ethmoid sinus with intraorbital extension. So we proceeded to go with the procedure, direct nasal endoscopy and biopsy. Here in the right nasal cavity, reddish fibril mass was found, extending arising from right middle meatus, completely obscuring the view of the choana. And left nasal cavity is smaller compared to right and scope could not be passed further. So biopsy specimen showed small round losal tumor in sheets, a possibility of esthesia neuroblastoma. And this is the specimen we got from the pathology department. So clear cytoplasm with centrally placed round nuclei. To confirm the diagnosis, we proceeded with immunohistochemistry. CD99 and EWSR1 was positive, which was found to be Ewing sarcoma. So the differential diagnosis based on the history and the clinical findings for this patient was rhabdomyosarcoma, retinoblastoma, Ewing sarcoma, neuroblastoma, and Wilms tumor. As a confirmation of Ewing sarcoma is found, we proceeded to go with the management of chemotherapy for this patient. And the chemotherapy started was VAC regimen, that is vincristine, actinomycin T, and cyclophosphamide. And the patient showed a significant improvement after first cycle of chemotherapy with a drastic reduction in swelling of the eye and nasal swelling. Now coming on to the case 2. Here is a 1-year-old, 3-month-old male child present to the hospital with complaints of left ear discharge since 3 months of age and right-sided deviation of mouth since 1 year of age. There was no history of hard of hearing as per the mother. The child was managed conservatively with a topical antibiotic since 3 months of age with no improvement in ear discharge. On examination of left ear, the external auditory canal was found to have an active foul-smelling mucopurulent discharge and the tympanic membrane could not be visualized. On examination of facial nerve, the child was found to have deviation of mouth to right with inability of closing the eyes, and there was absence of wrinkling of forehead on the left side when the child was made to cry. So we proceeded with the HRCT temporal bone. Here there's a soft tissue density lesion with a scutum erosion and tegment mastoidium with the dehiscence of superior and posterior semicircular canals and labyrinthine part of the facial nerve. MRI brain with inner ear was done to rule out any intracranial complications of CSOM. Here there was a hypointense component in left middle ear cavity and mastoid cells with a few areas of restriction diffusion suggestive of otomastoiditis with no intracranial involvement. So we proceeded with the surgery of left modified radical mastoidectomy, and intraoperative findings were found to be closed cholesteatoma and granulation tissue engulfing the ossicles with erosion of malleus, incus, and mastoid cortex. Also, there was a dehiscent tegment mastoidium and posterior semicircular canal with facial nerve. And the specimen when sent for biopsy, it turned out to be a small round dorsal tumor suggestive of Ewing sarcoma. For again confirmation, we proceeded with the immunohistochemistry in this type. Here, the EWSR1 gene along with the FISH test was positive, which is the 90% confirming of Ewing sarcoma. So post-operatively, as the child was found to have healthy mastoid cavity with no ear discharge, the patient was managed with the chemotherapy as a VAC regimen. That is vincristine, actinomycin D, and cyclophosphamide. And there was a improvement in the facial palsy from grade 4 to grade 3. Now here is another case, case 3. There is a 18-year-old male presented with the complaints of throat pain and pain during swallowing for 1 month with swelling over left side of cheek for 1 month. There was no history of voice change, fever, or any dental extraction or any other significant ENT complaints. On examination of cheek, there is a swelling of size 4x3 cm located over the left parotid region, which is firm in consistency, which is not mobile, not warm, not tender, and skin over the swelling was found to be normal. When proceeded with the oropharyngeal examination, the left tonsil was found to be enlarged of grade 4 and right tonsil is grade 1 enlargement and the uvula being pushed medially. The medial examination was found to be within normal limits. So we proceeded with the investigation of CECT neck. There's a soft tissue density lesion displacing the left parapharyngeal space and left masseter muscle, possibility of rhabdomyosarcoma. Again, we proceeded with the MRI. Since it's a sarcoma, diffusion restriction is noted in left masseter space with above mentioned areas with the displacing the cavities posteriorly, which is also suggesting of rhabdomyosarcoma. Hence, we proceeded with the procedure transoral biopsy, and the histopathology found to be sheets and clusters of small round cells with scant eosinophilic cytoplasm, round nucleus with occasional rosette formation. In the immunohistochemistry, the vimentin and MYOD1 were found to be positive in 90% of the tumor cells with the CD20 negative. Based on immunohistochemistry, rhabdomyosarcoma is confirmed for this patient. Here, the patient was planned for multidisciplinary approach. That is, the patient was planned for neoadjuvant chemotherapy, surgery, and adjuvant chemotherapy. But in the neoadjuvant chemotherapy with the VA regimen, that is vincristine and actomycin, there was a drastic reduction in the swelling size. Hence, surgery is not done for this patient. So, based on these 3 cases, now the discussion is that sarcoma in head and neck is a rare malignant disorder arising from mesenchymal tissues, which most commonly seen in extremities and trunk. But in head and neck region poses a unique challenge due to its complex anatomy and critical functions and some mostly aggressive tumor. It is usually diagnosed at an advanced stage due to its insidious onset and overlapping symptoms with other conditions. Understanding the etiology, clinical presentation, and treatment modalities, it is crucial for improving the patient outcomes. So there are different types of sarcomas. There is rhabdomyosarcoma, osteosarcoma, Ewing sarcoma, which is most commonly involved in head and neck region compared to other sarcomas like fibrosarcoma, and less commonly liposarcoma may be seen. Synovial sarcoma, angiosarcoma, and chondrosarcoma, the other sarcomas, less commonly noticed in head and neck region. So the management of sarcomas involves diagnosis and treatment. So in the diagnosis mainly involves the imaging with CT and MRI, but to rule any metastasis present, we can go for PET scan. And biopsy is confirmatory along with immunohistochemistry. So the treatment modalities that are available for sarcomas include surgery, chemotherapy, radiotherapy, targeted therapy, and immunotherapy. And the chemotherapy can be neoadjuvant or adjuvant chemotherapy. So the recent advances that are included in the treatment of sarcomas include molecular characterization and genetic profiling, targeted therapy, and immunotherapy, along with stereotactic body radiation therapy or proton therapy. So the take-home message from this study is that early diagnosis is necessary for appropriate management and follow-up of the patients, and also educational awareness initiatives must be started as the symptoms may mimic other normal conditions also, and as a multidisciplinary approach for resectable tumors, surgery followed by radiotherapy or chemotherapy is preferred. In case of unresectable tumors, as in the case of first child, or case of chemosensitive tumors, we can go for chemotherapy as a standard treatment of care. And these are my references. Thank you.
Okay. What are the risk factors for this development of sarcomas in head and neck regions? Is it smoking and alcohol? Is it because of smoking and alcohol, which are the risk factors for other malignancies like squamous cell carcinoma of head and neck surgery, head and neck region?
Sorry, now adults and adolescents are smoking as a risk factor, but in this study, everyone has noticed to be a pediatric population, sir. So we can think of any family history genetic, but they also do not possess a complete risk factor for sarcomas.
Could it be any radiation? Could be the
radiation may be there, sir, but in this study group, radiation exposure is not noticed in these 3 population. And other patients we are screening as a squamous cell carcinoma, mostly involving adolescents, they also having any radiation exposure in the past.
Tell me one syndrome which is associated with sarcoma. Any syndrome, genetic syndrome. Okay, no problem. What is the cause specific 5-year survival rate of sarcoma?
survival rate depends on the prognostic factors and the size of the tumor and the location of the tumor. If we diagnose it in early stage, and if it is in the locations not close to the skull base, the survival rate is 70% based on the studies. But if it is encroaching the skull base, or if it is in the second case, there is an involvement of carotid displacement. So in that case, if we go for survival rate, it is less compared to the other cases.
Okay. What do you understand by stage 2 according to Memorial Sloan Kettering staging system? Stage 2. Okay. What are the factors linked to greater cause-specific survival rates?
Sir, factors?
Related to linked to greater cause-specific survival rates in
In sarcoma, survival rates mainly based on age factor and the location factor, sir.
Yes. Gender.
Is age, gender, and the location, whereas the size of the tumor and the site of the tumor.
Yes. Any history of radiation exposure is there or not? That also
Yes, sir.
carries. Okay. What is the origin of this hemangiopericytoma? Which is one of the sarcomas. Have you ever heard about hemangiopericytoma?
Pericytoma.
Okay, no problem.
Yes.
No problem.
Okay, Dr. Mukesh. Dr. Mukesh.
Sir, good morning, sir.
Uh,
Can you hear me, sir?
yes, yes.
You see my video, sir?
Yeah, we can
Sir?
see. We can see your
Yes, sir.
screen.
Yes, sir. Good morning. Mukesh, here to present a case series on CS of rhinorrhea and its management, our experience. CS of rhinorrhea is caused by an abnormal relation between the subarachnoid space and the nasal cavity. Here is the classification of the CS of. This is in Omaya's classification. Sir?
We cannot see your slides.
Sir, it's sharing.
No.
We can see, but your voice is not clear.
Yes, you can unshare your screen and you can reshare. Doctor, we cannot see your screen. Your voice is not clear.
You can present later. The next candidate will take.
Dr. Mukesh, you can present later. Dr. Rajan Chellappa, are you ready?
Yes, sir, I'm ready, sir.
You can please share your screen. Dr. Mukesh, please unshare the screen.
Good morning, sir. Is my slides visible, sir?
Yeah, it is visible.
Sir, good morning, sir. Myself, Dr. Rajan Chellappa, second year MS in postgraduate.
Yeah, please
And
make
my
it full
top
screen.
Good morning, sir. Myself, Dr. Rajan Chellappa. I'm going to talk on pharyngeal mucosal changes in GERD patients, sir. Introduction. Gastroesophageal reflux disease is defined as abnormal reflux of the gastric contents into the esophagus, causing symptoms under complications. While GERD is traditionally viewed as an esophageal disorder, growing evidence shows that it can impact the upper aerodigestive tract, including the pharynx. The prevalence of GERD is rising globally, particularly in India, due to shifts in direct. Can I continue?
Please continue.
The prevalence of GERD is rising globally, particularly in India, due to shifts in dietary habits, increasing obesity rates, and evolving lifestyles. The pharynx, a crucial part of the upper aerodigestive system, plays an essential role in swallowing and speech, with its mucosa serving as a protective barrier against irritants. However, in GERD patients, chronic acid reflux can compromise this protective mechanism, extending beyond the esophagus and leading to laryngopharyngeal reflux, manifesting as chronic cough, hoarseness, and a sensation of lump in the throat. It's a global sensation.
Continue, doctor.
My objective is,
Rajan, are you there?
yes, sir.
No.
My objective is to determine the pharyngeal mucosal changes in GERD patients.
Please switch on the timer. Dr. Rajan Chellappa, you can continue.
Yes, sir.
I request organizers to switch on the timer.
Yes, sir.
A prospective study was designed by recruiting patients with GERD from Department of Medical Gastroenterology to Department of ENT. Among 100 individuals visiting the Department of ENT between July 24 and September 24, patients with GERD who met the inclusion criteria were selected. Breast biopsy samples of the pharyngeal mucosa were obtained from pharynx using a cytology breast. After fixating the samples using 99% isopropyl alcohol, all specimens were sent to Department of Pathology for cytological examination. The smears were assessed for the presence of epithelial hyperplasia or any indications of cellular dysplasia. The observed cellular changes were classified into normal inflammatory changes, cellular hyperplasia, and altered nucleocytoplasmic ratio. And the patient selection criteria, inclusion criteria as patients who are all willing for the study, and patients with chronic GERD, patients in the age group of 30 years and to 60 years, and patients not taking any medication at the time of study. And exclusion criteria includes patients age less than 30 years and more than 60 years. The second exclusion criteria is patients having other systemic illness like cardiac disease. Third exclusion criteria include pregnant females and patients with other systemic illness. Smokers, alcoholic, and tobacco are excluded from the study.
Can you change your slides? I cannot see your slides. Yes.
This is my patient
Okay,
selection
go.
criteria.
Yeah,
Sir.
yeah. Go ahead.
This is how I distributed the patients based on age 30 to 40 years, and 40 to 41 to 50, 51 to 60, and gender specifically male and female, with GAD duration of the symptoms 1 to 2 years. Patients presenting with more than 3 to 4 years of symptoms, and patients presenting with more than 3 years, 5 years and more than 5 years symptoms. Results. The information collected regarding all the selected cases is recorded in a master chart. Data analysis was done with the help of computer using MS Excel SPS 28 version. Using this software, frequencies, percentage, range, mean, standard deviation, chi-test and t-test and p-value are calculated. A p-value less than 0.05 is shown to have significant relationship. This is my result, sir. Out of 100 patients, 40 patients gave the report of normal epithelium, and 32% with inflammatory cells, and 26% presented with increased cell size, and 2% presented with increased nucleocytoplasm ratio. Discussion. Our study reveals significant association between the duration of GAD symptoms and patient age and specific pharyngeal mucosa. Notably, we observed an increasing incidence of increase in cell size and presence of inflammatory cells among participants with a longer history of GAD complaints and advancing age. These findings suggest a progressive impact of chronic acid exposure over time. The pathophysiology of GAD and its relation to the observed pharyngeal mucosal changes can be explained by the chronic exposure of the pharyngeal epithelium to gastric reflux site. The impetus for our study stemmed from the paucity of research specifically examining pharyngeal mucosal changes in GAD patients. When numerous studies have investigated laryngopharyngeal reflex as a whole, the distinct impact on the pharyngeal mucosa remains underexplored. Our focused approach allows for a more nuanced understanding of GAD's effects on this specific anatomical region. Conclusion. In conclusion, our study provides valuable insights into the specific pharyngeal mucosal changes associated with GAD, highlighting the progressive nature of these alterations with the disease duration and age. These findings contribute to a better understanding of GAD's extraesophageal manifestations and may inform future diagnostic and therapeutic approaches. Further research is warranted to explore the long-term clinical implications of these mucosal changes and their potential role in guiding patient management strategies. And these are my references, sir. Thank you.
What are the dynamic tests you can do for GAD?
You can do 24 pH monitoring, sir, and manometry we can do.
Any other?
Sorry, sir, I'm not sure.
Okay, what are the most consistent histological findings in non-erosive GAD?
You know, inflammatory cells were observed, sir, mostly.
Okay, what is the etiopathogenesis of Barrett's esophagus in GAD?
So, columnar metaplasia, sir, because of chronic exposure to acid.
Squamous metaplasia. Is it because of this chemical injury or any other inflammatory markers are like cytokinins? If yes, what are the cytokinins? Sorry,
I'm not sure.
Okay, what are the causes of GAD?
So, obesity, increased training, increased caffeine intake.
Okay, doctor.
Thank you.
Z. Bhanupriya. Dr. G. Bhanupriya. Are you there?
Sir, I think we have finished 14 candidates, sir.
But we missed 4 candidates, sir. So we can ask the whoever the pending, we can call them, sir.
Okay.
Dr. Asma?
Whatever organizations will follow.
Thanks. Thank you, sir.
Dr. Asma Begum? Dr. Jemima? Dr. Jemima, okay.
Yes, sir.
Ah,
Sir, can you see my presentation?
yes, yes.
Yes, sir. So good morning, sir. I'm going to present on the correlation between the depth of invasion and nodal metastasis in tongue malignancy. Just a minute, sir. So can you see my slides? Hello?
Yeah, change your slides.
Change
Yes,
your
sir.
slide.
Yes, sir. So the introduction, in India, 4 in 10 malignancies are oral cancers. In the developed world, the floor of mouth cancers are common, where
Please share your screen again.
yes, sir. So saying in India, 4 in 10 malignancies are oral cancers. In the developed world, the floor of mouth cancers are quite common, whereas gingival cancers are common in India. The incidence of tongue cancers have been on the rise in India, and as the cancer grows, they invade the surrounding tissue and spread to the cervical lymph nodes due to the rich lymphatic systems in the neck. So usually when a patient presents, they present with symptoms of pain, ulceration, or a proliferative growth on the tongue. Majority of patients with carcinomas in the lateral border of tongue usually present in stage 1 and 2 as compared to patients with carcinomas of floor of mouth, where they usually present in later stages. So this is the new American Joint, American Joint Committee, Cancer Committee's classification. T1 is tumor less than 2 centimeters in diameter with the depth of invasion of less than 5 millimeter. T2 is where the tumor size is less than 2 and the depth of invasion it could be more than 5 but less than 10 millimeter, or the tumor size is 2 to 4 diameters and the depth of invasion is less than 10. We have T3 where the depth of invasion is more than 10 millimeters in diameter and the tumor size is more than 4 millimeter in diameter. Then we have T4A, where it invades adjacent structures like the cortical bone of the mandible, maxilla, the antrum of the skin, and T4B, where it invades the masseter space, the pterygoid plates, and the skull base. This is the nodal staging, where N1, where the tumor, where the node is less than 3 centimeters in diameter in the greatest dimension. N2A, where there's an ipsilateral lymph node less than 3, more than 3, but less than 6 centimeters in the greatest dimension. N2B, where there are multiple ipsilateral group of lymph nodes less than 6 centimeters in the greatest dimension. N2C, where there are multiple bilateral lymph nodes more than 6 centimeters in the greatest dimension. So we have two terms, which is tumor thickness and the other one is depth of invasion. Tumor thickness usually refers to the vertical diameter, the vertical length. So it would include the exophytic as well as the endophytic portion of the tumor. Then we have something called as the depth of invasion. So we take this depth from the base, from the surface epithelium to the greatest point of invasion of the tumor. So the aim is to study the depth of invasion in tongue malignancies and its correlation with metastasis. In inclusion criteria, we've taken all patients with biopsy-proven tongue malignancies, and exclusion criteria, we've taken patients with ulcer over the tongue but biopsy negative, patients with non-squamous cell carcinoma of the tongue, patients with traumatic ulcers over the tongue, and patients with tongue carcinoma previously treated with chemotherapy or radiotherapy. So methodology, this study was carried out on 10 patients with biopsy-proven tongue malignancy between 2023 and 2024 to know the histopathological correlation between the depth of invasion and neck node metastasis. The study population, all patients presenting with biopsy-proven tongue malignancy, and duration was from June 2023 to 2024. So here patients with biopsy-proven malignancy were staged based on TNM staging and treated with wide local excision of the tumor and simultaneous neck dissection. Surgical specimens were oriented, labeled, and fixed in formalin. In specimens of node dissection, the number of nodes dissected and the maximum dimension of the largest excised node was noted. Multiple histopathological characteristics were analyzed, which include lymphovascular invasion, perineural spread, tumor size, depth of invasion, and the grade of differentiation. So the depth of invasion is usually calculated as the distance between the basement membrane and the deepest portion of the invaded stromal tissue by an ocular micrometer. It is usually viewed using 4x magnification. In patients with exophytic tumor, the measurement was taken from the height of the surface of normal adjacent mucosa to the deepest reaching front of infiltration. So I'm going to talk about 4 cases. Out of the 10 cases, I'm going to show 4 cases. Here, there's a patient who came with complaints of growth in the left lateral border of tongue for 2 months. 4 cross 5 centimeter proliferative growth noted in the left lateral border of tongue, extending 2 centimeters from the tip. The neck on palpation, there was left level 2 node palpable. USG neck showed evidence of subcentimetric lymph nodes noted in the left level 2 and 3. MRI showed an ill-defined heterogeneous hyperintense lesion of size 4.3 cross 1.2 cross 2 centimeters in the irregular margins noted in the lateral border of tongue with left level 2 lymph nodes of size 1.5 cross 0.9 centimeters. Pre-op biopsy showed infiltrating squamous cell carcinoma. We staged him as T3N1MX. Patient was taken up for left hemiglossectomy with supraomohyoid neck dissection. The biopsy, prior to surgery, the lymph node biopsy showed reactive lymphadenitis, whereas the post-op, the depth of invasion was 8 millimeter, and he had 3 out of 33 lymph nodes showing metastatic deposits. So the pathological staging changed to P2A N2B MX. Then we have a patient, this is a case 2. A patient presented with complaints of ulcer over the right lateral border of tongue for 2 years. It was on palpation, it was 0.5 cross 0.5 centimeter ulcerative mass noted in the right lateral border of tongue. USG neck showed multiple subcentimetric lymph nodes in bilateral level 1B. CT neck confirmed the same findings. The pre-op biopsy showed infiltrating squamous cell carcinoma moderately differentiated. We staged her as T1N0MX. We took her up for wide local excision with supraomohyoid neck dissection. So her pre-op biopsy was cervical lymph node showing reactive lymphadenitis. Her depth of invasion in the post-op biopsy showed 0.4 4 millimeters, and her post-op lymph node status was reactive lymphadenitis. So there was no lymph node metastasis. This was another case where the patient presented with ulcer in the right lateral border of tongue for 5 months associated with pain. Ulcerative proliferative growth noted 4 cross 3 centimeters in the right lateral border of tongue, 1 centimeter from the tip. CT neck showed an ill-defined heterogeneous enhancing lesion. Subcentimetric lymph nodes were noted in right level 1A, 1B, level 2, largest measuring 6.6 millimeters. The pre-op biopsy showed an infiltrating squamous cell carcinoma well differentiated. She was staged as T2N1MX. This was her depth of invasion, which was 4 millimeters, and all lymph nodes showed negative metastasis in the post-op biopsy. This was case 4, where patient presented with ulcer over the right lateral border of tongue. We staged him as T1N0MX. His pre-op biopsy showed reactive lymphadenitis, and his but his depth of invasion, the post-op biopsy was 10 millimeters, and the pathological staging turned to T2N2B MX, with 4 lymph nodes being positive in the post-op biopsy. So this was the results. For patients with T1 were 20%, T2 were 60%, T3 were 20%, and T4 were 0. Well differentiated carcinoma were 30%, moderately differentiated 60%, and poorly differentiated were 10. The depth of invasion for patients less than 5 millimeter, were 30% of the patients had less than 5 millimeter depth of invasion. 5 to 10 were 40%, and more than 10% were 30%. So the nodal metastasis N0 was the pre-op period was 6 patients, and lymph node positive were 4 patients. But the pathological staging N negative was 3 patients, and positive were 7 patients. So the conclusion, it was seen that as the depth of invasion increases, there is a higher chance of neck node metastasis. For carcinomas of tongue, a depth of invasion of more than 5 millimeter is taken as cutoff, above which the chance of nodal metastasis increases. And all the 7 patients, of all the 10 patients we've studied, all the 7 patients with the depth of invasion of more than 5 millimeters showed a cervical node metastasis. These are my references, sir. Thank you.
Different studies shows the depth of invasion. So what is the meta-analysis? Have you gone through any meta-analysis article which gives you some idea about this?
So the depth of invasion according to different studies are different. Some people have taken 8 millimeter as the depth of invasion, but so far it has been standardized that any depth of invasion more than 5 millimeter has increased chance of neck node metastasis, sir.
Yes, you rightly mentioned depth of invasion is 8 millimeter can be taken as a cutoff point in oral tongue cancer.
Yes, sir.
What about buccal mucosa?
So buccal mucosa studies have shown that more than 10 millimeter can be taken as positive for lymph node metastasis, according to different studies.
Okay. Okay. How do you evaluate a patient if suspected malignancy for tongue cancer?
So in our hospital, usually we do initially after the examination, we do an USG neck to look for lymph nodes, and so we take a USG guided FNAC followed by MRI, sir. And then we
what inference you will get from USG guided lymph node maps, lymph node aspiration?
So usually lymph node biopsy we do first staging whether there's already tumor mets or not, whether it's just cervical lymphadenitis or already the tumor has metastasis to the lymph nodes, sir.
Okay. What is the role of CECT in suspected neck mets?
So usually here for us, usually CECT is done for patients who are not affordable for an MRI. We usually take we ask them to take an CECT.
Okay. What is selective neck dissection?
So selective neck dissection, there are 5 types, sir. So you can have supraomohyoid neck dissection, extended supraomohyoid neck dissection. You can have lateral neck dissection, posterolateral neck dissection, and anterior neck dissection. So selective groups of lymph nodes are removed with preservation of non-lymphatic structures, sir.
Okay. Nice.
Dr. Subbu? Dr. Mukesh, are you ready?
Yes, sir. Good morning, sir. Sir, I'm ready with the presentation.
Just wait. Just wait, Mukesh.
Yes, sir.
Dr. Subbu is about to present, I think.
Yes, sir.
Okay,
Yes,
sir.
sir. I'm ready. So is my slide visible, sir?
Yes, ma'am.
Can I start, sir? Can I start, sir?
Please start.
Honorable judges, reverend dignitaries,
Your screen is visible. You please make it full screen.
Okay, sir. Hello, sir.
Please click on the slide share presentation.
It's on the slide share presentation. It's working. It's working. Sir, it's on the slide share presentation, sir.
It is not visible.
See, one suggestion to all those who were not present earlier, you either switch the laptop and check your Wi-Fi connection, or you change the laptop. You keep a standby laptop.
Okay, sir.
Just
Just change my laptop.
The other person who is ready, you can present.
Mukesh, Dr. Mukesh, you can start.
Sir?
Yeah, Dr. Mukesh, please share your
Can you see
screen.
me?
No, we can't see your screen. Dr. Subbu, please unshare your screen.
Yes. Unshare it. Unshare it. Share it.
Dr. Mukesh,
Yes, sir.
share your screen.
Sir. So can you see my screen, sir?
No, not it. I think your Wi-Fi connection is very much slow.
So now, can you?
No, it is not visible. So, Dr. Subbu and Dr. Mukesh, you can present later.
Okay, sir.
Okay. Next, Dr. Bhanupriya.
Yes, sir.
You please share your screen, madam.
Okay. Screen kada. What's that? So
Good morning. Continue.
Good morning, madam.
sir, my topic is analyzing the outcome of infrared terminate reduction surgeries in allergic and non-allergic patients, a comparative study.
You are not audible, madam.
Sir.
No, madam, we cannot hear you.
Sir, terminate hypertrophy is one of the most common causes for nasal blockage, often seen in the case of allergic rhinitis and non-allergic rhinitis. It's usually treated by and patients
or not responding from medical management
Where you were
or treated by inferior terminate reduction surgery. Infraterminal turbinoplasty is mucosal preceding turbinoplasty considered as preferred approach. Submucosal dithyramide is still widely used because it is easy to perform and has few complications. However, with the introduction of many surgeons have started recently using it for same purposes. Thus, the study was conducted to compare the outcome of inferior terminate reduction using above methods. My main aim is to compare and analyze the surgical outcomes of inferior terminate post-operative implant of non-obstructive and obstructive symptoms of the patient, pre-operative and post-operative DNA grading, and post-operative healing recovery and complications, if any, during the post-op follow-up, thereby establishing the ideal method for surgical technique for sternoplasty. Inclusion criteria: patients of age 20 to 60 years and who are refractory to medical treatment or medical management are selected, and patient who was not responding for decongestant test are selected. Usually, grade 2 and grade 3 inferior turbinate hypertrophy patients are selected. My exclusion criteria are patients with nasal obstruction due to other conditions like nasal mass lesions.
We cannot see your screen, madam.
It's like, can you? Can you see it now, sir?
No. Yeah, now we can see.
My study procedure. I have my patient present to OPD fulfilling the inclusion criteria are included in my study. After taking complete testing and recording the 4-point no score, clean and thorough clinical examination, pre-op DNE along with radiological investigations and relevant blood investigations are done. Each 10 patients are allocated in each group. My no score are nasal congestion, deals with nasal congestion, nasal blockage, trouble breathing through the nose, trouble sleeping, and unable to get enough air through nose and during exercise or exertion. And nasal endoscopy. I am using Friedman. I'm using Friedman system for inferior turbinate size. Grade 1, mild enlargement with no obvious obstruction. Grade 2, occupies more than half of the inferior nasal cavity. Grade 3, complete occlusion. Here, this is the Friedman grading of turbinate showing under inferior turbinate is infiltrated with 2% lidocaine and adrenaline. Mucosal diathermy using 22 gauge needle. It is inserted into the anterior end of the inferior turbinate, and which is spinal needle is used as monopolar probe, and diathermy is done. It's done at the anterior end, superior and medial surface and posterior surface of the end, wherever the hypertrophy is present. Submucosal pocket in the inferior turbinate and inserted inserting the microdebrider and debride the submucosal layer along with the bony part over the inferior turbinate. In both surgical procedure, at the end of the procedure, the bilateral nasal cavity is packed using antiseptic ointment soaked ribbon gauze or Merosil. The nasal pack was removed after 24 hours. Post-operatively, was done on again 6th and 4th week, 10th week. Patients was evaluated using 4-point symptom score and DNA grading. This is my master chart. My etiology are 7 patients allergic patients are 3 patients in SMD, and in MAID group, allergic patients 8 patients and a non-allergic patient 2 patients were included. In no score, preoperatively 8 to 10 in average in SMD and 8 to 11 in group.
Madam, share your screen.
Grade 2 was 6 patients. Grade 4 patients in operative in submucosal dialysis 8 to 10 minutes on average, and microdebrider 16 to 18 minutes. Intraoperative blood losses less than 2 ml in submucosal dithermy and 10 to average 10 to 30 ml in microdebrider assisted abdominoplasty. Postoperative pain is seen in one patient in his dithermy and microdebrider. 3 patients have complaints of postoperative pain, but which resolved in POD2. Post-op crusting is seen in 4 patients in SMD and 1 patient in microdebrider assisted abdominoplasty. Post-op synechia formation is seen in 2 patients in SMD and 1 patient in microdebrider assisted abdominoplasty. And post-op no score at the end of the 10th week is 5 for SMD and 3 for microdebrider assisted abdominoplasty. Post-op DNA grading at the end of the 10th week is grade 1, it has 6 patients, and grade 2, 4 patients, and MAID group, grade 1, 8 patients, and grade 2, 2 patients. Analysis of the outcome of the surgery. On comparing the analysis about 20 patients, though operative time and blood loss slightly more in microdebrider, MAID patients have better symptomatic improvement in post-op follow-up, and post-op crusting and synechia slightly lesser than submucosal dithermy. So I used to prefer microdebrider assisted abdominoplasty in both allergic and non-allergic rhinitis patients. These are my references. First, in this video, I'm showing first I'm creating the submucosal pocket at the anterior end of the turbinate and inserting microdebrider.
Madam, no video, no nothing.
See, we cannot see your screen at all. You are just.
Yes, sir. Yes, sir. Yeah. Rakesh, time is over.
So my screen is not visible, sir.
Sir, first in the first 14, 3 people are not able to present.
Can you
sir.
see my video?
Yes. Okay. Okay.
Dr. Asma, Dr. Subbu, Dr. Mukesh are unable to present, sir.
Okay. Okay. Let's move on to next judges. Thank you, Prabhakar sir and Anil Kumar sir for this session as a judges.
Thank you, sir.
Thank you so much for your patience and time for us, sir. Yeah.
Foremost, I would like to congratulate all the contestants. They have presented very well, excellent presentation with the high-end content, advanced content. And also, I congratulate HODs of corresponding medical colleges. And also, I thank the organizers for giving me this opportunity.
Most welcome, sir. Thank you so much once again. We move on to the next session, sir. I'm Sriharsha. Are you there? Sriharsha. I'm welcome Dr. Suktankar, sir, the senior most faculty and retired HOD from the Pune, AFMC Pune, and also Dr. S. Ramakrishna, sir, retired HOD and Superintendent of Government ENT Hospital and presently working at Malareddy Institute. Sriharsha, if you are there, please show the CVs. Welcome Suktankar, sir, and Ramakrishna, sir.
Good morning, Ramesh.
Good morning, sir. Good morning, sir.
Sir, good morning, Suktankar, sir.
Suktankar, sir. Are you? Yes, sir.
They are not unmuted.
Okay. Sir, in the link, but sir,
let him unmute.
Okay, sir. Yes. With the permission of the judges, Dr. Rakesh will move the presentation, sir.
Ramesh, can you just tell the serial number Thereby, it will easily
Yes.
identifiable.
Yes, sir. Sir, actually, this is the first 14 to 15 candidates they have judges, sir. But in between, some are missing. So
Okay.
while presenting, Dr. Rakesh will specifically tell the serial number and name of the presenter, sir.
That's better.
You have the list of batch 2 candidates of total 28. In that, you have to judge remaining candidates, sir.
Okay, we'll try.
Suktanka, sir, are you okay, sir? Shall we proceed with your permission?
Sir, ask Dr. Suktankar sir to unmute.
Sir, Suktanka, sir, unmute yourself.
Yeah,
Sriharsha.
am I okay now?
Yeah, yes, sir. Yeah, you are audible
Sir,
now.
good morning, sir. I am Ramakrishna, sir. Suktankar, sir, good morning.
నమస్కారం అండి బాగా గుర్తున్నారు నైస్ సీయింగ్ యూ
Forget, sir.
నైస్ సీయింగ్ యూ
Let us make a beginning, sir, with your company.
Yes, definitely. Thank you.
Yes, sir.
Of the judges, we will proceed, sir. Shall we proceed?
Yeah, please.
Yeah, Dr. Rakesh.
Yeah. Dr. Sheshan, are you ready? Dr. Sheshan.
Unmute.
Am I seen, sir?
Dr.
Yes.
Sheshan. Yeah.
Yeah,
Share
you
your
are.
screen.
Good morning, sir. I will share my screen. Just a minute, sir.
Is serial number 44, I think.
Yes, sir.
And the timing is 8 minutes or 5 minutes?
8 minutes, sir.
Okay, right.
Is my presentation seen, sir?
Yes.
Yeah.
Can I start, sir?
Yeah, please start.
Please.
Good morning to one and all who are listening over there. My name is Seshan, and my topic is about the excision of juvenile nasopharyngeal angiofibroma by means of an endoscopic approach. As we all know, juvenile nasopharyngeal is a benign tumor, locally aggressive. It passes through the natural crevices and natural foramen, and it gains angiogenesis by the nearby periosteum over there and the nearby vessels over there. In the past, before the advent of endoscopes, we know that every JNM was surgically operated by means of open approaches. Now the trends are changing with the advent of endoscope. Almost all the tumors with stages up to 3C can be removed by means of endoscopical approach. My aim of the presentation is to present that with the endoscopic approaches that we can easily visualize the bleeders and cauterize it, and we can easily go through the foramen, natural foramens and recesses so as to eliminate the disease from the, and also avoids the open approaches which disturb the federation pattern in case of children with young age, because it's most commonly present in adolescent males and prepubertal males. My case series includes a study of 4 cases. My first case came with the 26-year-old came with the complaints of right nasal cavity bleeding for the past 6 months and nasal obstruction. Here's the DNA video of the patient. The DNA video shows that the polypodermas noted over the right nasal cavity just behind and below the middle terminates. And doing a CT, we found out that mass was completely filling the pterygopalatine infratemporal fossa and reaching up to the skull base. And further, we did a CT angiogram so as to visualize the feeder. When feeder was found to be internal maxillary artery, we then prepare the patient for surgery. The surgical video, first we did the Denker's approach, then removed the anteromedial. Then the internal maxillary was visualized and it was clipped intraoperatively. Sir. After clipping intraoperatively, IMA, the mass was totally excised out through the nasal cavity. Then
your slide is not seen.
Okay, sir. Just a minute, sir. Seen now, sir?
Yes.
Yes. The first patient, we did internal maxillary artery ligation during the intraoperative time. Then we excised the whole mass through the nasal cavity. The mass was then the pterygoid wedge was drilled because So it is important to drill the pterygoid at the end of the surgery because the recent hypothesis states that JNA is due to an incomplete regression of first brachial artery. So which regresses near the pterygoid wedge, and the mass can be visualized here. And my second case is about a patient who presented of 20 years, presented bleeding from the left nasal cavity and left nasal restriction for the past 8 months. The DNA video shows that the mass over the left nasal cavity, which is red to gray in color. And CT, we found that the mass was filling the entire nasal cavity and reaches just up to the pterygoid fossa, not completely filling the aorta or involved in the erosion. Since it is small mass, we directly prepare the patient to surgery. We initially done a Denker's approach by lifting the mucosa near the pyriform aperture. Then the anterovidial wall of the maxilla was removed. Then the mass was visualized near the sphenoparietal environment, which was taken out, then sent for HPE. The pterygoid wedge was then drilled. The mass can be visualized in the picture, sir. Thank you. Case 3, tells about the patient 21 male came with the complaints of right nasal obstruction for 2 years, but he has a history of only 1 episode of bleeding and has a history of snoring. The DNA video shows that the mass over the right nasal cavity, sir, which is just behind the inferior terminate below and medial to the inferior terminate. This patient has on CT we saw that the Radowski staging was 2B, that it completely filled the pterygopalatine fossa, reaching till the pterygopalatine fissure. On CT angiogram, we found that the feeder was internal maxillary artery and done a PE of angioembolization with the help of an interventional radiation. The mass was taken out under general anesthesia. In this case also, we approached posterior wall of maxilla by means of Denker's approach. Then we totally removed the then pterygoid wedge was drilled so as to prevent the recurrence and the residual disease. This is an interesting case in which a 9-year-old male child presented with the complaints of nasal obstruction, nasal discharge, no other complaints of bleeding, but swelling over the right cheek with the history of mouth bleeding. Initially, we thought of adenoid. Patient also had a crust with the DNA, showed the crust with the polypoidal mass behind the crust. Then we done a CT, which showed that the mass was extending near the infratemporal fossa, so that it presented with the swelling over the cheek, and it also reaches near the skull base. Since it's a small size, we wanted to avoid the open approach. We got through the endoscopic approach. We also done a CT which showed that internal maxillary artery and the ascending pharyngeal artery of the feeder vessel, and we done a pre-op embolization so as to prevent the intraoperative bleeding. Since it's a younger child who may have more vascular elements, we done a right ECL ligation at the starting of the procedure. Then we we started the procedure. Initially, we almost did a Denker's, we then converted into the medial maxillectomy, in which the maxilla, pterygopalatine fossa, right nasal cavity, infratemporal fossa all come into a single cavity. Then mass was extending near the clavus. Only the pterygoid wedge was there was a rest. Pterygoid wedge was drilled away. This is what showing. And we all know we do investigation like diagnostic nasal endoscopy, computer tomography of paralysis, and we enhance with the contrast, and to find the feed result, we do a CT angiography, where we can also embolize through it. MRI brain is to find out that there is an erosion of skull base and there's an intradural environment. This staging shows the Radowski staging. Recent staging is the Radowski staging, where mass is limited to nose and with one or more sinuses, and it then extends to pterygopalatine fossa, then extends to RB, then extends to infratemporal fossa, then extends to skull base, and then it extends to skull base, eroding skull base, and ends in intradural. Discussion is that endoscopic approach is a minimally invasive is due to imaging technology and minute endoscopic in which the bleeders can be visualized. Previous and visualized, and mass can be visualized. And of the 4 patients, 2 patients where the 2 patients undergone pre-op embolization are significantly shown that they have a decreased blood loss intraoperatively. Totally 4 cases presented in this study was taken in a period of 2 years, which were done in our institute, and all the 4 cases were posteriorly all the cases were followed. First 3 cases showed complete recovery, and the last younger child showed recurrence. Since the recurrent tumor was present over the skull base and literally extending eroding skull base, we then refer the patient to radiotherapy since we want to avoid open approach in an younger child. Then conclusion is that rather compared to open approach, endoscopic approach is has reduced complication, reduced morbidity, and faster recovery, shorter hospital stay, and also blood loss can be significantly reduced in case of endoscopic procedure. And in also patient with less extensive journey, endoscopy is the mainstay of treatment. And for patients who are requiring revision surgery for recurrence, also endoscopic is the mainstay of treatment. These are the references. That 4-4 Brado technique, surgical and John and Naso engineering 20 years of experience in endoscopy. Thank you, sir.
Session, you have told the advantages of embolization. Can
Sir,
you tell
I'm
me?
not.
Can you hear
Hello,
me?
sir. I'm not
Can
able
you,
to hear, sir.
now, can you hear me
Hello,
now?
sir.
Can you?
Hello, sir. Am I audible, sir?
Yeah, you are audible.
Am I audible, sir?
Yeah, you are audible, but you seem to not hear me at all. Can you hear now?
Audible, sir.
Okay.
Very low
Ramakrishna
voice.
sir, you
Sheshan, you are
Increase the
audible.
volume.
Okay. Can you hear the sir?
he is not able to hear us.
Sir, no, I'm not able to hear, sir.
What about session? Are you able to hear me?
Sheshan, can you able to hear Dr. Ramakrishna sir?
Am I audible, sir?
Better now.
Session.
Are you audible? Am I audible now?
I'm audible, sir.
You are audible. What about us? Oh, okay.
Session, can you hear sir?
He
Sir,
is
there is
not
some
able
issue
to
of
hear
unmute
you
sign
also.
chat. Can we move on to the next presenter?
Okay, sir. We'll move to next
Yeah,
present.
definitely.
Okay,
Not
session.
able to hear, sir.
Lakshana. Dr. Lakshana. Dr. Lakshana, can you hear me?
Yes, sir. I'm able to hear, sir.
Okay. You can share your screen, madam. Share your screen. Is there any difficulty? Doctor? Yeah, we can see your screen.
Yes,
You
sir.
please enlarge it. Yeah, you make it full screen.
Yes, sir.
Good.
Yes, madam. You can continue.
Yes, sir. Good morning, respected chairpersons, judges, and my dear colleagues. I'm Dr. Lakshana, going to present on transforming boundaries, head and neck dermoids. A dermoid cyst is a
Yeah, proceed.
Continue.
Yes, sir. A dermoid cyst is a pathological type of congenital or acquired cyst, which are commonly known to arise from the active ectodermal cell rests that are trapped in an abnormal position. When considering all dermoid cysts, 7% arise from the head and neck region, and more than half will be diagnosed before 6 years of age, and incidence is around 1 to 20,000. Intracranial dermoid cysts are rare and compose only 0.1 to 0.7% of all intracranial tumors. So this paper tries to emphasize the clinical presentation, radiological investigation, gender ratio, age and side of the dermoid cyst and highlights the rare sites of presentation and complications. The retrospective 5-year data collection was done of patients who were diagnosed as head and neck swelling and underwent excision, and histopathology was proven as dermoid cyst. Data was collected and analyzed via SPSS software. So percentage distribution of gender, female were around 58% and 41% were male. Percentage distribution according to the site, and 41% were on the left side, 17% on the right side, and others were around 41%. So totally we had 17 patients. So most of them presented with a neck and a nose swelling. Even rare presentations were noted in the nasopharynx, pinna, and post-oral region. Here I highlight 3 cases with a rare and uncommon presentation. So here comes a 2-year-old male child who presented with a swelling in the dorsum of the nose as we see in the first image, and we evaluated him with an MRI which showed 1.5 into 1 into 1 centimeter cystic lesion as shown in the second image, which was noted in the prenasal area connecting with the intracranial cystic lesion, which was measuring around 1.2 into 1 centimeter via a 1.9 centimeter connecting tract. Defect was noted in the anterior cranial fossa as shown in the third image. So this patient underwent removal of the cyst under general anesthesia. This lesion was noted attaching the upper and lower nasal cartilage traced between the 2 nasal bones, which was excised in toto. An intracranial lesion was removed endoscopically and HPE was proven as dermoid cyst. A second case, a 4-year-old female child presented with bilateral eye swelling as shown in the first image. We evaluated her with an MRI orbit which showed a cystic lesion of measuring 7 into 5 into 9 mm in the root of the nose with a soft tissue swelling and fat stranding involving the preseptal compartment of the left eye. So this patient underwent excision of the cyst and was treated with IV antibiotics and completely recovered, and HPE was reported as dermoid cyst. Here, a 43-year-old female who came with complaints of bilateral ear block for 5 years and left ear discharge for almost 1 year. On examination, right tympanic membrane was bulged with air fluid level and left ear showed a central perforation. So we did a diagnostic nasal endoscopy to rule out the eustachian tube patency, which showed a cystic lesion occupying the nasopharynx. Further, we evaluated her with a CT PNS, which showed 1.4 into 1.2 into 1.4 centimeter, which was a well-defined cystic lesion with a peripheral enhancement with a speck of calcification in the nasopharynx. So for this patient, she underwent transnasal marsupialization of the cyst, and to our surprise, HPE was reported as a dermoid cyst. So dermoids arise from the trap pouches of the epidermal folds where they are slowly expanding unilocular cystic masses which produce only mild symptoms. So these commonly occur in the orbit, calvarial, diploic and intracranial spaces. So here imaging plays an important role in defining the margins, extensions and any suspicious malignant transformation. So MRI in our case helped to rule out the intracranial extension, plane of attachment of the lesion. Even in the rarest presentation in the parotid region, It helped us to rule out the attachment to the parotid and its relation to the vital structures such as retromandibular wing. Most of the times, dermoids are asymptomatic. They are removed for cosmetic reasons or when they mass compresses the vital structures causing functional symptoms. So surgical excision remains the treatment of choice with an excellent prognosis. For example, in nasal and pinna dermoids were removed for cosmetic reasons. Nasopharyngeal dermoids were removed since patient had persistent ear complaints, whereas postauricular dermoids, even though they are not cosmetically important, they were removed in view of malignant transformation to squamous cell carcinoma. Dermoids with intracranial extension should be removed to prevent mass effect and meningitis. Coming to complications, they cause bony erosions, eyelid displacement, and intracranial extension and risk of transformation to malignancy. Dermoids which have an intracranial or intraspinal extension may lead to meningitis, abscess, or cause a local mass effect causing increase in the intracranial pressure. So coming to the differential diagnosis, dermoids, though being a common midline lesion in the head and neck region, it should be considered as one of the differential diagnoses for a swelling in the head and neck region. For example, in a parotid region, pleomorphic adenoma and schwannoma were considered as differentials. In the nasopharynx, Thornwall cyst, Rathke's cleft cyst, branchial cleft cyst were considered as a differential diagnosis. This paper emphasizes the various presentations, diagnostic approach, complications, and management of the head and neck swelling dermoids. Due to its tendency for growth and possible complications, early surgical intervention is recommended. Recurrence after surgery is around 2 to 4%, even though malignant transformation is rare, around 1 to 2%. I conclude that dermoid cyst warrants excision. Thank you, sir. These are my references.
Lakshana, a good presentation.
Yes, sir.
Case number 3, you said that there is a mass in nasopharynx and
Yes,
also
sir.
seen in the ear with the central perforation. Is it
Yes,
is it a
sir.
mass in the ear or something else?
It was not a mass in the ear, sir. Mass, actually, she presented with nasal complaints, sir. And we
Okay.
did diagnostic nasal endoscopy. Ear
Okay.
complaints. She presented with the ear complaints. So we did a diagnostic nasal endoscopy since she had bilateral ear complaints. So to rule out any eustachian tube dysfunction,
Yeah,
we did
the effect of the
diagnostic
mass
nasal.
on eustachian tube resulted this sort of changes in the ear. That is your conclusion, right?
Yes, sir. Due to the cystic lesion in the nasopharynx, she presented with a
Yeah.
ear complaint, sir.
Yeah, understood. And what about the incidence of malignancy is 2%? I really don't have any faith on that sentence. Is it recorded evidence, like a sort of authentic study? It may get secondary infected. It may get secondary infected. I don't know about malignancy change.
It's a
Sir,
malignancy.
sir, comment.
Malignancy is very, very rare.
Yes, sir.
In these cases.
Okay, sir.
So the incidence will be not 2%. It will may be very, very rare.
Still less. Infection may be possible.
Yes, sir.
Infected cyst or something, rupture and all sort of thing we have seen. And there's one more thing.
What happened to the middle ear mass? You said middle ear mass. So
No, sir, middle discharge, sir.
what happened to the middle ear?
No, sir, it was a middle ear discharge.
Fluid. You mean fluid there?
Yes, sir, fluid.
You
We
said bulb.
treated her. Yes, sir.
Okay. Now, one question about the cosmesis of the incision used on the dorsum of the nose. In
Yes,
a
sir.
child, the incisions are directly there. Are there any other cosmetic incisions for these lesions for the dorsum of the nose? Do you know? To approach the dorsum of the nose, not
Yes, sir.
endoscopy.
Okay, sir.
Any other incisions which will not violate the dorsum.
Dorsum.
Oh, okay.
Flap.
Right.
We'll move to
Not sure.
We'll move to the next student.
Dr. Praveen.
Yes.
Dr. Praveen, are you ready?
Yes, sir. Yes, sir. I'm
Please share your screen. Ishan, please close. Dr. Praveen.
Yes, sir.
Please share your screen.
Sir, I shared my screen, sir. Able to visible my screen?
Yeah, it's visible. It's visible.
Yes, sir. Good morning, sir. I'm
The
Dr. Praveen.
projectors remaining, please don't share your link. Session, you'll exit from the link. Your presentation already over. You are trying to share your link.
Sir, question and answers.
You already over done it. That's nothing. That's okay. Already over.
Ramesh, we need not bother about him, no? Ramesh?
Yes, sir. Yes, sir.
It is completed. That's it.
Yes, sir.
Thank you.
Praveen, you can start.
Yes, sir. Good morning, sir. I'm Dr. Praveen. I'm presenting my paper on the topic a case series of sinonasal malignant tumors and its management by endoscopic surgery in a tertiary care hospital. Introduction. Sinonasal malignancies are a highly heterogeneous group of cancers, account for less than 1% of all cancers. In this intranasal endoscopic resection approach represents a safe and effective method for the surgical management of sinonasal malignancies, while compared to open approaches such as transfacial and transcranial approaches followed by adjuvant therapy. The endoscopic approach rests on the observation that sinonasal cancers frequently have a focal attachment point and that the most tumor volume fills the air-filled sinonasal cavity. This endoscopy approaches proceed with piecemeal debulking with the goal of identifying and resecting the tumor pedicle en bloc. Endoscopic approaches provide improved visualization of the tumor margins as facilitating complete dissection of the tumor organ, resulting in negative margins. Aim of the paper is to evaluate the outcomes of the endoscopic approach to sinonasal malignancies with or without adjuvant therapy. This case series includes 3 cases of sinomalignant tumors and its management approaches by endoscopic surgery followed by adjuvant therapy. All the 3 cases are done by same surgeon in the same tertiary care hospital. Period of study is 6 months. First case is a 52-year-old female. Came with complaints of nasal bleed on and off for 3 months. History of nasal block for 3 months present. History of decreased perception of smell. On a diagnostic nasal endoscopy, showed a pinkish smooth mass arising from the septum in the left nasal cavity. CT, nose and paranasal sinuses has been done. It showed a well-defined soft tissue density lesion in the posterior-superior part of the left nasal cavity, abutting the middle and superior turbinates. It does not extend into the spinopelvic foramen, tricuspid fossa, or posterior nasopharynx. Patient has been underwent a carburetor-assisted excision of the sinonasal mass under general anesthesia. Histopathology showed suggestive of glomangiopericytoma, where the fibrocollagenous tissue is lined with the respiratory epithelium and neoplastic cells. Vessel shows a strong staghorn appearance, perivascular hyalinization has been seen. Neoplastic cells positive for beta-catenin and SMA, that is smooth muscle actin. Post-operatively, patient was on follow-up for 5 months. No recurrence has been noted and no adjuvant therapy has been given for this patient. Glomangiopericytoma is a rare benign sinonasal tumor with an overall survival rate. It accounts for fewer than 0.5% of all sinusal tumors. It occurs in late adult life with a slight preponderance in women. The gold standard investigation is histopathological examination as it arises from the Zimmermann pericytes that surround the capillaries. Treatment option is complete excision, complete local excision with a 5-year survival rate is 88%. Second case is a 55-year-old male came to OPD with complaints of left-sided nasal block for 6 months and complaints of blood-stained nasal discharge from the left nasal cavity. On diagnostic nasal endoscopy, showed in the left nasal cavity showed a proliferative friable mass bloodstained arising from the roof of the nasal cavity. CT nose and paranasal sinus has been done. It showed ill-defined soft tissue lesion noted in the left nasal cavity arising from the anti-ethmoidal cells, causing widening of the nasal cavity and blockage of the maxillary ostium involving the capriform plate. Differential diagnosis showed esthesia neuroblastoma and sinusal carcinoma. Patient has done MRI contrast and nose and paranasal sinus have been done. Showed heterogeneously enhancing mass lesion of size 3.5 into 1.7 into 2.5 centimeter, involving the anti-ethmoidal as cells, mostly in the midline and the paramidline location, involving the posterior part of the septum. Extension superiorly up to the roof of the ethmoid sinus. Laterally causes blockage of the left maxillary ostium. Inferiorly up to the superior part of the nasal cavity. There is no obvious intracranial extension has been noted. Patient first underwent endoscopic biopsy of the sinonasal mass, in which histopathology showed sinonasal adenocarcinoma, intestinal type, followed by patient underwent endoscopic craniofacial resection of the sinonasal carcinoma. These are the intraoperative images. In the first image, it shows the antiskull base has been exposed. There is no obvious erosions has been noted. Ascending process of maxilla and the cribriform plates has been drilled on both sides up to the fovea. No active serious leak has been noted, and the defect has been closed using a facial data in multiple layers. After that, histopathology showed all the margins were negative. Post-op PET scan has been done and showed ill-defined erosions of the bilateral cribriform plate of the ethmoid with no obvious extension into intracranial cavity. No locoregional lymphadenopathy at distant metastasis has been seen. Patient currently on concurrent chemoradiotherapy. Third case is a 73-year-old male presented with the complaints of left-sided nasal plug for past 1 month and complaints of left-sided nasal discharge for past 1 month. And diagnostic nasal endoscopy showed ulceroproliferative growth noted in the roof of the nasopharynx towards the left side. CTPNS has been done, showed a hypodense lesion of 2 into 1.8 into 1.2 centimeter in the nasopharynx, and involving the left fossa of Rosenmüller and left torus tubaris, causing extension tube block and left serous arteritis media. MRI nasopharynx has been done, as it showed an enhancing soft tissue thickening noted in the left fossa of Rosenmüller, extending to the adjacent mucosal pharyngeal space and pharyngeal tonsil with intracranial involvement over the base of the skull and cavernous sinus. Extension has been noted here. Patient underwent biopsy of the nasopharyngeal mass has been done, as it showed adenoid cystic carcinoma of nasopharynx T3N0M0. Patient underwent a debulking surgery. Endoscopic nasopharyngectomy has been done. Post-operatively, MRI neck has been done, showed ill-defined soft tissue thickening, as it showed a residual disease over the adjacent pharyngeal mucosal space. Patient currently on radical radiotherapy. Discussion based on the surgical outcomes and challenges. In all the 3 cases, endoscopic resection allowed for precise tumor removal with debulking with tumor debulking with minimal morbidity. The ability to preserve the surrounding anatomy with achieving tumor negative margins is a significant advantage. However, the limitations of the endoscopy surgery, especially in cases with the extensive invasion, like in the third case with the intracranial extension, it's necessary to adjuvant therapies like radiotherapy and a long-term follow-up is needed. In case 1, there is no recurrence at the 5 months period post-operatively, whereas case 2 and case 3 presented with the residual disease, emphasizing the aggressive nature of some sinonasal malignancies and importance of close post-operative monitoring and adjuvant therapy. Pathological considerations. In this case series, each tumor exhibit distinct histopathological features from the benign nature of glomerulopericytoma to the aggressive adenocarcinoma and adenocystic carcinoma. IHC markers such as beta-catenin, SMA, and CD117 are essential in confirming the diagnosis. Conclusion: as endoscopic surgery combined with adjuvant radiotherapy offers an effective treatment option with favorable outcomes in terms of disease control and patient survival rate. The endoscopy approach is good as an open approach such as transfacial and transcranial craniofacial resection in obtaining negative margins. It carries less morbidity and shorter hospital stay. Thus, the gold standard for a surgery of sinusal malignancies is therefore to select the approach that is most capable of obtaining negative margins with minimizing patient morbidity. These are my references. Thank you.
Your first case is a benign case.
Yes,
it's
sir.
not a malignancy. Yeah, so you only said it is a benign and your topic is malignant cases. Now, what is the cause for recurrence? Is it the aggressiveness of the tumor or inadequate excisions because of endoscopic limited access approach?
In the second case, we plan a debulking surgery alone. So inadequate clearance is the cause for a recurrence. Whereas in the second case, we histopathologically we showed margins have been clear, but still the PET scan showed residual disease has been there. So.
So that
in
is not a recurrence. That is a residual disease over the bone.
over the bones, cribriform plate.
Okay. Now, can you call this as a craniofacial resection?
As the first, second case has been can be called as a craniofacial resection, sir. As the cribriform plate has been
removed.
Yes, sir.
But the remnants had disease.
Yes, sir. Remnant process.
The third case is adenoid cystic carcinoma.
Yes, sir.
Right? So,
Yes, sir.
if is there any other approach other than nasal endoscopy for that area?
For that nasopharynx, combined with neurosurgery teams, because the tumor itself involving the intracranial contents, as the cavernous sinus has been involved, base of skull and cavernous sinus has been involved, sir. So we mainly plan for a debulking of the tumors, sir. We are not for complete removal, not for in-block resections.
Okay. So, for adenoid cystic carcinoma, to prevent recurrences, early recurrences, you need to do the complete excision.
Okay.
Are they radiosensitive?
Yes, sir. That's why radiotherapy has been started.
They are not radiosensitive. They are partly radio resistant. It's only adjuvant treatment. It won't help in the residual.
What is the peculiarity of the adenoid cystic carcinoma, Ravi?
Yes, sir.
What is the peculiarity of the adenoid cystic carcinoma during spread and other thing aspects?
Peculiarity means
the
behavior of the
spread of the
adenoid cystic
tumor.
carcinoma.
There is a high tendency for metastasis for adenoid cystic carcinoma.
Transneural spread that is being
Neural spread cause. In where intracranial extension is in adenoid cystic carcinoma.
So there are
practically adenoid cystic carcinoma has to get excised.
Yes,
Suptankar sir rightly said that the role of other modalities are not very effective. Yes, sir. Suptankar sir.
Yes, sir. Yes, sir.
Yeah. As far as possible, excision is the line of treatment. If it is not so, recurrence is very, very high. And the problem is your carotid is very close to the site of involvement. That is our observation.
Yes, sir.
Thank you.
Thank you.
Okay. We can go to the next speaker. Hello.
Shanta Kumari, are you ready? Dr. Shanta Kumari. Dr. Shanta Kumari. Dr. Susmita. Dr. Shanta Kumari.
Sir,
Just
give us 2 minutes. Sir, can you hear me? Sir?
Yeah, you are audible.
You are audible, madam. Please share your screen.
Start video. Sir?
Yeah, sure.
Yes, no.
First, please share your screen.
Your slides are not seen.
One second, sir.
Share them.
Sir, is it visible, sir?
No.
Madam, it is not visible. Okay, doctor. Take your time. We are proceeding with the next presenter. Dr. Sushmita? Sushmita, are you there? Is it Sushmita or Shantakumari?
Sir, my name is Sushmita, sir.
Okay. Yeah. Please share your screen.
PG.
Sir, is it visible now, sir?
Not visible.
Slides are not seen. The screen is empty. Yeah.
Now we can see the Shantakumari screen. Dr. Shantakumari.
Sir, is it visible now, sir?
Yeah, it is visible.
Okay.
Okay.
Shall I start, sir?
Dr. Susmita, please wait.
Yes, sir.
Shantakumari, you can continue.
Okay. Good morning, sir. I'm going to talk about rhinogenic contact point headache, causes and role of surgical management. So what is rhinogenic contact point headache? It is defined as intermittent pain localized in the periorbital and medial canthal temporozygomatic regions with significant So what is lidocaine patch test? It is under DNA guidance, cotton patches soaked in the 4% xylocaine were applied in the nose, that is contact points, for the period of 10 minutes, and there will be more than 50% reduction of headache. So my methodology is presented to our OPD with his of which is response to the medical treatment, and my exclusion criteria are acute and chronic rhinosinusitis, patient polyposis, and patient with neurological causes of headache. So then these patients are subjected to the DNA and CTNS and lidocaine patch test. Then based on the contact points, the targeted surgery will be done. The follow-up using pain assessment scale. So these are the common mucosal contact points: middle terminate with septum, septum with the middle terminate with the lateral nasal wall, inferior terminate with septum, that is in bilateral inferior terminate hypertrophy, septum with the agernasal, concha pulmosa, and overpneumatic ethmoidal bulla, and paradoxical middle terminate. These are the surgical procedures.
Madam, excuse me, madam.
Sir?
Your screen is not visible. Please share the screen.
No, sir.
Not
yet. Sir?
No.
Not visible, madam. Having difficulty, take somebody's help or change the laptop. Check the internet connection and come back. Okay, we'll go with next presenter.
Okay, sir.
Okay, and don't interrupt in between.
Okay.
Dr. Sushmita. Yeah, I think
she is back.
Dr. Shantakumari.
Sir?
I think your screen It's visible now. Okay, you can continue. You can continue. Please continue.
Angioplasty, lateral lamellectomy, tonsillectomy, turbinoplasty, removal of agar nasal. Targeted surgical intervention in patients suffering from the refractory contact mind headache, and to evaluate the surgical outcome and to reduce the frequency and severity of the headache related to the mucosal contact points. This is a pain, moderate pain, severe and moderate pain, significant mild interference with the daily activities, and severe pain, unable to do the daily activities. In my case 1, a 42-year-old female with complaints of headache for the duration of 8 months, which is not relieved by events, headache more over the medial canthal periorbital regions, and with the associated symptom of nasal obstruction on and off duration, and no other symptoms. This is CT planus showing bilateral inferior turbinate hypertrophy.
Doctor.
After so more than 50% relief of headache.
Yeah.
Sure.
Case 2, a 3-year duration of headache with nasal obstruction as my associated symptom. And my CT showing bilateral inferior turbinate hypertrophy with the bilateral concha bullosa. So we did lignocaine patch test, shows more than 50% reduction of headache. So we did septal correction with turbinoplasty. By the end of 1 week, patient has mild pain. By the end of 1 month, patient has complete dissolution of symptoms. In my case 3, 1 year duration of headache with associated symptom nasal obstruction. So my CT shows by deviated septum to right with the spur impinging on the inferior turbinate with bilateral inferior turbinate hypertrophy. In my lignocaine patch test shows more than 70% reduction of headache. So we did septal correction with turbinoplasty. We follow shows by the end of 1 week, patient has mild pain. By the end of 1 month, patient has by the end of 1 week, patient has moderate pain, and by the end of 1 month, patient has mild pain. In my case 4, 2 years duration of headache.
Slides are not seen again. Can't see the slide.
1 second, sir.
No. రామకృష్ణ గారు మీకు కనబడుతుందా?
No, sir.
No, sir.
I'm in the same phase.
Not
seen, not seen.
Okay, sir, Ramkrishna sir, we'll give her a chance at the last, sir.
Okay. You make a note of
We'll
it,
go
then
to
we
the
will.
next presenter.
No problem, doctor.
Dr. Susmita. Dr. Susmita.
Sir, sorry to interrupt you, sir. Sir, the previous presenter's session, he has presented while taking questions is not, mic was not working, sir.
Yeah.
So he's requesting for questions, sir. Mr.
You
Session.
want to give him entry?
If you
Okay.
consider-
Okay.
Yes, repeatedly.
Okay, Ramesh sir, ask him to come back.
Yes, sir. If repeatedly sending message, that's why I'm requesting you, sir. Yes.
Dr. Seshan, are you there?
Dr. Seshan.
Dr. Shantakumari, you please stop sharing your screen.
Okay, sir.
You don't try in between. Okay, please stop. We'll give you at last.
Okay.
Please stop your screen. Okay. Dr. Sheshan, are you there? Dr. Sheshan.
Use your mic now.
Dr. Mukesh?
Sir?
Please close your screen. Please close your screen.
Yes, sir.
Please close your screen. Don't share your screen.
Yes, sir.
Sheshan, are you there? Sheshan.
Unmute yourself, Sheshan.
Sheshan, judges are ready and they are about to ask you questions. Are you ready?
Sir, can you hear me, sir?
Yes,
Sir,
yes, sir.
this is Dr. Seshan's friend, sir. He's having some network issues, sir. Right now, he's trying to connect, sir. We
Ask
can
him
move.
to take the question. Okay.
Yes, sir. Yes, sir. I'll remind him, sir. He's
Yeah.
there in the next room trying for network connection, sir. We can proceed with next presentation, sir. Meanwhile, I'll remind him, sir.
Okay, and don't interrupt Sheshan in between. We will ask you questions at last. Okay.
Yes, sir. I'll remind my
Don't
friend,
disturb
sir.
Dr. Ramesh, sir. Okay.
Okay, sir. Sure, sir.
Okay.
I'll remind my
Dr.
friend,
Susmita,
sir.
Dr. Susmita, are you ready? Dr. Susmita. Okay. Please share your screen.
Yes, sir. 1 second, sir.
Okay, and you and Shantakumar are friends, huh? Both from the same computer?
Yes, sir.
Again,
Hope similar problem should not crop up.
So can you see my screen, sir?
Not yet.
Yeah, please share it first. Please share it, madam.
Switch off.
So can you see my screen now, sir?
Yes, madam.
Good morning. My name is Dr. Sushmita. I'm a second year postgraduate in MSc. I'll be talking about the different presentations of malignant tumors of nose that we saw in our institute. Sinonasal tumors are rare and they can have an epithelial or mesenchymal origin. Epithelial tumors are the most common. They can originate from the olfactory epithelium or neuroendocrine tissue or axillary salivary glands. Case details of a few patients who presented with symptoms like unilateral or bilateral nasal obstruction, disfigurement of the external nasal contour, nasal discharge, and epistaxis were seen. DNA was done and the radiological investigation was done in all patients like CT and MRI scans. Biopsy was taken in all cases. This is a 33-year-old male. He presented with an apparent vestibulitis of nasal cavity. He had a history of bilateral nasal obstruction for the past 5 months, history of epistaxis for the past 5 months. For 1 week, he had a history of headache involving the frontal region. This is how he presented to us. He had a disfigurement of the external nasal contour. On examination, external nasal contour was altered and there was enlargement of the dorsum of nose. Anterior rhinoscopy revealed a proliferative growth in the right nasal cavity. There was an erosion of the hard palate when we examined this oropharynx. D showed a proliferative mass in a lateral wall of right nasal cavity with crust and blood clots. Septal perforation was present. We took multiple biopsies for this patient, which turned out to be only necrotic tissue. But finally, we took another biopsy and it turned out to be non-Hodgkin's lymphoma, T-cell type. This is the CT scan of the patient.
Madam, we
He-
cannot see your screen. We
Can
cannot see your
you-
slides.
You
Can
have
you
to
display
change the slide.
Supportive slides.
See, both of you should change your laptop or network connection.
Yeah, this is a little better clinical photograph.
Yeah.
Can you see now?
This is CT scan.
Yes, sir. For this patient, he underwent chemoradiotherapy, but after 6 months, he passed away due to the illness because he presented very late to us. Case 2. This is an 18-year-old male. He had a history of swelling over the root of nose for the past 3 months. He had a history of headache for the past 3 months involving the frontal region. History of nasal discharge from right nasal cavity for the past 3 months. And he had a history of blurring of vision for the past 2 months. There was frontal bossing seen. Initial DNA and biopsy came out to be as acute inflammatory pathology. So the patient gave a specific history of swelling over the root of nose after a human bite. So we assumed that it would be frontal osteomyelitis. This patient was posted for excision of mass along with osteoplastic flap procedure. Repeat biopsy turned out to be as polydifferentiated high-grade sinonasal carcinoma, and his CT brain showed metastasis in the right frontal lobe.
Your slides are not changing.
There are no supportive slides displayed for this case.
Whatever you are telling is slides are not corroborating.
Shantakumari and Susmita. Okay.
Yes,
See, both are having network issues, and please check your laptop. Okay. This is not the way of presentation. Okay, we cannot judge like this. Okay.
sorry, sir.
At least try to do a trial run, then get ready with more confidence.
See, this
Sir,
is the
is it
internet
seen
problem.
also?
Yeah, this is the second case you are talking about now.
Yes, sir.
Subhankar sir, support.
Yeah, can be seen.
Yes, sir.
We posted the patient for excision of mass, and we did an osteoplastic flap procedure. This was the mass taken out, and his biopsy came out to be a polydifferentiated high-grade sinonasal carcinoma. We did a CT brain for this patient, and he had metastasis to the right frontal lobe. Case 3 is an 18-year-old male who presented with a casualty with bleeding from left nasal cavity. He had a history of left-sided nasal obstruction for 3 months, a history of ear blocking sensation for 2 months, and history of pain left ear and left eye.
Can you go to the corresponding clinical slide of this case?
Yes. He was a young adult with bleeding from assumed it to be a juvenile nasopharyngeal angiofibroma.
No, your slides are not changing.
We are seeing the slides of the earlier case. Clinical picture. Now at least show me the clinical picture of the present patient.
Seen now, sir?
Radial imaging is seen. Image is seen.
You maximize the slides, then I think it will be better. Do you know how to maximize?
Yes, sir.
So you have come to slide 1 now.
Yeah.
Go
So
to
third,
the,
this is which case? No, case 1, huh?
yeah,
So it's case 3C now, sir.
yeah, angiofibroma.
Oh, yes.
This is image.
We assumed it would be a juvenile nasopharyngeal angiofibroma. But so we posted this patient for excision, endoscopic excision of mass. But the HP turned out to be a nasopharyngeal carcinoma, and the patient is currently undergoing adjuvant chemoradiotherapy. Case 4, this is a 61-year-old male. He came with the chief complaints of nasal obstruction, which was progressive, and it was involving the left more than the right nasal cavity. He had history of bleeding from left nasal cavity for 1 month.
No slides related to case 4, ma.
Yes, sir.
See, your time is wasted like this.
So is it seen now, sir?
No.
Yeah, history is there.
Case 3 only, sir. He's talking about case 4. Yeah.
This patient had a history of bleeding from left nasal cavity for 1 month. He had a history of hyponasal pneumonia. On local examination, anti-rhinoscopy did not reveal much information, but we did a DNA and we saw a mass covering the left choana, left sphenoethmoidal recess, and it was entering the right choana. Biopsy was taken from the mass.
Any endoscopic photographs?
Sir?
We were just seeing only right up. Right. Endoscopic photo is seen now. So go ahead.
So is the video seen, sir?
Yeah.
For this patient, we HP as a associated nasopharyngeal carcinoma. The patient is undergoing 30 cycles of radiotherapy.
Any neck notes for this patient, ma?
No, sir.
No neck notes.
Yes, sir.
Yes, proceed.
Case 5 is an 81-year-old male with complaints of left-sided nasal obstruction, which was gradually progressive. He had a history of left-sided nasal discharge. DNA showed growth in the lateral wall of left nasal cavity. This patient already had a history of inverted papilloma 10 years back. So we suspected it to be another inverted papilloma. The HPE came out to be a squamous cell carcinoma. So we the inverted papilloma. This is the DNA of the squamous cell carcinoma.
Yeah, this is the DNA photograph of squamous cell carcinoma.
Yes, sir.
Good, go ahead.
His HP came out to be as infiltrating squamous cell carcinoma. Thank you, sir.
Have you finished?
Yes, sir.
What was the aim of your presentation?
To present about the different cases that came to our institution, sir.
You said diagnostic pathways. Diverse presentation and diagnostic pathways. So in the diagnostic pathways, in the second case, you people did a CT brain also when the PNS is shown the lesion? Because in the post-op, you have seen recurrence or residual mass intracranial.
Yes, sir.
So did the pre-op CT did not show?
Yes, sir. Pre-PT, when we do a PNS, sir, post-op, the patient was having autism and
No, no.
responsiveness. So we took a CT
Did the pre-op showed
metastasis.
or didn't show any lesion? Did
We
the
have not shown
pre-op
any lesion
CT?
in the frontal lobe.
So what was the time gap between the pre-op and post-op CT?
Pre-op CT PNS was taken in July, sir. 1 month later, we in August, mid-August, we did a excision of mass. 1 week later, the patient had decreased responsiveness, so we took a CT brain, sir.
So the 3 months gap was there.
Yes, sir.
So 2 months after CT, you did surgery. Okay. So there is always in malignancy, there is CT planning should be as close to surgery as possible. The second is, in the second case, I mean the first case is T cell type NHL. Patient died 6 months post your treatment. So what was the workup done after the nasal biopsy to rule out other parts of the body being involved by NHL? Because within 6 months he died. And you just said he died. He died with what? Disease or any other ailment, or what was the thing? Or you people, he was lost to follow?
He was referred to the medical and oncology department, sir, and they did a CT scan.
Okay.
This was 1 month after he was referred to medical oncology, sir.
Fine.
He underwent at least 3 months of radiotherapy, but I just know the information that he passed away. So I
Okay.
don't know the exact.
Probably you didn't know what are the PET CT findings. So in addition to radiotherapy, was he given any chemo also post-op?
Yes, sir. He was given a CHOP regimen, sir. Cyclophosphamide.
So probably you people are not aware with what complication he died. Okay.
Yes.
Ramakrishna sir, you were.
No, sir, your questions are quite valid, but the follow-up of the patient is not really satisfactory. That's only my comments. I think more than that. Right, sir.
We'll move to the next presenter.
Yeah.
Dr. John Bosco.
Yes, sir, I'm present, sir. Am I audible, sir?
Yeah, you're audible. Please share your screen.
Go to slide 1.
So is my screen share visible, sir?
No.
No.
Okay, sir.
Yes.
Yeah. Maximize it. Yeah, that one. Press.
In case 4 is seen, can you go from?
You have it's
Yes, sir.
no. Yeah, now
Title
yes.
slide. Yeah, title slide.
Yeah. John, you can start now.
So wait a minute, sir. Wait a minute, sir, please.
Okay.
Sir, I'm starting, sir. Good afternoon, sir.
Please
Sir, shall I
start.
start, sir?
Yeah, please.
Yes, sir. Good afternoon, sir. My name is Dr. John Bosco. I'm going to demonstrate you a case series on rhinoorbital cerebral mucormycosis, its risk factors, and our surgical experience in its management. Introduction. Coming to the introduction, rhinoorbital cerebral mucormycosis is an uncommon, aggressive, invasive, acute, fulminant, invasive fungal infection that affects the sinuses, nasal cavity, mucosa, nasal mucosa, and intracranial structures, which is caused by the angiotropic fungus belonging to the order Mucorales. It has significant morbidity and mortality. The leading international Society of Fungal Education portal estimates that annual global prevalence of mucormycosis is approximately 10,000 cases annually when Indian data is not included, and when Indian data is included, it becomes nearly 9,10,000 cases annually. It usually occurs in immunocompromised individuals with impaired neutrophilic response. And these patients include uncontrolled diabetes mellitus patients, especially with ketoacidosis, diabetic ketoacidosis, or patients undergoing steroid therapy, or patients undergoing organ transplant or hematopoietic stem cell transplant recipients, or iron overload patients, or patients on deferoxamine therapy, or acquired immunodeficiency syndrome patients. And coming to the etiology, the fungus is ubiquitous in nature, that is present everywhere on the decaying debris and soil. And the most common genera causing human infections include Rhizopus, Lichthemia, Aphoxomyces, Mucar, and Rhizomucar. And the most commonly associated mucorale species in rhinoorbital cerebral mucormycosis is Rhizopus oryzae, or the latest name is Rhizopus oryzus. Coming to the pathophysiology, the sporangiospores are commonly inhaled by the host, and an immunocompromised individual, the initial site of infection is the nasal mucosa of the inferior turbinate. The rhizopus grows rapidly in the hyperglycemic environment because the phagocytosis is significantly impaired, and the neutrophil cannot show its chemotaxis or its defective intracellular killing by both oxidative and non-oxidative mechanisms. And also, because of the acidotic pH, the serum binding protein transferrin dissociates from the iron, and there is availability of free serum iron. So this fungus requires iron because iron is a growth factor for this fungus. So the diabetic ketoacidotic pH also helps the fungus to grow. And in hyperglycemia, there is also upregulation of the glucose related regulatory protein 78, which is normally an endoplasmic reticular protein. It will be resurfaced to the cell membrane of the endothelial cells, which helps in the penetration of the fungus into the endothelial cells, causing vasculitis, thrombosis, tissue infarction, and necrosis of the tissues. Coming to the histopathological examination seen, the classical histopathological examination is of broad acetate papery hyphae with irregular borders and obtuse angle branching is seen. You can see the different slides of gomori methamine silver stain and lactophenol cotton blue stain showing the Rhizopus oryzae, the broad acetate irregular bordered hyphae can be seen with obtuse angle branching. And coming to the materials methods of my study, patients irrespective of age and gender attending ENT OP from 2023 to 2024 were taken into consideration. All these patients came with complaints of nasal obstruction from the nose, nasal obstruction, foul smelling discharge from the nose, black necrotic crust in the nasal cavity, swelling of cheek, pain and swelling of gums or loose tooth, or tooth pain and palatal defect, and some patients presented with ptosis and impaired vision. The investigations used were routine blood investigations were done, diagnostic nasal endoscopy of each patient to check for thick purulent discharge in the nasal cavity or any blackish crust that are eschars present in the left nasal cavity or right nasal cavity, and smears, nasal swab or smears were sent for KOH mount for fungal elements, and imaging was done. Non-contrast CT PNS was done, and MRI PNS orbits. T1 sequencing was done, T2 sequencing was done with fat suppressed and fat enhanced images, and also the most important investigation of choice for surgical planning was MRI PNS with orbits with brain with contrast enhanced, gadolinium contrast enhanced, and DNA guided biopsy was also done. And the staging used was the staging described by Santosh G. Horawat, a Indian ophthalmologist, during the epidemic of mucormycosis during the COVID season. That is, stage 1 includes involvement of the nasal mucosa. Stage 2 is for any involvement of the paranasal sinus mucosa, and stage 3 is for any involvement of the orbit, and stage 4 is for the involvement of the CNS, and it has all subdivisions. Coming to the first case, that is of stage 4C, because in this patient, the nose was involved, paranasal sinus was involved, orbit was involved, and skull base was involved. It was a 37-year-old male patient. He was a known case of polio, and also he was a known case of type 2 diabetes mellitus, and he had prior admission to the hospital for diabetic ketoacidosis. And on examination, he has ptosis of the left eye. The pictures we can see is of the DNE. In the posterior part of the coena is seen, and the posterior part of the inferior tablet, you can see the posterior part of the inferior tablet, you can see the necrosis, blackish crust present, and mucopurulent discharge in the nasopharynx, exposed basisphenoid bone, and the posterior bony part of the septum is also exposed. And you can see in the last image, there is mucopurulent discharge dripping down into the posterior pharyngeal wall from the nasopharynx. And the CT PNS of this patient showed skull base erosion, such as floor of the sphenoid sinus was eroding, and also the medial pterygoid plate and lateral pterygoid plate was also eroding. There was soft tissue density in the left retromaxillary space, and also there was erosions in the left petrous part of the temporal bone. In the MRI, you can see the MRI seen here is T2 weighted fat enhanced image. You can see in the right maxillary sinus there is hyperintensity showing acute inflammation, whereas in the left maxillary sinus you can see heterogeneous enhancement. There is hypointensity including with hyperintensity, and there is also, you can see the periantral fat or retromaxillary fat shadow in the right side. It is healthy, that is enhanced, whereas in the left side there is hypointensity, signifying necrosis and presence of fungal elements in the retromaxillary region, that is in the pterygopalatine fossa and the infratemporal fossa. And the treatment done was preoperatively injection lamp was given at a dose of 5 mg per kg body weight for 5 days, and then surgical debridement was done with endoscopic modified Denkus approach, and postoperatively 14 days of injection lamp was given as per dose of 5 mg per kg body weight, and then he was discharged on tab posaconazole 300 mg BD on the first day up till 300 mg OD for 3 months. And even retrobulbar lamp was given. Endoscopic orbital decompression was done intraoperatively. Retrobulbar lamp was given with a dosage of 3.5 mg lamp every alternate day for 5 days. And the next case is of stage 3B. You can see the image of the patient. He was a 39-year-old male patient, came to ENT OPD with complaints of left-sided facial swelling, left-sided eye swelling, ptosis, and also loose tooth pain, and there was a palatal defect in his oral cavity examination. You can see the DNA images. You can see the blackish crust present over the inferior turbinate and also over the posterior wall of the maxillary sinus. He was already post-op. He was a post-op case. He was already operated for press outside. And you can see the palatal defect, which is of 1.5 into 1.5 centimeter. And CT scan showed bony erosions in all walls of the left maxillary sinus, ethmoids, and sphenoid sinus. And in the left pterygopalatine and infratemporal fossa, soft tissue lesions were present. And you can see in the sagittal cut, the hard palate. And the MRI PNS shows T2 hypointense signals from left maxillary ethmoid. And hello, sir.
Next candidate, please. So you are exceeded your 8 minutes time already.
Yeah.
Yes, sir. We'll call another candidate, sir. If they finish within the time only, please ask the question, sir.
My concluding results were, as per IHL, most common predisposing factor for the development of rhinoorbital cerebral mucormycosis is immunocompromised state caused by uncontrolled diabetes mellitus and lack of proper hygiene as well.
Okay, you can stop sharing.
Okay.
Done.
Next, Dr. Eileen Benny.
Hello, sir.
Yeah, please share your screen.
Sorry. Are you able to see, sir?
We cannot see your screen, madam.
Yes.
Sir?
Please start.
Good afternoon to all the respected chairpersons, judges, and colleagues. My name is Dr. Eileen, and I'm presenting a paper on outcomes and insights of management of parathyroid adenomas. Hyperparathyroidism is the third most common endocrine condition after diabetes and hypothyroidism. Primary hyperparathyroidism is characterized by excessive secretion of parathyroid hormones from parathyroid glands. The incidence is 2.5 in every 1,000 adults. Primary hyperparathyroidism is more prevalent in older adults and postmenopausal women, which highlights its demographic significance. Its etiology is attributed 80% to benign parathyroid adenomas, 15 to 20% to multiple adenomas or multi-gland hyperplasia, and 1% to parathyroid carcinomas. So many patients are symptomatic at the time of diagnosis, but symptomatic cases can lead to severe complications. The symptoms of primary hyperparathyroidism include that of hypercalcemia, osteoporosis, renal stones, and cardiovascular issues. The established treatment for symptomatic primary hyperparathyroidism is parathyroidectomy, which involves the surgical removal of the affected parathyroid tissue. Minimally invasive parathyroidectomy and bilateral neck exploration are the two surgical modalities for parathyroidectomy. So my objective here is to describe the clinical features and management strategies of patients with primary hyperparathyroidism. A retrospective analysis of cases diagnosed as primary hyperparathyroidism in a tertiary care hospital operated on in the past 3 years in the Department of ENT was performed. And for each case, we documented the clinical data, biochemical and radiological findings, as well as other relevant investigations, including the histopathological results. So my first case is a 51-year-old female who came with the complaints of recurrent renal stones for which a right nephrectomy was done. Her serum parathyroid hormone was found to be 185.7 picograms per ml. An ultrasound and sesame B scan was done, which suggested a right inferior parathyroid adenoma, for which she underwent excision. The intraoperative serum parathyroid hormone dropped to 41.83 picograms per ml. My second case is a 65-year-old female that presented to us with burning micturition on and off for the past 4 months. Her serum parathyroid hormone was 580 picograms per ml. The ultrasound and sesame B scan done showed a right superior parathyroid adenoma, and she underwent a right superior parathyroidectomy, and the intraoperative serum parathyroid hormone dropped to 46 picograms per ml. My third case, a 46-year-old female, came to us with a swelling in the anterior aspect of the neck, for which we did an ultrasound. The ultrasound showed a TIRADS 5 lesion in the right lobe of thyroid, as well as a well-defined hypoechoic lesion in the inferior left lobe of the thyroid gland. So we did a sesame B scan, which showed an abnormal uptake near the left inferior pole of the thyroid gland. The serum parathyroid hormone for this patient was 1,432 picograms per ml, and the patient underwent total thyroidectomy with left inferior parathyroidectomy, and the intraoperative serum parathyroid hormone dropped to 96.5 picograms per ml. The postoperative serum calcium was 7.7, and the patient was symptomatic, had symptomatic hypocalcemia and underwent treatment for the same. My next case is a 30-year-old female that came with joint pains for the past 6 months. Her serum parathyroid hormone was 674.9 picograms per ml. The ultrasound and the sesame B scan showed a right inferior parathyroid adenoma, for which the patient underwent right inferior parathyroidectomy. The intraoperative serum parathyroid dropped to 123 picograms per ml. My last and final case is a 62-year-old female who also presented with bone pain for 6 months. Her parathyroid hormone levels 1,138 picograms per ml. The ultrasound and cystoscopy B confirmed the diagnosis of left superior parathyroid adenoma, for which the patient underwent excision of left superior parathyroid adenoma. The intraoperative parathyroid hormone was 60 picograms per ml. So 5 patients were diagnosed as primary hyperparathyroidism, and the patients underwent a parathyroidectomy. The mean age was 50.6, and there was a definitive female preponderance where all my patients were female. 2 investigations were done for all the patients, an ultrasound neck and a cystoscopy B scan. And in all 5 cases, there was no discordance noted between the ultrasound imaging and the cystoscopy B scan. So the type of surgery done, 4 out of 5 patients underwent minimally invasive parathyroidectomy, and 1 patient underwent bilateral neck exploration, and the reason here being concomitant thyroid disease. So an intra-group comparison done between the preoperative and the postoperative calcium showed a p-value of 0.043, which was significant, and the comparison between the preoperative and postoperative parathyroid hormone showed a 0.007 p-value. And the postoperative symptomatic hypocalcemia was noted only in 1 out of the 5 cases, and this patient is one that went bilateral neck exploration. So surgical removal of the abnormal parathyroid tissue, that is your parathyroidectomy, is the optimal treatment for patients with proven primary hyperparathyroidism. So common approaches for minimally invasive parathyroidectomy involve open focal mini incision, a video-assisted approach, total endoscopic approach, or robotic surgery. A reduction in parathyroid hormone level of more than 50% from the highest baseline value at 10 minutes post-ligand ligation is generally considered as an evidence for adequate gland excision. Bilateral neck exploration is now utilized only when the preoperative localization of the adenoma is not possible in cases of discordant localization studies in the parathyroid imaging, familial or genetic disorders of primary hyperparathyroidism, and concomitant thyroid diseases. So this is an algorithm for the management of hyperparathyroidism. The diagnosis is made with the help of biochemical testing and symptomatology, and the patients undergo an ultrasonography and a cystoscopy B scan. If both are positive and concordant, then focused or minimal access surgery is done. If only one is positive, minimal access surgery with intraoperative parathyroid hormone or 2-gland ipsilateral excision is done. If they're discordant or both are negative, then we will go ahead with a bilateral neck exploration with intraoperative parathyroid hormone monitoring. When talking about bilateral neck exploration versus minimally invasive parathyroidectomy, the risk of postoperative hypocalcemia and recurrent laryngeal nerve injury is higher in the bilateral neck exploration group. A fall in serum calcium concentration is common in post-parathyroidectomy patients with hyperparathyroidism, but it usually resolves in 2 to 4 days. So a systematic review by Amida et al., the risk ratio for the success rate at 6 months in the minimally invasive group in comparison to the bilateral neck exploration group was 0.98. And the risk ratio for total incidence of perioperative adverse events was 0.50, which was in favor of the minimally invasive group. And the mean difference for the duration of surgery comparing bilateral neck exploration with minimally invasive group was in favor of the minimally invasive group by 18 minutes. So in conclusion, parathyroidectomy is the gold standard for primary hyperparathyroidism. 2 positive concordant studies are reliable in localizing the adenoma. And though the trend is towards minimally invasive surgery with intraoperative parathyroid hormone monitoring, bilateral neck exploration does have its own indications. These are my references, sir. Thank you.
Cases are good. And at the same time, you have done 5 cases, what you told me. Out of that, 3rd case, you did total thyroidectomy because of concomitant thyroid disease also. Yes or no?
Yes, sir.
Yes. And on table, you just commented the vascularity of the thyroid, the parathyroid must be identified. Then only selectively you have to remove it without any sort of deviation. Yes. How did you achieve that?
Sorry, sir?
Parathyroid blood supply definitely is a matter of concern now when you are going for a parathyroidectomy.
Yes, sir.
How did you manage that identification and other things?
So we identified the inferior thyroid artery first, and then from there we identified the branches that were supplied.
highly selective approach then, without
Yes.
compromising blood supply to the thyroid. Identification and incidence of recurrent laryngeal nerve involvement also is possible in this sort of situations.
Yes, sir.
Because there is usually it runs between superior parathyroid and inferior parathyroid.
Yes, sir. So we
Because one of
identified the recurrent laryngeal nerve also, sir.
Yeah, any sort of recurrent laryngeal nerve involvement you have encountered as a complication?
Sorry, sir?
Did you encounter any recurrent laryngeal nerve palsy?
We didn't. No, sir.
Sir,
What was the indication for total thyroidectomy?
Yeah.
Sir,
It was a unilateral problem.
actually, no, sir. I've only mentioned the thyroid spy lesion, but there were multiple nodules in both the lobes. It was a multinodular goiter. The others were thyroids 2 and 3. There were multiple nodules in both lobes of the thyroid, sir.
What was the post-op histopath?
Histopathology came as follicular nodular disease, sir.
So, do you do total thyroidectomy for multiple nodules detected only on radiology?
No, sir.
Which is
Patient
not clinically evident?
It was clinically, her complaints were swelling in the anterior aspect of the neck. She came with a swelling in the anterior aspect. So for cosmetic purposes, as well as the thyroid spy lesion, we went ahead with the total thyroidectomy. So.
What is the role of neck dissection in this case? What is the role of neck dissection? You told, no?
Yeah, yes. So.
Yeah.
I'm not very sure.
You're not sure, right? There is no involvement of neck nodes, no?
No, sir, there was no neck involvement of neck. Clinically, there were no nodes involved.
Yeah.
And even in ultrasound, there were no involvement of neck.
You meant exploration of neck or neck dissection?
Exploration of neck, so for the
But
bilateral exploration.
you said dissection. That's why the doubt.
Okay, no, sir, sorry.
When you say dissection, it is lymph node dissections.
Yes, sorry, sir. I meant explorations.
What is the, have you done any other workup? Because parathyroid adenomas can be a part of multi-endocrine neoplasia.
Yes, sir.
Any
Actually,
other workups done? You have not mentioned in your study.
okay, sir.
You should have told that workup done and some findings or no findings.
Okay, sir. No, 3 out of these 5 patients were referred to us from the endocrine department itself, sir. So they had already done their work, the workup from their side to rule out any other endocrine disorders as
First
well.
class, that is fine, but you should tell also.
Okay, sir.
So that it is isolated parathyroid
No. Okay, sir.
lesions.
Yes, sir.
Okay, thank you.
Thank you, sir.
Next, Dr. Juveria.
Yes, sir.
Dr. Juveria?
Sir.
Please share your screen.
Good afternoon, everyone. I'm Dr. Juveria. Sir, is my screen visible?
Yes,
Sir?
screen is shared.
Yes. My case series is about a comparative study of occlusive nasal packs and intranasal nasal splints after septoplasty.
Yeah, please proceed.
Yes. Just a second. Just a second. Coming to the study, here is the introduction. In our daily practice, we come across septoplasty, which is one of the most common operations in ENT department. Here, nasal packing is used primarily to control bleeding in all endonasal surgeries. Packing also helps in internal stabilization following operations on the cartilaginous or bony skeleton of the nose. Packing helps in preventing complications of septal surgery like hematoma, infection, and abscess formation. But but in packing, there are some complications like mucosal injury, sleep disturbances, aspiration of various packing materials, eustachian tube dysfunction, which occurs with packing group, which questions the wisdom of using this type of packing method. So in my study, the aim of the study is to compare the post-op results of regular nasal packing with that of transnasal septal splints. Here, the materials and the methods used were, the study design was a comparative study in which 80 patients were studied for a period of 12 months. The inclusion criteria included patients of both the genders between the age group 18 to 60 years with the deviated nasal septums. Here the exclusion criteria was patients with history of previous septal or turbinate surgery, patient using hemodiluting agents, patients with history of nasal polyposis, drug abuse, and the patients with bleeding diathesis and other medical disorders were excluded. The methodology here which was used was patients were divided into two groups, Group A and Group B. In Group A, it was the patients with the intranasal splints. Silicone septal splints were placed, fixed by 8 shaped transseptal sutures with 3,0-ethylene suture material, which were removed after 1 week post-operatively. In Group B, it was without intranasal splints. Here the regular nasal packing was done, which was removed after 48 hours post-operatively. Both the groups were followed up regularly at first week, third week, and second month post-operatively. Here is the bar diagram for pictographic representation. Here, the demographic characteristics of patients subjected to septoplasty is patient count mounted by age and patient count by gender. The blue represents the age group less than 20. 20 to 29 is the orange, gray one is the 30 to 39, and more than 40 years of age group is a yellow picturization. Here we mounted age with the patient like less than 25 patients were treated with intranasal splint. 20 to 29 years was 19 patients, and 30 to 39 were 12 patients, and more than 40 were 4. And without splint, less than 20 years are 5 patients, 20 to 29 are 20 patients, and 30 to 39 were 9 patients, and more than 40 were 6 patients. Next, coming to patient count by gender, 15 patients with splint were male and 25 were female, and 13 without splint and 27 with splint were female. These were the results. Early post-operative outcomes contrasted between the two included study groups. First one is by post-operative pain level, second was by sleep disturbance, and third were by the difficulty with food intake. These were all graded on basis of mild, moderate, and severe severity of the pain, disturbance of sleep, and difficulty by food intake. Results, coming to the results, late post-operative results at the fourth week, we assessed using adhesions, crustation, and perforation. For the patients with intranasal splint, adhesions were 0, without splint were 3, like for regular packing, and crustation was seen in patients, 2 patients, and without splint, crustaceans were seen in 4 patients. Perforations were not present in patients with intranasal splint, whereas 1 patient had perforation without splint. Coming to the discussion, our study showed the decreased risk of adhesion between septum and turbinates in splint group. As Schoenberg et al. And Campbell also showed the same thing. Our study showed nasal discomfort and sleep disturbances more with the splint group, whereas Abdul Khalik and Jung et al. Showed no variation in post-op pain and sleep disturbances. Our study showed no significant difference in rate of crustation, whereas previous study showed decreased rate of crustation in splint group. And there is no evidence of septal perforation, and it is in line with previous studies. This is a picture of intranasal splint. Coming to the conclusion, comparing the different techniques and based on the results of the study, septal splint suturing will have similar results to those from the nasal packing group from crusting and complication point of view. However, septal splint suturing results in less pain and discomfort for the patient. Based on these observations, the septal splint suturing technique is a valid alternative to intranasal packing following septal surgery. These are my references. Thank you.
Study is good. What about the post-operative? You have put a septal splint. No?
Yes, sir.
Because in the case of nasal packing, it is foolproof because all areas of injury are definitely treated with a nasal pack.
Yes, sir.
Approximation. Whereas in the septal splint, there may be little ooze or possibilities there. What is your observation? You are not done packing there. Just to put a approximation of the edges and put a suturing.
Yes, sir.
Silicone splints, no ma?
Silicone splint.
So is there any extra problem of oozing and other thing post-operative period of 48 hours or something?
Discharge
Nasal
was
pack is
present.
definitely superior over splints.
Yes,
You get
sir.
a patency of the nose, you can put a splint, thereby nose is not really packed. That is a possibility with a splint, yes or no?
Yes, sir.
So, are there any post-operative ooze or bleed with septal splint?
In a few patients, there was mild bleeding in the early 24 hours, sir, which was
Settled later on.
controlled, sir, which was controlled by either
Pinaxim or something you have put?
yes, sir. We put some
Nasal drops or sort of things?
yes, sir. We put Botroclot drops, sir. It was mild bleeding, sir. It stopped immediately, sir.
Pinaxim, that means ethamsulate also might have been added.
Yes,
As
sir.
an extra care with splints.
Yes, sir.
So you suggest to go for splints for a better tolerance.
Yes, sir. Like perforations were completely negligible, sir. Zero perforations when compared to other nasal packings.
And you said there's some difficulty in sleeping with the septal splints. Yes or no?
Yes, sir. Yes, sir. Patient was psychologically when consoled regarding that, patient improved, sir. Like if psychologically counseling was given, and patients were having anxiety issues, sir, after nasal splints.
So you attribute it for that rather than any nasal patency.
No, sir.
Okay. Suptanka sir, open for you, sir.
Now, the point which you raised, discomfort, other authors felt nasal pack leads to more nasal discomfort and a lack of sleep. But
Yes, sir.
your study shows
The
the
paradox.
splint different result, opposite. But in the conclusion, you are telling your results are same or like. But anyway, leave it. How did you customize the splint? Because the splints will come in a standard size.
Yes, sir.
Pediatric, adult, male and female type. So for your given patient, how are you customizing the splint, or whatever splint has come, you are just putting it?
Like for pediatric less than 15 years, we are using pediatric splints, sir. After external measurement and the amount of septal deviation the patient is having.
You have not got my point, because the whatever is the sizes the company provides is by Western standards. But whereas in India, those same one will be larger for the patient and it will be touching the roof of the nose. So are you looking for those things in those patients and then sizing it to the required size, or just you are putting it and suturing it?
Approximation we are doing, sir, like
You are putting it, but then you should do endoscopy and see where
bring
the
it to the
roof
situation.
is touching.
Okay.
Yeah. Okay. That may be the reason why there is a difference in your results from the standard.
Okay, sir.
Right. Thank you.
Thank you, sir. Thanks.
Okay, Dr. Bhavya.
Yes, sir.
Okay. You can share your screen.
Yes, sir. I'm doing.
Juvaria, you stop your sharing your screen.
Sir, I have shared my screen. Can you see it, sir?
Yeah, we can see it. Maximize it.
Yes, sir. Yes, sir. Good afternoon to everyone, sir. I'm Dr. Bhavya, JR2 ENT. I'm going to present a small, simple study of the outcome of septoplasty with or without inferior turbinoplasty in cases of obstructive sleep apnea, sir. My aim is to assess the outcome and compare between septoplasty with inferior turbinoplasty and plain septoplasty in cases of OSA in terms of nasal obstruction and quality of life, sir. Coming to introduction, nasal obstruction is the most common in patients with obstructive.
Move on to the next slide.
Sir, I'm sharing this. I'm changing
No,
the slides.
you maximize the slide, then only the slide will change for us.
Title is only seen.
Sir, it is in slideshow only, sir.
Slideshow. Yeah,
Sir,
now it is coming. No, you
Yes, sir.
maximize the slide.
Yes, sir.
Proceed.
OSA is intermittent complete collapse of pharyngeal airway followed by brief arousals or awakening. It is caused by recurrent episodes of partial or complete obstruction of the upper airway. Pathologically, nasal obstruction causes increased airway resistance, which leads to collapse of nasal walls, which contributes to the oropharyngeal collapse. So, nasal surgeries such as septoplasty, turbinate reduction, sinus surgery, and nasal wall reconstruction might help to relieve the nasal obstruction complaints. In my study, I'm calculating the efficacy of the post-op on the basis of Epworth Sleepiness Scale, sir. Obstructive sleep apnea arises from the collapse of the upper airway coupled with a muscle tone relaxation during sleep. Usually, this upper airway accounts for 2/3 of the entire airway, which extends down to alveoli. Hence, in my study, I will do the simple widening of the nasal valve and the entire nasal passage, which leads to the decrease in the negative pressure at inspiration during sleep and contributes to the improvement of the OSA. Septoplasty along with inferior turbinoplasty is an effective surgery to relieve the nasal obstruction. I will select the patients. My patient selection is based on the screening for OSA, and then I have to look out for my surgical findings, whether patient has deviated septum
Your
or any
slides
hypertrophy.
your slides are not changing. See, you maximize the slide, then it will automatically change. You maximize the slide. Probably you don't know.
Sir, in slideshow, it is not changing, sir. So I'm minimizing.
Fine, carry on. Then you have to keep on changing the slide. Continue.
First, I will do the patient selection, which is based on the clinical evaluation.
probably the patients, diagnosed patients with OSA who are having operative nasal findings, and then I'll go for DNA, diagnostic nasal endoscopy, and then CT scan, and then I will carry forward for my surgery. Basically, all these patients will be owing to a rhinogenic cause. This is Epworth sleepiness scale score. Based on this scaling, I will be calculating my pre-operative and post-operative outcome. Usually, the normal scaling lies between 6 to 10, 11 to 12 is excessive daytime sleepiness, 13 to 15 is moderate, and 16 to 24 is severe. My objectives are to study sleep-related quality of life in study population before and after septoplasty, with or without inferior turbinoplasty, and to compare outcome of septoplasty with and without inferior turbinoplasty. My inclusion criteria are adult age groups, usually above 18 years age, and then patients diagnosed with OSA, patients having septal deviation either with turbinate hypertrophy or without turbinate hypertrophy, and patients willing to participate in the surgery. My exclusion criteria, I will exclude all the patients who already had the previous history of nasal surgeries, who are on long-term usage of nasal drops or steroids, basically the rhinitis medicamentosa, and patients with craniofacial abnormalities and any other nasal pathologies like chronic sinusitis or enlarged adenoids. My sample size is 20, sir. It's a bit low because finding patients with OSA along with the nasal findings is a bit difficult, and the time period is for 6 months. And I have divided my patients into two groups, group A and B. In A, I have taken 10 patients for whom I will be doing septoplasty alone. And in group 2, I will be doing septoplasty with turbinoplasty. And then, sir, my interpretation, based on the age distribution, I have taken in group 1, the age group between 18 to 30 is 1, 30 to 56, and 50 to 60 is 3. And then in group 2, I have taken younger age group, like patients among the younger age group a bit more. And then older age group, I have taken nil. So the youngest patient in my study is 20 years, and the oldest one is 54 years. Average age for septoplasty in my group 1 is 30 years and group 2 is 26 years. Gender distribution, usually OSA has more male predominance, hence my patients are mostly male. Coming to preoperative Epworth sleepiness scale, so these are my findings. I will compare it with the postoperative score. And this is my postoperative score after 3 months, sir. There is improvement, like the significant improvement is seen by 30% in group 2, that is with septoplasty and inferior turbinoplasty, comparatively with septoplasty alone. And there is no worsening of any patients. And there is mild improvement of 50% in group 2, whereas there is 40% in group 1. Coming to discussion, intranasal surgery is currently regarded as important in order to improve compliance with treatment. Already patients will be on the treatment like CPAP and BiPAP, and doing this surgery will be an additional recovery for the OSA patients. And among the upper airway surgeries, septoplasty and inferior turbinoplasty is one of the best surgery and the easy surgery with good outcomes in OSA patients. Many studies showed better compliance after 3 months post-operative period. So coming to conclusion, 40% in group 1 had significant improvement in symptoms, whereas in group 2, the improvement is 60%. Hence, along with correction of the deviated nasal septum gives more improvement in the airway postoperatively in the OSA patients. And along with this, I have counseled my patients post-operatively to bring a change in their lifestyle. They have to do lifestyle modifications also, because most of them are obese, and they need to quit smoking. There are smokers also in my study, so I have counseled them to change their lifestyle adjustments also along with surgery. They have done so. So post-operatively 3 months, I have got better results with turbinoplasty associated with septoplasty than plain septoplasty. And there are no worsening of any cases.
Time
There is
up.
only better. Yes, sir. These are my references, sir. Thank you.
Bhavya, how did you divide the cases between the two groups? What was the criteria?
Sir, using stop bang questionnaire criteria, I have assessed the patients for
No,
OSA,
no. You have
and then I
assessed.
have.
How did you divide them into two groups? One into septoplasty, other into septoplasty and turbinectomy or turbinoplasty.
Sir, initial based on the age groups, mostly I have taken the like for suppose 18 to 20 years of 80 to 13 years of age group, I have
So
taken.
that you have used some bias for to compare two methods. All patients should be of similar type.
Yes,
You
sir.
have different type of patients for different groups, but end result you want to compare and say turbinectomy septoplasty is better. And already
Sir,
they and already these people are on CPAP and all. So which is the standard treatment? Is it the septoplasty or CPAP?
Sir, CPAP is the continuation treatment. Like they have to be on the CPAP for a longer time.
No, you answered the question. So when they have got CPAP, what is the indication to add a surgery? There is some indications when they are using CPAP. There is an indication to add some surgeries. What is that indication?
Sir, not all my patients are on CPAP, sir. There are patients without CPAP, healthy patients who presented to OPD with normal OSA symptoms like mouth breathing and snoring.
So mouth breathing and snoring you will call obstructive sleep apnea. That is the
No, sir, I have assessed their BME.
no. You have to do a sleep study. There's scoring.
Sir, actually, my
Oh,
patients are not affordable for sleep studies, so
then
I have excluded that and I have taken ESS scale because it doesn't need sleep study. I haven't gone for apnea, hypopnea.
Bhavya, your work is confined to nose. There are multi-level problems. Retrolingual, all aspects. Retropalatine, all aspects.
Yes,
So,
sir.
had it been in the
Yes,
only
sir.
nose with a rhinomanometry study or objective evidence, definitely the results would have been more supportive. That's what I feel. Sir, what do you say, sir? Sithankar, sir.
yeah, answer to my question is whenever you are using
Yes, sir.
CPAP, the air pressures required when it is goes above 20, the patient cannot tolerate those pressures. That means there is obstruction in the nose. So those people, you have to do surgery where required. Either it is in the nose or in the palate or based on wherever problem. So your title is misleading. The patients with and without both you have put, and only nasal obstruction and snoring is not diagnosed as obstructive sleep apnea. Both are entirely different. Otherwise, all DNS patients should be patients of sleep apnea. So
Sir, I
there
have
I
calculated the Mallampatti score BMA.
okay, leave it, leave that issue. You understood my question. That's it. Enough. From my side, I think close the discussion.
Yes, sir. Thank you, ma.
Thank
Thank
you.
you, sir. Thank you, sir.
Next presenter, Dr. Arya.
Yes,
N.
sir.
Nair.
Present, sir.
Ah,
Am I audible, sir?
yes, yes.
Shall I
Please share
present?
your screen.
Yes, sir.
Your slide share, please.
Sharing, sir. Is it visible now?
Not yet.
Yes. Okay.
Yes.
Yeah.
Visible. Yes, sir. Good morning, good afternoon, everybody. I'm Arya. My topic for today is pediatric airway surgery, our 10 years experience in managing pediatric upper airway obstruction in a single institution, a retrospective study. So, excuse me, sir. Okay. So what sets a pediatric airway apart? So when we talk about pediatric airway, the most common phrase that keeps coming up is that children are not small adults. So we are now going to evaluate why this statement is there as such. So in children, there is larger hair, shorter and smaller neck, prominent occiput, larger tongue, higher and anterior larynx, U-shaped epiglottis, and they have the narrowest level of airway at the level of cricoid as opposed to adults. We have it at the level of glottis, and that the trachea is funnel shaped. So what are the clinical presentations? Stertor, stridor, feeding difficulty, distress, aspiration, apnea, failure to thrive, difficult intubation. These are the common clinical presentations. And causes of airway obstruction can be divided into three, that is naso and oropharyngeal causes, laryngeal causes, and tracheal causes. Now, aim of my study is to review the etiology, management, and the outcomes of pediatric upper airway obstruction. And my methodology is that it's a single institutional retrospective cohort study consisting of 172 consecutive pediatric patients with upper airway obstruction within a period of 10 years, that is 2014 to 24. Outcome measures are mainly measured through decannulation and the absence of stridor. Of these, decannulation is taken, it's given the focus as it's more objective. So how do we go about with these cases? First of all, we get a call from another department, a consultation call saying that there are some of any of the presenting complaints, or these children will come to the OPD with these presenting complaints, and we evaluate the patient clinically, either by the flexible scopy and then we plan for an airway evaluation under GA. And then further plan for the procedures comes after the result of the airway evaluation under GA. So this everything is a multidisciplinary approach to patient care, as we need the concerted efforts of anesthesia, cardiology, neonatology, pediatric intensivists, and pulmonology to achieve a better result. And we also have to counsel the caregivers as per the need for multiple surgical procedures for these children. So here's a flexible laryngoscopy setting. And here is a micro laryngobronchoscopy setting in the operation theater. We have a Parson number 2 direct laryngoscope that's inserted and suspended so that the surgeon can have bilateral, both hands are accessible. And we also have a microscope right here. What's the inclusion criteria? Pediatric patients with clinical diagnosis of upper airway obstruction presenting during the period of 2014 to 24 are included in this. Pediatric patients, as in the patients with age less than 18 years according to IEP classification. And these are our results. So, source of the data is Institutional Electronic Medical Registry from the year of 2014 to 2024. And we had a total of 172 patients, out of which we have noticed that infant males presenting with stridor is the most common presentation. And the number of patients requiring surgery is 96. And total number of procedures done from 2014 to 24 is 136, which shows that some of the patients have had multiple surgeries done for them. Now, total number of cases with airway obstruction was 172, out of which the most common cause was supraglottic, followed by subglottic and glottic causes. Supraglottic causes, out of supraglottic causes, laryngomalacia was the most common cause, with extralaryngeal causes such as valvular cyst, etc., also contributing to the same. Okay. Here we have 3 videos of laryngomalacia with short AE4, tubular epiglottis, and also the arytenoid mucosa prolapsing into the airway. And here we have choanal atresia of the left side of the nose, left nose, and valvular cyst being coagulated. Glottic causes contributed, out of the glottic causes, 36% was contributed by bilateral vocal cord palsy, followed by glottic stenosis and unilateral vocal cord palsy. And here we have bilateral vocal cord palsy and laryngeal web right here. Here we can see the false cords are adducting, but then on further inspection, we can see the true cords are immobile. And subglottic causes, there were 63 cases, out of which subglottic stenosis was the most common cause, then followed by tracheomalacia and subglottic hemangioma. Subglottic hemangioma, you can see here, there's some reddish lesion here. This is a subglottic hemangioma. It is mainly managed by propranolol therapy. No surgical procedures were done for these children. And then subglottic stenosis, here we can see a little bit of opening, while in grade 4, it's completely occluded. The classification we have followed is Lossy airway classification. And in out of the 136 procedures, single procedures were 55, while multiple procedures done for the same patient, that is 81. Now, total surgical procedures, we had the most number of surgical procedures that we did for these children were tracheostomy, followed by array epiglotoplasty, then serial dilatation, followed by laryngotracheal reconstruction. And tracheostomy, out of the 32 tracheostomies we did, the most common cause contributing to the need of tracheostomy in these children was subglottic causes, subglottic stenosis, followed by bilateral vocal cord palsy, and then glottic stenosis. Array epiglotoplasty was done for 30 children, out of which 15 of them also had glossopexy done for them. Serial dilatation was done for 26 children. Out of these, 15 were done with traditional dilators like Savary dilator and Hegas dilator, while towards the end of like 2018-19, we started using balloon dilatation for these children. And after that, we have been, now we are using only balloon dilatation. And for 11 of these cases, balloon dilatation has been done. Mortality was 5%. And post-operative complications were also noted. So post-endoscopic right cord split surgery, one of our child developed posterior glottic stenosis and underwent post-right cord flap advancement. And then PCTR, cricottracheal resection, had failed anastomosis in 2 cases. Revision was done and one developed unilateral vocal cord palsy and had to be re-tracheostomized. And then laryngomalacia, post-array epiglotoplasty, one child developed supraglottic stenosis and is planned for flap advancement. Another child developed transient dysphagia after surgery. One infant with congenital heart disorders had subglottic stenosis. Undergoing anterior tricuspid during that time, he had a graft failure and fistula following posterior pressure ventilation, which was needed for his impaired pulmonary function and further required tracheostomy. So the discussion, out of 32 patients, 25 tracheostomized. Out of the 32 tracheostomized patients, the 25 were decannulated, that is 75%, 7 cases not decannulated, out of which 5 are under follow-up and 2 have expired. And we have seen that surgery-specific decannulation rate is better for tracheostomy alone. And then comparing our decannulation rates with that of other institutions, ours is a 75%. In 2023, Lausanne had published 44 years of results showing 90.7% of decannulation rate. Great Ormond Street has a documented 54.8%. Hospital for Sick Children, University of Toronto has a 92%, and Auckland Starship Children's Hospital has an 83.5%. So in conclusion, the most common surgery performed was tracheostomy for subglottic stenosis. Second most common surgery was array epiglotoplasty for laryngomalacia. Third most common surgery performed was serial dilatation done for subglottic stenosis. And then single procedures were done for grade 1 subglottic stenosis. Multiple surgical procedures were required for subglottic stenosis, posterior glottic stenosis, and bilateral vocal cord palsy. Multiple surgical procedures for mainly grade 3 and grade 4 subglottic stenosis. And then we have noted a significant improvement in prognosis after surgery. So here I have included 2 videos of our children undergoing decannulation after years of tracheostomy. So indeed, their smile in the faces of the children and their parents are totally worth all this trouble that we go through with pediatric airway surgeries. Here are my references. Thank you very much. That will be all. Yes, sir. I'm done, sir.
Okay. Good presentation.
Thank you, sir.
Varied cases, and
Yes,
the most out of this, the most difficult will be the subglottic stenosis, right?
Yes, sir.
So
Yes.
in all cases, you did initially tracheostomy, then
No, sir.
did the other procedures.
Initially, depending on how the child is presenting, if the child is having very serious cases of like distress and cannot thrive at all, then we did the surgery. Otherwise, if the child could manage, as in grade 1, grade 2, they were not tracheostomized. But in grade 4, we have tracheostomized almost all the patients who presented with this.
Right. When the patient is having a cardiac problem,
Yes, sir.
congenital cardiac issue,
Yes, sir.
you will prefer cardiac to be treated first or subglottic stenosis to be treated first?
During such cases, we do like concordant surgery with them, along with them. So during the procedure, sometimes these children get tracheostomized along with their cardiac procedure itself, sir. Otherwise, we would like the cardiac
is by
issues.
GA. For GA, you have to do tracheostomy,
yes, sir.
definitely. So
Yes, sir.
that is a part of initial treatment, but how much time gap you will give after the heart disease has been set right? Will you do in the same same sitting the subglottic treatment also, or would you like to, or you are staging it?
Sir, what I have seen in a couple of cases through this retrospective study is that once the cardiac surgery has
No,
done
your
and
case,
finished,
you had a case.
yes, that is. Yes, we had. This is a retrospective study, sir. So I haven't actually seen during my period any of these patients. I have taken from the EMR, Electronic Medical Registry. So
Fine.
I've seen, yes, sir. So I've seen one of these patients has undergone the surgery and post-operatively on 78th day post-op, when they tried to extubate the child, they couldn't extubate. That's the time when they realized that there's possibly some underlying airway obstruction, and they called us for an evaluation. We found that the child is having subglottic stenosis, and then we tracheostomized the child during that time.
So it was actually initially intubated successfully,
Yes,
but re-intubation for a post-op problem they were not able to do. So
Yes,
that was probably a marginal congenital subglottic, became, I think, iatrogenic
after
grade
multiple
3 or
intubation. Yes, sir.
4 subglottic stenosis.
Yes, sir.
Okay. So when do you do the anterior split and posterior split? When do you put some graft material? When you don't need to put a graft material in the cricoid splits?
Anterior cricoid split is done when the child, when the cricoid.
No. My question is,
When,
after the split, some cases you need to put a graft. Some cases you don't need to put a graft. So, any idea? If you know.
My belief is that the arytenoid fixation will be checked, and if the arytenoid fixation is there, then we put the
Nothing to
graft.
do with the arytenoid.
Okay, sir. Okay, sir. I don't know,
It
sir.
is the subglottic stenosis.
Cricoid related.
Cricoid related.
Okay, sir.
So sometimes you put a graft, sometimes you don't put a graft. Does it have anything with the recurrence or with the staging?
I don't know, sir.
You don't
Okay,
know.
I'll pass that question.
Okay. So what is the type of surgery done for laryngomalacia in your cases?
Array epiglottoplasty, sir. Just the trimming of the mucosa, and then sometimes we do glossoepiglottopexy too. That is cauterization of the base of the tongue and the lingual surface of the epiglottis, and sometimes we suture that epiglottis to the base of tongue as well.
You don't trim the epiglottis tip?
Yes, sir.
Do you trim the epiglottis tip?
Only in very minor
Depending
cases,
on
but mostly we don't trim the epiglottis tip, sir.
Depending on situations.
In cases with prolapsing epiglottis into the airway, yes, we have done that for certain patients. One of our patients had that issue. Yes, sir.
What about subglottic hemangioma you are talking about? Do you find any
Subglottic
problem?
hemangioma, we usually manage here with propranolol therapy, sir. Like 1 to 3 mg per kg dosage is given, and then evaluate. First, initially, we admit the patient and evaluate for them for any development of tachycardia or any other issue, hypertension, etc. And then if they are completely stable, then we follow with that propranolol therapy. That regime is followed.
You are happy with it? Medical management?
Yes, sir. Actually, there is a tremendous response to propranolol.
How many months you use?
Around 12 months, almost. Until the lesions are settled and everything is stable, we continue using it. That is almost around 1 year.
You are having confidence on the propranolol rather than sclerosing agent?
Yes, sir. Yes, sir. From the results, we are having confidence on propranolol.
Because decannulation is a very important problem. Difficult problem is failed in the case of pediatric airway management. Once you go for tracheostomy, that's one of the toughest situation.
Yes, sir. Yes, sir.
Did you modify any sort of tracheostomy modifications for in pediatric route? Some flap or something like?
We had actually 2 failed decannulations, of which one child we had to re-tracheostomize the child again with a stoma revision, and another child post LTR the anastomosis didn't hold, and we had to re-tracheostomize that child as well. So yes, there were cases where we had to give up trial of decannulation, and it was pretty upsetting.
See, it is not the decannulation. The question is any modification to the tracheostomy as compared to adult in this 1 year age group patient. What is the, because the accidental extubations are more common in this age group. How you
Maturation
are
switches.
preventing it? Any modification to the actual stoma you are adopting?
We usually do maturation sutures where the epithelium, skin is also sutured along with the rest of the mucosa, so that it will stay in place.
Do you
And
excise a part of the cartilage?
not really, sir. I haven't seen that being done. No, sir.
Do you give a horizontal cut or a vertical cut?
I have seen horizontal cuts only, sir.
Not very
So
sure.
please go
Not
and,
sure. Not very sure, sir.
Please go and read what are the
Yes, sir.
modifications required in such
Yes, sir.
small children.
Actually, children, pediatric tracheostomy itself is a difficult entity. We have to have some modifications from routine.
Yes, sir. We'll read up on that, sir.
Okay.
Thank you so much for the question, sir.
Thank you.
Yeah.
Thank you, sir. I have finished.
Next, Dr. Sharanya.
Hello, sir.
Okay, ma'am. Please share your screen.
Visible?
Yes.
Not, yeah, now.
Visible.
Ah.
Good afternoon, respected faculties and my dear friends. Today I am Dr. Sharanya, second year END resident. Today I am going to present my case study on comparative study of the efficacy of myofunctional exercises in improving the apnea-hypopnea index in obstructive sleep apnea syndrome.
Yeah, continue.
Yeah, go with your topic now.
OSA is a health problem worldwide. It is associated with comorbidities like cerebrovascular accidents, arrhythmias, and hypertension. Polysomnography is a standard diagnostic tool. The severity of the OSA is based on apnea-hypopnea index. OSA is managed conservatively using mandibular advancement devices, tongue retaining devices, weight loss, sedatives, and surgical intervention. Continuous positive airway pressure is the gold standard treatment in managing OSA.
Please change your slides.
Myofunctional.
Please change your slides.
Slides are not moving.
Okay. Myofunctional therapy is a tool to diagnose the. Myofunctional therapy is a tool to improve the tonicity of the upper airway dilator muscle.
Sharanya?
The objective of my what, sir?
Full screen, please.
Full screen.
Have you shared your presentation or last laptop? Better you share your laptop and present your presentation.
Sir, is it visible?
Full screen.
Full screen.
Full screen. Go down. There is
Go
a
down.
placement.
Yes.
Sir, is it visible?
Yeah, it is not full screen, but if you can you show us the slides, then they are not automatically changing.
Your voice is not there now.
Sir, is it visible? The objective of my study. The objective of my study is to study the efficacy of performing the myofunctional exercises. The objective of my study is to study the efficacy of performing the myofunctional therapy to evaluate the subjective rating using EPSA sleepiness scale scoring system and Pittsburgh Sleep Quality Index. My study was a prospective observational study conducted in the Department of Otorhinology in the time period of 2020-2024. These are my selection criteria, inclusion criteria and exclusion criteria. Sir, is it visible?
No.
Slides are not moving now.
Now is it visible, sir?
No.
No, sir.
Yeah, it's visible now.
And these are the
Yeah.
inclusion criteria and exclusion criteria. Materials and methods. I used Airway Gym mobile app, pictorial chart of functional exercises, ESS and PSQA questionnaire, stop bank questionnaire. In my study, the patient diagnosed with mild and moderate OSA with flexible endoscopy suggestive of tongue-based collapse. They are subjected to myofunctional therapy using a pictorial chart and app for at least 90 days. The sleep score were assessed at the prior and at the end of study, and regular follow-up of the patient was ensured. Sample size. The sample size, since there was no previous study which relates to the efficacy of performing the myofunctional therapy in OSA, my sample size was calculated on the basis of the pilot study of 6 samples within 3 months. This is statistical analysis. Sir, is it visible, sir?
Yes, yes.
Gumoris proposed orofacial myofunctional therapy as a method for the treatment of OSA. Myofunctional treatment in sleep disordered breathing. Myofunctional therapy uses isotonic and isometric exercises of the oral and the oropharyngeal muscles. It provides a better stability of the stomatogenetic system to correct the muscle imbalance and the tonicity. Myofunctional therapy promotes the nose breathing, tongue resting against the hard palate. It improves the function of the breathing, mastication, swallowing, and speech. It facilitates the opening of the airway by improving the adherence to continuous positive airway pressure. These were my results. The pre-BMI, we are comparing the mean values of the BMI. Pre-BMI was found to be reduced to 24 after exercise. The pre-HA was 10, which was reduced to 6 post-exercise. The pre-ODA 11 was reduced to 4 post-exercise. The pre-ESS score, the mean value was 11.17, was reduced to 9 post-exercise. The pre-PSQ score was 7, was reduced to 6 post-exercise. In my study, there are 4 males and 2 females. The p-value of the ESS score, which reflects the subjective improvement of the patient, was found to be less than 0.05, which was found to be statistically significant. But the mean value, but the p-value of the ODA, AHA, BMI, and PSQ score was found to be more than 0.05. This is the graph showing the comparison of the pre and the post comparison of the ESS score, PSQ score, and AHA score. Discussion. In 2070, the first application to treat the myofunctional therapy was developed. Initially, the app was named as Apnea By. Later, it was changed to Airway Gym. The Airway Gym app comprises of 9 isotonic and isometric exercises that use proprioceptive training to strengthen the oral and the oropharyngeal muscles. These are the exercises in the app: the chromatic snake exercise, the tongue to left cheek, there is tongue to right cheek, and chameleon down exercise, chameleon down up exercise, left mandibular pressure exercise, right mandibular pressure exercise. This shows the snake exercise in the Airway Gym app. Due to hygienical reasons, a clean film or a white transparent film is placed over the smartphone and the patient will do the exercise. This is chromatic snake exercise in the Airway Gym app. Before each exercise, an animated demonstration and a video show the patient how to perform the exercise, and the user can follow the patient's progress of the daily progress of their activities over time. After performing the exercise, the patient receives a feedback of their success performance as a point source. And even if the patient forgets to perform the exercise, the app will give a reminder every 5 days. This is the picture of a patient performing myofunctional exercise. Participants instructed about the use of the app and the exercise to perform for 20 minutes daily. Follow visits occurred after 3 months. At these visits, all the variables were measured again and the questionnaires were completed. And the patient were asked whether they were using any other therapies. Using the Airway Gym app, the patient interacts with the screen of the smartphone using a sensitive plugin. The app provides an acoustic, mechanical, visual feedback about the accuracy of the exercise performed on a daily and a monthly basis. Research by Gumoros et al. Showed that there was a certain percentage decrease in the AHI and the significantly reduced neck circumference. But according to studies of Diaferi et al., there was no change in the neck circumference in patients using myofunctional therapy. And the limitations and conclusion. My study started with 10 patients, 4 were dropouts due to low adherence. And the limited study of 6 patients showed definite improvement in the symptom of the patient. However, myofunctional therapy doesn't need to be standalone treatment. It has to be associated with weight loss program. The option of CPAP should always be given to these patients and longer the exercise so that in future, if they drop out to the CPAP usage, they will still get benefit from the exercise. Take-home message is that most of the existing mobile health apps focus on diagnosis of snoring. None focus on the treatment of OSHS. Few are designed to promote the adherence to CPAP. Mobile technology may be valuable in treating the OSHS because of its potential to promote patient empowerment and self-management. These are my references. Thank you, sir.
It is something new, and at the same time, all your exercises relates to oral cavity and tongue only. Other areas are not having any sort of involvement. It doesn't have much of role. All the exercises related to oral cavity and tongue.
Oral tongue exercise, palatal exercise, facial exercise, abdominal breathing exercise, all included in the pictorial chart, sir.
Okay.
We are using both the app and the pictorial chart. We are giving both of them.
Okay. And second is your BMI is also matter, which will influence the outcome.
Yes. As the BMI decreases, there was much improvement in the patient.
Okay. What about the tolerance of the CPAP is better after these exercises?
We are selecting patients without using CPAP, sir. But after the exercises, there was better. The patient was able to use CPAP better because of difficulty. Also, some were not using. In our study, we are not taking patients who were using CPAP. But after the exercises, as the improvement of the tonal muscle increased, then they were able to tolerate.
By doing this sort of exercises, improve the tone of the muscle. And what about, did you say any sort of postural so-called counseling to turn towards the left or something, or right or something, along with these exercises?
No, sir, only the pictorial chart I explained and the airway gym map exercise.
Of course, the very purpose of doing this sort of exercises are to improve the tone or something like of the oral cavity and tongue only, nothing beyond it. What I feel.
Okay. Now, after the one odd question. After this therapy, what objective assessment was done to know that the base of tongue is not falling backward or what?
Objective evidence.
Only the tone was.
How do you tested the tone? That is my question.
Because their instrument was there to measure the tone, but it was costly, so we didn't use this instrument in our study.
No, is there any other method to know the tone of the muscle? Means whether it is falling back or not. What are the? How do you test? How do you assess the oropharynx? Is there any scopy and all?
By Muller's maneuver, initially when the patient came to the OP, we do flexible scopy, and with Muller's maneuver, we were able to assess if there was tongue-based collapse and all. But we are not able. We didn't measure the tone and all. In the study which was conducted in Spain, there was an oral performance.
Okay. What prevents you from doing this test in the post-exercise
period? Muller's test would have been done.
Okay, sir.
That is simple.
Okay, sir.
You can do it and compare.
Okay, sir.
Muller's maneuver.
Okay. So this is a adjuvant to people who are not tolerating CPAP or very mild Only snoring people without OSA. I take it as that way. Right? So, because why I'm asking is, if it is a moderate or severe OSA, without giving CPAP, giving this treatment for 3 months is not ethical.
Okay.
Yes, sir. That's why I asked you tolerance levels of CPAP. Maybe improve.
This doesn't reduce the snoring, sir. Patient came with excess daytime sleepiness and also. And after doing the sleep study, we will be able to know the AHA and compare the AHA. Because after doing the exercise, they said that the sleep quality was better and they benefited from the exercise. And the snoring didn't decrease and also only the sleep quality and the.
So it is more of objective assessment, not with any corroboratory investigation, just a history. Right. Right. Okay.
Thank you.
Thank you, sir.
Thank you, sir. Nice presentation. Next, Dr. Ramya.
Sir.
Sharanya, stop sharing, and Ramya, you can share.
Okay, sir.
Sir, audible and is my screen visible, sir?
Yes, full screen, please.
Already done, sir.
No. Yeah, now, yes. Yes.
Can I start now, sir?
Yes,
Please.
yes, start. Don't waste time.
Good afternoon, judges. I'm Dr. Ramya, and today I'm going to present a case series on the surgical impact on the middle ear function, that is the outcomes of adenotonsillectomy in children. Objectives. This study aims to evaluate the improvement of middle ear function following adenotonsillectomy in children diagnosed with adenotonsillar hypertrophy. Specifically, the objectives are to assess the changes in middle ear pressure, auditory thresholds, and overall hearing quality post-surgery. Methodology. This prospective study was conducted in a tertiary care hospital for a period of 6 months on a cohort of 30 pediatric patients aged between 5 to 15 years who underwent adenotonsillectomy for adenotonsillar hypertrophy. Preoperative assessments included tympanometry, pure tone audiometry, and otoscopic examination to evaluate the middle ear function and hearing status. Post-operative evaluations were performed at 1, 3, and 6 months following surgery. The data collected was statistically analyzed to determine the significance of improvement in the middle ear functions. Results. Post-operative assessments reveal a statistically significant improvement in the middle ear pressure as well as the auditory thresholds. Tympanometric results showed that a reduction in the incidence of middle ear effusion, with approximately 80% of the patients displaying normal tympanogram findings at the end of 6-month follow-up. Pure tone audiometry results, they demonstrated an average improvement of 15 decibels in hearing thresholds, indicating there was enhanced auditory function. This improvement was more pronounced in patients who are having preoperative middle ear effusions. Gender distribution of my study population, it was having a slight male preponderance, with males contributing 56.6% and females contributing to 43.3%. Age distribution, most of the children, they were between the ages of 9 to 12 and 13 to 15, whereas only 8 patients were between 6 to 8 years of age. Symptom profile, most of the patients, almost 28 patients, they were complaining of snoring or mouth breathing, which accounts to 93.3%. The next common complaint was hearing loss. It was seen in 14 patients. Dysphagia or throat pain, it was seen in 12 patients. Ear block was present in 10 patients, and upper respiratory tract infections were seen in 8 patients. Tympanometric curve type, preoperative versus postoperative. Among the 60 years examined, out of which 9 years examined showed tympanometry A curve, whereas 19 years examined showed tympanometry B curve, and 32 years examined showed tympanometry C curve preoperatively. Whereas postoperatively, in the first month postoperatively, type A tympanometry curve is seen in 23
years examined, and type B is seen in 5 years examined, and 32 years examined, type C was seen. Post-operative 3rd month, type B curve was not seen in any of the cases, whereas post-operative 6th month, approximately 80%, that is 48 years examined, showed type B temperamentary curve. This is the graphical representation. Coming to the pure tone audiometry, pre-operatively, less than 15 decibel hearing loss was present in 9 years examined. 16 to 25 decibel hearing loss was present in 21 years examined, and 26 to 40 decibel hearing loss was present in 30 years examined. By the end of 6 months post-operatively, 56 years examined showed less than 15 decibel hearing loss. Average hearing loss, pre-operatively, it was 28.1 decibel hearing loss, whereas post-operatively 1 month, it was 22.05. 3 months post-operatively, it was 17.4. Post-operative 6 months, it was 13.4. So average hearing improvement is 14.7 decibels. Here we can see there was significant decrease in the hearing loss. Discussion. One well-known risk factor for eustachian tube dysfunction is middle ear effusion in children. One well-known risk factor for eustachian tube dysfunction and middle ear effusion in children is the possible occlusion of eustachian tube orifice by hypertrophied adenoid tissue. We should start treatment using antibiotics, decongestants, and anti-allergics. However, in children in whom these symptoms greatly continue or worsen, or who do not respond to medical therapy, they must undergo surgery. 30 children between the ages 5 to 15 were a part of our study on whom adenotonsillectomy was performed. Similar to our findings, a prospective cohort study by Kayat et al. Revealed that adenoid hypertrophy was most common between the ages of 5 and 10. Fujioka et al. Study found that adenoids attain their maximum size between 4 to 8 years of age, after which they regress gradually till the age of 12 years. According to a study by Brook, the adenoid appears most commonly in the 7-year-old range, but our study finds it to be in between 12 years. Kayat et al. And similar other studies show the male preponderance. Our study also has a little male preponderance compared to females. In this study, tympanometry's type C curve is more in number than type B curve, indicating eustachian tube blockage to be more than the middle ear effusion. Whereas Fulo-Nicholson's categorization from 1983 finds type B curve to be in majority. According to Sharma et al., the mean decibel gain at 7 weeks was 4.5, and at the end of 6 months, it was 3.5 decibels respectively. But in our study, the mean hearing gain post-operatively, at the end of 1st month, it was 6.05. At the end of 3rd month post-operatively, hearing gain was 10.69. And at the end of 6 months post-operatively, hearing gain was 14.7 decibels. Conclusion, adenotonsillectomy is effective in improving middle ear function in children who are having adenotonsillar hypertrophy. The significant reduction in middle ear effusion and subsequent improvement in auditory thresholds underscore the benefit of this surgical intervention. These findings support adenotonsillectomy as a viable treatment option for addressing middle ear dysfunction associated with adenotonsillar hypertrophy in pediatric population. Thank you one and all for giving me this opportunity. These are my references. Thank you.
Okay, good study. And did you do grading of the adenoid hypertrophy, Amma? Are you
Grading of adenoid hypertrophy? Yes, sir.
Did you do it?
Yes, sir.
Did you do it or not?
We have done, sir. Grading of adenoid hypertrophy by Clemens and McMurray's classification. Most commonly, in my study, they were. Sir.
No, that is no mention of it is in your slides.
I have not. Only symptoms I've kept, sir.
No matter, because even that also matters in the final outcome, no?
Yes, sir. I'll try to include in next time, sir.
Okay, good study otherwise. So you always recommend for a better hearing improvement in all affected cases. That's your conclusion.
Yes, sir.
In your study, what I have seen is less than 50% of the people complained. I think 40 plus people complained hearing loss.
14,
But
yes, sir. 46%.
46%.
Yes, sir.
But more people had type B and type C tympanometry on presentation.
Yes, sir.
So they are, I think, more than 60% or so.
Yes, sir.
So
I'll
how do you relate to those people having no hearing loss clinically?
Yes, sir.
And only tympanometrically there were findings, because audiometrically you have you done audiometry and seen when there is no hearing loss also, do they have any hearing loss?
Yes, sir. Preoperatively also on audiogram.
So what is the correlation? That's what I am trying to tell. What is the correlation in those people who did not have hearing loss clinically, I mean by history, but audiometrically they had, what was the type of impedance? Any cross correlation was done?
They
No.
were not
Okay.
having any hearing loss as such, sir. But on impedance,
But
they
you
were
have done
scoring.
audiometry. You have done audiometry. Okay. So in all
Yes, sir.
cases, you have done impedance.
Yes, sir.
So
Yes,
you
sir.
can see in those patients what was the audiometry. Okay, fine. The second point is, in 20 people or 20%, still they continue to have type C.
Type C. Yes, sir.
So what was the cause? You have done the adenotonsillectomy, type C is there. That means they are liable to have ear issues in future. What
Yes,
may
sir.
be the cause in those? Did you assess?
In spite of doing
In
Most probably they may still be having, even after adenotonsillectomy, they were kept on sprays, sir.
So in other
Mometazole.
words, no. In other words, you should know the reason to give treatment. In other words, I will look for other causes for eustachian tube dysfunction other than just presence of enlarged adenoids.
Do you know something related to eustachian tubes? Bacillus eustachian tube, all sort of things.
Sir,
Stenting
can
of
you
the
please
eustachian
repeat
tube.
the question? I'm sorry, sir, I cannot hear it.
Sir is asking, is there any eustachian tube pathology? In spite of doing your adenotonsillectomy, C-type is persisting. Yes or no?
Yes, sir.
Yes. So,
C-type is persistent.
so any sort of remedy is possible, like eustachian tube. What could be your
So
diagnosis?
those 20% of people, you should assess what is the cause. Is it inflammation, allergy, or the anatomical disturbances in the eustachian tube, submucosal cleft? All these things have to be ruled out.
Okay,
Okay.
sir. Okay, sir.
Right. Thank you.
Thank you so much, sir. Thank you.
Good topic. Common topic.
Sir, next, the pending candidate, sir. Dr. Mukesh, 41 serial number.
Good afternoon, sir.
Yeah. Go ahead.
Good afternoon.
Share your screen.
Yes, sir.
Screen.
Yes,
And
sir.
also your video.
Yes, sir.
Turn on your video.
Sir, am I visible, sir?
Yeah, you go ahead.
Sir, my presentation is visible?
Yes, go ahead.
Yes. Sir?
Yes.
Good afternoon to one and all present here. Myself, Dr. Mukesh, here to present a case, CSF rhinorrhea case series, our 1 year of experience. CSF rhinorrhea is caused by an abnormal communication between the subarachnoid space and the nasal cavity. Here is the Omaya's classification showing the traumatic and the non-traumatic leak, of which we have mainly dealt with the benign intracranial hypertension, accidental causes, and the iatrogenic causes. Our cases, 10 cases done between 2023 to 2024 June, which consist of 9 females and 1 male, and of which 8 had spontaneous leak and 2 had traumatic leak. And these are the various approaches we had used. And Haddad flap was preferred over the mucosal graft, and the diagnostic lumbar puncture was done to monitor ICP, and the acetazolamide was given to reduce the ICP both pre-operatively and post-operatively. And all the cases had good post-operative outcome without any recurrence. And these are the sites of leak, of which lateral lamella of cribriform forms the 40% of the leak, and followed by lateral recess of sphenoid, which forms 20% of the sites of leak. And this is how we investigate the case. To confirm CSF and to identify the cause of leak, we do clinical examination, thyroid function test, fundus examination, diagnostic lumbar puncture, CSF analysis, and the diagnostic nasal endoscopy. And to locate the site of the leak, we do MR cystonogram, CT cystonogram, and along with DCT bone window cuts, of which the investigation is done. We had certain findings, of which 87.5% of patients had spontaneous leak, had BMI more than 30, about 30, and thyroid function test in 2 females revealed hypothyroidism in the spontaneous leak cases, and one of the spontaneous leak cases had findings consistent with idiopathic intracranial hypertension in the fundoscopy, and the routine CSF analysis were done, and none of them revealed any organisms, and CT and MR cystonogram were done according to the case which we do. And neurological and neurosurgical opinion were obtained if it is necessary, and we have proceeded with the cases. Our 48-year-old female is the first case with a lateral lamellar defect with a meningocele, and the case 2 is a 20-year-old female with raised ICP changes showing bilateral cribriform defect, and the post-operative DNA picture confirms the same and is beautifully been repaired. And the 28-year-old female with an iatrogenic leak in the right cribriform plate is case 3, and the case 4 is a 43-year-old female with a meningocele having bilateral cribriform defect. Case 5 had the posterior ethmoid roof defect, and the case 6 had left lateral recess meningocele, which is evident in the CT picture, and which is being shown in the images, and the free mucosal graft has been used. And in this case, we have approached via the transpterygoid approach. Case 7 is a lateral lamella of cribriform plate defect, and case 8 is again lateral lamella of cribriform plate defect. And case 9 is a CSF leak from the lateral lamella of cribriform plate, and case 8 is the one which shows the good uptake of the Haddad vascularized flap. And this is the summary of the cases which we have done. This is a short video clip of the patient which we have operated via the transpterygoid approach to the lateral recess defect. This is the CT image showing the lateral recess defect. And recess defect with the meningocele has been visualized, and the drilling of the pterygoid plate has been done. Meningocele is seen in the lateral recess, and the defect is identified, and the fat is plugged, and it is closed with a free mucosal graft. Moving on to the next video, this is a case of transnasal approach to the bilateral cribriform plate defect, and here is the video showing the cribriform plate defect. And here we could see the leak. And in this case, the layer by layer closure has been done with the fat, surgicel, gel foam, sisal has been applied, and at last the Haddad flap has been used. And this is the post-operative DNA of the patient, which shows a good healing. And this is how we have managed the case. We have split the treatment, like treatment of the underlying cause, treatment of the headache, and the treatment of the vision. As we all know, we are familiar in correcting the underlying cause like hypothyroidism and the weight reduction. And in our cases, we have specially included tablet acetazolamide 500 milligram BD up to maximum of 4 gram with syrup KCl to prevent hypokalemia. And as usual, we have given ceftriaxone, bed rest, head elevations, stool softness, etc. And for the treatment of headaches, we have considered NSAIDs and topiramate. And for the treatment of the vision, we do the diagnostic lumbar puncture and visual field charting and temporary lumbar drain in cases of raised IIH. And when is the surgery necessary? We have operated the cases for the the listed 5 indications, which includes ascending intracranial infections. When the risk of ascending intracranial infection, we do operate, and there is a risk of pneumocephalus, we do operate, and high pressure leaks, of which 8 cases have been had high pressure leaks, and dramatic CSF leak in 1 case, which did not resolve after 7 to 10 days, we did operate, and then post-surgical trauma. This has been evident with the article which we have quoted, risk of meningitis with CSF rhinorrhea. And this is the modified Dandy's criteria, which we have followed for idiopathic intracranial hypertension cases of 8 cases. And this is the post-operative follow-up of the cases. Of all the cases we have done, we have always maintained, we have monitored the lumbar puncture, and if the symptoms persist, we then give acetazolamide tablets, and then even after the symptoms do persist, then we give steroids, and even if with steroids the symptoms of IH persist, we then go consider for optic nerve fenestation surgeries. And this is the video of the CSF pressure, which we do for the cases which we suspect, where we suspect idiopathic intracranial hypertension. This is the case which we have operated in the last June, of which the video shows the pressure being raised up to the level of 25 centimeter of water. So in this case, we have advised the patient to be on the temporary lombardine for the post-operative day 3, and then we have discharged the patient with tablet acetazolamide. So this is how we select the approach. In our cases, we had one ethmoid roof defect, which is approached via the transnasal transethmoidal approach, and the sphenoid sinus defects in 2 cases, which we have done via the transpterygoid approach. And in the frontal sinus defect, we do consider frontal recess and the posterior wall defect approach. This is how we post-operatively manage the patient with bed rest, stool softeners, and the acetazolamide, which we have quoted with the articles, and the DNE, saline nasal douching, and the post-operative lumbar puncture, which is commonly done for the cases which we suspect idiopathic intracranial hypertension. And these are my references. All the references are pertaining to the benign intracranial hypertension, and this is the article showing the preoperative management of spontaneous CSF leak with tablet acetazolamide. Thank you, sir.
So good study. And how many cases you have used head flap?
Sir?
How many cases you have used head flap out of 10?
Haddad flap has been used in almost 9 of the 10 cases, sir. And the one which we showed in the video, which we have followed for the free mucosal graft, sir.
There are many alternatives are available, no? Instead of Haddad flap. Many alternatives are available, no? Free mucosal flap, rotation flap from septum, all are available, no? Haddad flap is maybe a little more, what I feel.
Yes, sir. Yes, sir.
Okay.
Of the cases which we have done, we have observed that Haddad flap is superior to the free mucosal graft because of the vascularity and in preventing the recurrence, etc., sir. Moreover, we also prefer using the multi-layer technique or the sandwich technique, in which the fat, surgical, gel foam, everything is close in the layers.
Over and above, using Haddad flap for this sort of cases, I feel it is a little bit more. But my personal opinion. Sir,
I couldn't hear you, sir.
Sir, Saptankar, sir.
Yeah, when you are using, you used in all cases fat only, right?
Yes, sir.
As a first layer.
Yes, sir.
How do you prevent floating of the fat in these patients? All of them have high pressures and more CSF. So
Yes,
how
sir.
did you prevent?
Sir, we use that technique called bath plug technique, sir, in which the...
But you didn't mention. But you
Yes,
didn't
sir.
mention when you use
Yes.
a bath plug technique, and
Yes,
you said Surgicel,
Yes, sir.
fascia, Surgicel, and all over that Haddad.
Yes, sir.
So over all this will Haddad stick, or does
Yes,
it require a raw area?
That's what I'm asking. Local flaps
So,
would
sorry,
have
sir,
been enough.
you
Mucosal flap.
asking any raw area, sir, before placing this?
No,
Not a
in a
criticism.
multi-layer,
Yes,
if
sir.
once you put surgicel or some fasciolata or fascia, so
Yes, sir.
over the flat flap, will it stick there? Because
Yes,
it needs a raw area. Fat is okay, surgicel is okay, but once you
Yes, sir.
put some fascia type, then hadad
Yes,
in
sir.
that area will not stick.
Yes, sir.
That's okay. So what is the
Okay, sir.
aim of hadad flap?
Sir?
What is the purpose of putting a hadad flap?
Hadad flap itself has the own vascularity, sir. The posterior septal branch of sphenopalatine artery. So, in case of free mucosal graft, the vascularity won't be there, sir. So, the hadad flap can be there forever, sir, when compared to the free mucosal graft. So, in that way, the outcome of the patient will be better, sir, in hadad flap.
You have not understood the question fully. The purpose is vascularity is there. So why it is preferred is you have created wide raw area. So
Yes,
that raw area has to be mucosalized. So you
Yes,
are
sir.
doing immediate mucosalization.
Yes, sir.
Understood?
Yes, sir.
Won't
I understood,
stop
sir.
the leak. For the stopping the leak, you have put a fat plug.
Yes,
Other methods, hadad is basically to mucosalize the rest of the area. It
Sure,
is
sir.
successful because of the vascularity. Okay.
Yes, sir. I could take it, sir.
Thank you.
Okay,
Yes, sir.
good.
Thank you so much, sir.
Thank you, sir. Next candidate is serial number 38, Subbu.
Yes, sir.
Please go ahead.
Yes, sir. Can I continue, sir?
Yes,
Yeah,
sir.
please.
With the full screen. Yes.
Yeah, please start.
Okay, sir. Okay, sir. Honorable judges, reverend dignitaries, respected teachers, and my dear friends, my topic is deep neck space infections and abuse our experience. Deep neck space bacterial infections originating from the upper. Sir, one second. Screen is not sharing. Sir, is my screen visible, sir?
Yes.
Yes, it's visible. Please carry on.
Deep neck space infections are the bacterial infections originating from the upper aerodigestive tract involving the deep neck spaces. Identifying the site of the infections and understanding how it spreads is a diagnostic challenge because of its complex anatomy, far-reaching clinical implications, potential to spread quickly because it's a widespread disease, rapidly fatal, and resistant to treatment. Though it's an uncommon disease, but it's really severe, and if not treated adequately, it may lead to death. The aims of my study was to evaluate the clinical presentations and management in treated cases of deep neck infections and to analyze the interventions and sequelae of the disease. My study was a retrospective analysis of 30 treated cases of deep neck infections admitted into ENT department in a period of 1 year. Data collection involved demography, most common presentation, laboratory examinations, the etiology, treatment, and complications. Computed tomography of the neck, surgical reports, and rigid usophagoscopic finding were used for establishing which of the neck spaces were involved by the infection. Interventions, if any, and sequelae of the diseases were analyzed. Data were tabulated for descriptive and statistical analysis. My study setting was a hospital-based retrospective study among 30 treated cases presented to ENT department with deep neck space infections. My study period was for 1 year, and my study population constituted 30 treated cases of deep neck space infection. Coming to the results of my study, there were 16 male patients and 14 female patients, constituting 53% and 47% in total. The most common age group presenting in this study was from 35 years to 65 years of age, constituting 14% patients in total. Smoking was reported, betel nut chewing habits in 3 patients, and 7 patients had diabetes mellitus, 6 patients had systemic hypertension, 3 patients were hypothyroidic, and 2 patients were cardiopathic. Like I've already mentioned, the most common age presentation from 41 to 60 years of age. Coming to the etiological factors, the odontogenic conditions and tonsillar causes were the most common presentation in my study. 1 patient had tuberculosis, 5 patients had parotid or either submandibular infection, 7 patients had presented with foreign body esophagus, and 7 patients with unknown causes. This was a 45-year-old female presenting to ENT department with facial swelling, swelling of the lips, and also the edema of the oral cavity, Ludwig's angina with deep neck infection. Almost all the patients I witnessed, like 30 of them had either neck edema or the facial edema. 25 persons had fever, 10 patients had trismus, 4 had dental infections, 7 tachycardia, 3 patients went to septic shock. This was a 50-year-old male presenting to casualty and then to ENT department. This patient had presented with right parotid swelling, facial swelling, trismus, toxemia, and fever. Coming to the treatment in my study, cervical drainage was done in 5 patients. Cervical drainage with debridement of the wound was done in 4 patients. Cervical drainage and tracheostomy was done in 2 patients. Rigid esophagoscopy and drainage was done in 7 patients. All the drained patients were also treated with endovenous antibiotics. Conservative treatment with endovenous antibiotics and anti-inflammatory drugs were done in 12 patients. Coming to the bacteriological studies, there were 28 positive cultures and 2 negative cultures. Out of the positive cultures, Staphylococcus aureus was the most commonly isolated bacteria, followed by this group G streptococcus. In my study was 12.5%. Like 10 patients had ended up with complications. 3 patients had septic shock, 3 upper airway obstruction, 2 patients had pleural effusion, 1 mediastinitis, and 1 pericardial effusion. Mann-Whitney method was used to establish predisposing factors for poor prognosis of the infection in my study. P less than 0.05 was considered statistically significant, and 2 groups were compared. One group who had a better outcome, that is the non-demise group, were compared with the demise group. In my study, there were like 3 mortality patients, that is 10%. And so in my study, tachycardia, toxemia, and respiratory failure were statistically significant in the demise group. As for the analysis of the infection site, the involvement of the parapharyngeal space and association of the parapharyngeal space with the mediastinal or the pleural space, and also with the retropharyngeal intermediastinal space was statistically significant in the demise group. Among the complications, septic shock and mediastinitis was statistically significant variables in the demise group. Coming to the discussion of my study, as I've already discussed, the most common age group was that affected varied from 30 to 65 years, similar to the findings in the literature. The disease was more common in males. Smoking and betel nut chewing were the most commonly associated social habits found in my study. Most commonly associated systemic disease was diabetes mellitus. The most common clinical presentations being edema, odynophagia, fever, and trismus. Tachycardia, toxemia, respiratory failure were the most commonly associated prognosis factor in my study. Odontogenic and tonsillar causes being the most common presentation. Staphylococcus aureus was the most commonly isolated bacteria. The most commonly involved area being the submandibular, parotid, and the parapharyngeal spaces. CT has evidently helped improve the diagnosis of the deep neck space infection. As I've already discussed, my complication rate was 12.5% with 10% presenting with, and mortality rate was 10% in my series, that is 3 out of 30 patients. Our study enabled us to conclude that odontogenic and tonsillar causes are the most common causes. Special attention should be given to the airway management, especially to the patients presenting with upper airway obstruction, particularly in Ludwig's angina, where the patients come with edema of the oral floor. And surgical drainage is the standard treatment of deep neck infection. Computed tomography is the investigation of choice for the diagnosis. Deep neck infections have high morbidity and mortality rates, particularly when associated with septic shock and mediastinitis. These are the references I had referred to. Lastly, I would like to end my presentation with the shloka from Bhagavad Gita. उद्यमेन हि सिद्ध्यन्ति कार्याणि मनोरथैः न हि सुप्तस्य सिंहस्य प्रविशन्ति मुखे मृगाः, which means there is no substitute for hard work, there is no substitute for effort. You can achieve your task and your goals only by putting in your efforts and your hard work, not merely by dreaming. Thank you. Thank you for this opportunity.
Out of your study, your odontogenic infections are very, very common and high.
Yes, sir.
Odontogenic, right?
Yes, sir. Yes.
Number two, did you see any sort of chronic problems like TB spine or something, cervical spine in your retropharyngeal abscesses?
Yes, sir. Sir, I had one tuberculosis patient, sir. That patient had actually that patient had presented with cervical lymphadenopathy, and she was admitted in our ward. Because of the cervical lymphadenopathy, we had done FNSC on her, and also because the patient has had chronic cough, so we had sent for CV-NAT and all, and then she had the CV-NAT test was positive, sir. So we had one tuberculosis test.
Did you
chronic?
treat the patient?
I can't say it chronic, sir, but yes, sir.
Did you treat the patient with anti-tuberculosis treatment as a conservative basis,
Yes,
or
sir.
something else?
Yes, sir. No, sir. ATT was started, sir. ATT was started. And then later we lost that patient in follow-up, sir. Like after the patient got discharged from the ward, we lost that patient in the follow-up, but we had started ATT, sir.
Okay. So you even told some sort of patients demised or something, like you put two classifications.
Yes, sir. Yes, sir. Yes, sir. Like
That's all
out of
because
40 patients.
That's all because of extensive disease into mediastinitis and other things.
Sir, I had one mediastinitis patient, sir. The patient was admitted in our ICU for almost 1 month. We had a bedside for that patient, sir.
Okay.
One case of mediastinitis.
Right. You had 3 cases of parotid abscess, 2 or 3 cases of parotid abscess, right?
Yes, sir. Yes, sir.
So what they were treated surgically, I suppose.
Yes, like not all of them were treated surgically, sir.
Correct.
Some of them
So
were treated with intravenous.
listen to my question. Once what type of surgery is done for the parotid abscess? How does it differ from other types of abscesses? Have you seen any parotid
yes,
abscess drained?
Sorry, and out of these 30 patients,
salient
out of these
taking points are needed?
Out of these 30 patients, like
Okay,
to be very honest,
my
in
question,
my study,
Subbu, my question is very specific. Is there any difference in the surgical management? How do you drain the parotid abscess as compared to other abscesses? Simple question. To prevent injury to the facial nerve, what do you do?
Sir,
Okay.
I would like to pass it, sir.
You will learn about it. The second
Yes,
question is,
yes, sir.
28 people had culture positive, 2 patients
Yes, sir.
did not have culture positivity.
Yes,
So
sir. Yes,
you
sir.
mean to say that there were no bacteria in those people?
Sir, what
Did
the
you
report
do
was,
anaerobic
there are
studies
few
also?
pus cells and no bacterial cells. That was the
No
report.
bacteria?
No bacterial cells, few pus cells present, no bacterial cells present.
Agreed. I understood. So when you find, what type of culture you have sent?
Sir, pus culture, sir.
Pus culture only. What type of bacteria you are sending? Okay, probably you are not aware. Do you know about anaerobic cultures?
Yes, sir.
Did
Have
you
you
focus on
sent?
it?
Did you send? So in
No,
any
sir.
apps, you must send for anaerobic culture in a different method to transport that. Okay? Aerobic cultures negativity doesn't rule out anaerobic bacteria. So in those two patients, you must think of, instead of zero bacteria, it may be anaerobics. And 3 patients had breathing difficulty.
Yes,
You
sir.
said tracheostomy in 2 people.
Yes, sir.
So that tracheostomy was done to alleviate the breathing problem or to facilitate general anesthesia.
But the first case had come with Ludwig's angina, actually. That was a lady, sir. And the patient had severe swelling of the oral cavity, and the patient was in a very bad condition. So, what we were planning for incision and drainage actually initially, but since the airway was fully compromised, sir. So we had asked help from the anesthesia team, and anesthesia team told that airway, intubating would be really difficult in this case because the swelling is too much, and airway is like fully compromised. That's why we went for tracheostomy in that patient.
So in other words, because of trismus, say a patient in trismus, you always do tracheostomy, or is there any other method of intubation?
The submental, there is another intubation, submental intubation.
Yes, submental also it will go through oral cavity finally. So it will be post nasal intubation with the fiber optic endoscope.
Yes.
If there is no laryngeal edema. Okay.
Yes. Yes.
Right. So I have finished, sir. Any more questions, Ramakrishna sir?
Sir, no, sir.
Thank you, sir. Thank you, Subbu.
Thank you for the questions.
Thank you, all the judges, for your time and patience, sir. This our session is ending now.
Ending or ended?
Yeah, already. I'm confirming, sir. That's why I'm just given a pause. Sriharsha, anyone is there?
What about?
Sriharsha?
No, sir. Nobody is there.
Okay,
Yeah. Thank you so much, sir. Thank you,
you.
Sriharsha, and
Thank you, Ramesh, and everybody who has given this opportunity. We will meet during our conference.
Yes, sir. Thank you, sir. Thank you, sir.
All the best.
Sure. Thank you very
Yes, sir.
much. Good
Yes, sir.
day and have a nice time.
Okay, sir. Thank you, sir.
Right. Bye-bye.
Bye.
See you.
Thank you, all the coordinators, for supporting me. Sriharsha, you can end the session.